Good morning, ladies and gentlemen, and dear colleagues. I'm on behalf of NTUH to welcome you to the 10-year Lean Surgical Symposium and Joint Surgical Conference with MGH and NTUH. It is our honor to have you all and our colleagues from the MGH today. And let's welcome Professor Chen Huang, Chairman of NTUH Surgery Department.
Good morning, dear colleagues. It's my pleasure to welcome you all to join today's 10-year Lean Symposium. I think we are very honored to have colleagues from Massachusetts General Hospital to join us this symposium this year. Probably you know that since last year, we visited Massachusetts General Hospital, visited the chair, Dr. Littlemore, and also several colleagues, including Dr. Tanabe and Dr. David Zhang. We had a wonderful meeting there, and afterwards, I think it's almost 1 year that we have Dr. Tanabe and Dr. David Zhang coming to Taiwan to have a meeting with us. It's already 1 year, but this year, I would like to say maybe, should I say thanks for the COVID-19 or not? But anyway, that's a chance to make us to have this chance to have a virtual meeting with our Massachusetts General Hospital colleagues. As you know, Dr. Littlemore is also the editor-in-chief of Annals of Surgery. So I think that is recognized as the top journal in the surgical field. So for us, this is a great chance to learn a lot from them. I would like to say some words about Professor Tianyou Lin. Professor Tianyou Lin was actually the second chair of Department of Surgery at National Taiwan University Hospital. And he was probably the first international known surgeon from Taiwan. I think he is also the first one to publish papers in Annals of Surgery in this department. And to honor him, we have this symposium started many years ago annually. And now it's really a pleasure to have this opportunity to have colleagues from Massachusetts General Hospital to join us. Now, I would like to invite Professor Littlemore, the chair of Department of Surgery at Massachusetts General Hospital, to say some words for us.
Well, thank you, Dr. Wong. I assume everyone can hear me.
Hear you clearly.
Good. So first of all, it's a tremendous honor for me to be able to speak on behalf of our faculty at the Department of Surgery at the Massachusetts General Hospital and Harvard Hospital. It seems like decades ago when you and your colleagues visited Boston and we had such a nice conversation about how we had hoped that this relationship would develop into something that would be long lasting. We all hope and pray that what we've all experienced in your countries and our countries over the last 12 months will be moved beyond us, and that the opportunities for us to collaborate and maybe next year to do this a very, very nice symposium in person is an opportunity. In the meantime, doing it via Zoom is great. Those of us in Boston are working at the end of our day, and I know you guys are at the beginning of your day. It's really an honor for me to know that the dean of your National Taiwan University College of Medicine, Dr. Ni, is with us. You have the superintendent of your hospital, Dr. Wu, and the past president of the university, Dr. Yang. It's a real group of superstars that are here. So we at the MGH are honored to be here. We have a great group of faculty representing us today. I want to give a tremendous shout out and thank you to David Chang, for all that he's done to nurture this relationship through the years, working with Ken Tanabe. I know these conversations and the relationship has been going on for a long time, and I hope it gets stronger. The rest of us, including some young faculty, Motaz Kadan, a surgical oncologist, Heidi Ye, a liver transplant specialist, and Jeff Yang, who is a rising star in thoracic surgery, are very pleased to be part of this. We also have Jim Cusack, one of our real leaders in surgical oncology, here to talk about a topic where he has really been one of the leaders in the forefront, and that's HIPEC and cytoreduction surgery for colon cancer. So it's a great program. I promise to stay on as long as I can stay awake, but I know I'll be represented well by Doctors Tanabe and Dr. Chang. And I want to give one shout out to one of our great surgical chief residents, Z Fong. Z is an important colleague and friend and really a rising superstar in surgical oncology. And he's here to help us make sure we make this a very special evening for all of you. So thank you so much for this invitation. I look forward to hearing your talks, and I will happy to turn it back to you, Professor Wang.
Okay, thank you, Dr. Lillemore, and also thanks all the effort done by Dr. Tanabe and Dr. David Chang to make this symposium come true. So now we have some welcome remarks from our Dean, Yanxian Ni.
Good morning to my colleagues in Taiwan, and good evening to my colleagues in the United States. I'm a Dean of the National Taiwan University College of Medicine, Dr. Yanxian Ni. Professor Huang, Professor Lillemore, and Professor Tanabe, it's really great to see you here. I'm very, very honored to invite you to the symposium and to do the opening remarks. Because of the last year's COVID-19 pandemic, many international conference has changed its format. So today we have a hybrid conference here. The Taiwanese colleagues, we are getting together in the auditorium, and to see you all of you overseas in the United States and France through the monitor online. Many of you may scatter everywhere, maybe in your own room, to join this symposium. Today, we are going to have the Lin Tianyou Symposium, Surgical Symposium. This symposium is initially in memory of Professor Lin Tianyou, who is the founder of Taiwan surgery. This year, we also have a special memorial service for Professor Chen Kaimo, who passed away 1 year ago. Professor Chen is the past chairman of the surgical department of National Taiwan University. He also contributed a lot to Taiwan's surgery. This year's symposium, including many important topics, and we invited many speakers from Taiwan, United States, and also from France. I believe that this symposium is going to achieve a lot of the very fruitful discussion. And after this symposium, we will have we can strengthen our collaboration in the future. Finally, I believe that we will finally weather this storm of COVID-19 pandemics, and hope that next year we can have a real face-to-face meeting, and hope all of you can come to Taiwan. Thank you so much, and see you soon.
Now we would like to start the first talk of today, or in the morning or in the evening. And the first talk will be delivered by Professor Mingxian Wu. Because he has another lecture in another meeting, so he won't be able to join us this morning, but he has pre-recorded his lecture and to talk us about the Helicobacter and gastric cancer prevention. Professor Wu right now is the director of the National Taiwan University Hospital, and he was well known because of his study in Helicobacter and gastric cancer prevention. And he did many studies and published in Lancet and Lancet Oncology. And his studies was used to form the consensus of gastric cancer prevention in a international base. So today we are very honored to have the first talk by Professor Mingxian Wu.
The chairman, Professor Huang Junsheng, dear colleagues, and our good friend at Massachusetts General Hospital, good morning. Today, I'm greatly honored to share National Taiwan University Hospital experience on screening and the eradication of Helicobacter pylori for gastric cancer prevention. In my talk, I will include 4 questions. The first question is why to prevent gastric cancer. The second is what to prevent gastric cancer. The third is how to prevent gastric cancer. Finally is when and where to implement the prevention strategy. The first question is why to prevent gastric cancer. As the famous Albert Einstein said, intellectuals solve the problem and the genius prevent them. So of course, prevention is better than cure, especially in malignant disease. We have several clinical challenges of gastric cancer. Despite declining incidence in Western countries, gastric cancer remains common and fatal disease in some specific geographic regions, such as East Asia. Early detection, especially early gastric cancer, has a very good prognosis. However, it is difficult for early detection, and for advanced gastric cancer, recurrence is quite common. For advanced gastric cancer, we usually treat patients aggressively. However, the side effect is also serious. Gastric cancer is potentially preventable, but specific at-risk populations remain ill-defined. These are clinical challenges of gastric cancer, and to improve gastric cancer outcome, we may need a different strategy. Gastric carcinogenesis is multifactorial and a multi-stage process. Different risk factors can lead to chronic gastritis and gradually progress to atrophic gastritis and intestinal metaplasia, and finally to gastric adenocarcinoma. We have 3 strategies for improving outcome of gastric cancer. When patient has symptoms and are diagnosed in advanced stage, we can develop effective treatment modality such as surgery, chemotherapy, and radiation therapy. And the way patients are asymptomatic, we can have implemented effective screening program and apply normal diagnostic tool for early detection of gastric cancer. This strategy is usually adopted by Korea and Japan. Finally, we can identify risk factor, and if this risk factor is modifiable, we can have primary prevention. Primary prevention, of course, is better than secondary prevention and tertiary prevention. The second question is what to prevent gastric cancer. In terms of gastric carcinogenesis, both hereditary and environmental factor are important. This is the famous pedigree of Napoleon. Hereditary factor cannot be modified. We can only modify environmental factor. For example, Helicobacter pylori infection to prevent gastric cancer. Helicobacter pylori was discovered by Barry Marshall and Robin Warren in year 1983. It is estimated about 89% of non-cardiac cancer can be attributed to Helicobacter pylori infection. Therefore, eradication of Helicobacter pylori can prevent gastric cancer more than 50%. We have carried a systemic review and meta-analysis, and our results show Helicobacter pylori eradication can reduce 50% of risk. Different gastric cancer baseline risk can have different preventive effect. The third question is how to prevent gastric cancer. This is year 1995 when I first met Professor Barry Marshall, and this is 10 years later. In year 2005, Barry Marshall and Robin Warren won Nobel Prize because they discovered Helicobacter pylori, which is related to chronic gastritis, peptic ulcer, and gastric cancer. After Nobel Prize is awarded to Helicobacter pylori discovery, there remain two important issues unanswered. The first is what mechanism lead to disease in certain subjects. The second is how to translate our knowledge into clinical practice, such as prevention of gastric cancer. Therefore, we established Helicobacter pylori study group in National Taiwan University Hospital since year 2005. This includes clinical medicine, pharmacology, focus on signal transduction, and proteomic focus on developing normal biomarker, and finally is biochemistry to study the mechanism. The severity of gastritis can determine the different outcome of Helicobacter pylori infection, and the severity of gastritis is decided by Helicobacter pylori virulence type, and the environmental cofactors, and the genetic susceptibility of host. We have found several virulence factors of Helicobacter pylori from National Taiwan University Hospital. Especially we have found gastric cancer strain is more virulent than gastritis and the other strain. And Some definitely risk factors are identified by our group, including AHPC heat shock protein. And we also identify several important host factors in Taiwan. This factor can determine the different outcome after Helicobacter pylori infection. Eradication of Helicobacter pylori can not only cure fatty ulcer but can prevent gastroduodenal disease occurrence, including gastric adenocarcinoma and gastric lymphoma. In terms of eradication rate, two factors are very important. The first is antibody resistance, then the second is patient's compliance. It has been reported Helicobacter pylori infection can decline dramatically if the patient has antibody resistance. In Asia Pacific region, the primary antibody resistance for Helicobacter pylori is very high. In this systemic review and the meta-analysis performed by our group has shown metronidazole resistance is as high as 45%, clarithromycin is 21%, levofloxacin is 27%. To find effective regimen for primary prevention of gastric cancer, we form a Taiwan gastrointestinal disease and Helicobacter pylori clinical trial consortium. This includes different hospitals from different geographic regions: Northern Taiwan, Southern Taiwan, Central Taiwan, and even Eastern Taiwan. We have isolated different Helicobacter pylori strains from different geographic region of Taiwan, and has found the antibiotic resistance of clarithromycin is 10 to 15%, metronidazole is 20 to 40%, and the levofloxacin is 10 to 50%. In general, as compared to Western countries, the primary antibiotic resistance rate of Taiwan is lower than Western countries. Then we perform a series of clinical trials to investigate whether the primary the first line regimen, second line regimen, and the rescue therapy for Helicobacter pylori is optimal in Taiwan. We has compared triple therapy, 4 drugs combined, including concomitant bismuth quadruple therapy, with different duration, including 10 days to 14 days. And even we have carried rescue therapy for Helicobacter pylori infection based on genotypical and empirical drug history. We have published several important clinical trial results in prestigious journals such as Lancet, the Gut, and the Gastroenterology. And the result from this clinical trial has modified the treatment guideline for Helicobacter pylori infection, including duration of treatment and the different combination of regimen. Based on this clinical trial result, we have written treatment guideline to teach how we can eradicate Helicobacter pylori on American Gastroenterology Association official journal. Finally, with this effective regimen, we want to carry primary prevention of gastric cancer in real world. We select Manchu Island as the target population because Manchu Island is a high-risk area for helicobacter pylori infection and gastric cancer. This program is initiated by Professor Zhao Tang Lin and Dr. Liu Zhengying, who is Director of Public Health Bureau of Manchu government. Manchu government has a threefold gastric cancer incidence and the mortality rate than Taiwan. And we initiate an organized screening program which has a definite target population, and we invite this definitely target population for screening. Then we have a timely assess, quality assurance, and the tracking of outcome. This flowchart show the 3 steps for organized screening program. The first step is invitation, and then this participant receive screening test, and if the screening test is positive, then referral for treatment or endoscopic examination. This mass eradication program is initiated since year 2004 by urea breast test to screen Helicobacter pylori status, and if the patient had Helicobacter pylori infection, then was referred for endoscopy and treatment. And then we had the second round at year 2008 and the third round at in year 2012. The first round of chemo prevention is to have proof of concept and the simulation of long-term outcome. This simulation shows screening of Helicobacter pylori and eradication is cost-effective for prevention of gastric cancer as compared to pepsinogen screening. The second round of chemo prevention is from year 2008 to year 2009. The M are short-term effectiveness and the reinfection rate. This slide shows Helicobacter pylori prevention declined dramatically from 64% to 15%, and the reinfection rate is estimated to be as low as 1%. The third round of chemo prevention is year 2012. The M are impact on antibody resistance and the efficacy of new treatment. As compared to result in Taiwan, the antibody resistance in Manchu Island does not have dramatic change. So the impact of mass eradication on drug resistance is low. And in year 2006, we can see a dramatic decline of gastric cancer incidence at Manchu Island. And this strategy of mass eradication has been adopted by World Health Organization as the strategy for prevention gastric cancer. This is the final result of our mass eradication of Helicobacter pylori. As shown in this slide, it can reduce gastric cancer incidence to more than 60% after 12 years follow-up. In addition to Manchu Island, which is located outside Taiwan, we select Changhua County as another place for gastric cancer prevention. In this screening program, especially not only has a high risk of gastric cancer, and also colorectal cancer. We use Helicobacter pylori stool antigen instead of urea blood test because we want to combine with fecal immunohistochemical test for colorectal cancer screening. So we can use so-called two-in-one. We can screen Helicobacter pylori infection and occur blood for gastric cancer and colorectal cancer prevention. This is so-called two-in-one. We invite population age 50 to 69% for fit and randomized into two groups. The first group is as common colorectal cancer screening program, only give them a fit test, but another group is combined with stool antigen test. The patient is divided into two groups. The first group is only fit test, and the second group you can use the same stool regimen, the same stool samples for Helicobacter pylori stool antigen and the immunohistochemical test for occur blood. And this is the flow chart. We enrolled more than 20,000 people to this program. And this is the baseline result. And when we provide two-in-one, especially Helicobacter pylori stool antigen test is added into the fit, the normal screening subjects and those who carry the common risk factor will be invited to uptake the screening service, and we can find more colorectal cancer. And use this approach, population participation is increased, and sources needed are minimized, and the benefit from screening is augmented. So this two-in-one program, the baseline result of this two-in-one program are very encouraging. So in summary, prevention is better than treatment for gastric cancer from the public health viewpoint. Eradication of Helicobacter pylori may lead to reduction of gastric cancer. Gastric cancer can be prevented by 50% in adults with short-course antibiotic treatment. Finally, screen and treat Helicobacter pylori infection can be integrated with other healthcare issues. Because we have much experience in screening and the eradication of Helicobacter pylori and published a series of papers in this field, we host the 10th ACE Pacific Topic Conference, and the main theme of this conference is screening and the eradication of Helicobacter pylori for gastric cancer preventions in year 2019. And we invite many famous international scholars in screening and prevention of gastric cancer and in the field of Helicobacter pylori. Finally, we reach a consensus for screening and eradication of Helicobacter pylori for gastric cancer prevention. In this consensus statement, we have reached 26 statements, and this consensus report has been published in December issue of 2020 in GUT, and become the cover story of the 6 years anniversary of GUT. I want to acknowledge my thanks to National Excellence of Clinical Trial Center, National Taiwan University Hospital, and the Ministry of Science and Technology, and the Taiwan Clinical Trial Consortium for providing the budget support. And I want to thank you all participating patients, colleagues.
We'd like to thank Dr. Wu for preparing this excellent talk. We still have several minutes, and we can welcome some questions, probably especially from the colleagues in Massachusetts General Hospital. Dr. Wu cannot be here, but he has his colleague, Dr. Ziming Liu, to answer the questions if you have any. Is there any questions from the audience and also from our online colleagues? So, Dr. Liu, may I ask that it seems that you have a very successful program. So, are you going to have this program to be implemented in all the area in Taiwan?
Yes, thank you very much for this important question. Because in addition to the effectiveness, we also have to consider the cost effectiveness. Therefore, for eradication of H. pylori for gastric cancer prevention, we need to focus on high-risk subjects if our resources is limited. Therefore, currently, I think the first stage we will focus on those aged greater than 50, and in some counties that have instance of gastric cancer higher than 15 to 20 per 100,000 per year, and in maybe in the second stage, we can reduce the age limit maybe to younger adults. But I think we are also collecting more data, especially the data for long-term safety concerns. And I think maybe the 3 or 5 years later, we can have more data on this issue.
Thank you. I think probably Taiwan is not the highest, is not the country of highest instance of gastric cancer in the world not right now. Probably Korea or Japan, they still have higher instance. So are they aware of this program, and do you think they will try to do that in their country?
Yes, this is also an important issue because in Japan, they have already started to treat H. pylori infection for any patients with endoscopically documented chronic gastritis, and the fee are covered by their health insurance system, and according to their recent report, the participation rate is high, and in Korea, their government support for the secondary prevention that in terms endoscopic screening, but currently they are changing their policy to screen H. pylori and eradicate H. pylori.
Thank you very much. And
Dr.
now,
Wang, Dr.
yes.
Wang, Dr. Fang has a question.
Hi, Dr. Huang.
Hi. Yes,
Hi,
please.
first of all, I think thanks so much for having all of us here with you. I think I speak on behalf of all my colleagues that it's really an honor to be here with everyone in this symposium. I have a quick question for Dr. Liu. Is there any data on if there's any difference between the prevalence of Helicobacter pylori between Asian and Western countries? Because it sounds like there might be potential implications on the surveillance strategies if it's different between the countries.
Yes, this is also an important factor that need to be considered. According to our most recent review, the prevalence of H. pylori was around 42% globally, but there are regional variations. In Asia, the prevalence of H. pylori was around 45% in Asia, but the prevalence is much lower in Europe and in North America. And in America, the prevalence of H. pylori is currently around 10%, but there are ethnic differences for Asia people or those come from South America. The prevalence was 20 to 30% in America.
So I guess your point is that in American-born Asians, the incidence rate is still higher than in the typical American. And does that still make it cost-effective to be screening for Helicobacter pylori the same way you're doing it in Taiwan?
Yes, I think for migrants from Asia, their risk for gastric cancer remains high, and that probably attributed to their genetic factor and dietary factors. And therefore, I think even in USA, screening and eradication of H. pylori should be implemented in those with high risk population.
That's very fascinating. Thank you again so much for having all of us here with you today.
So thank you. Now I would like to proceed to the next talk. It would be my honor to introduce our next speaker, Professor Banzi Yang. Professor Yang is currently the chair professor of National Taiwan University National Taiwan University College of Medicine. He was actually the former president of National Taiwan University, and he was elected as a member of Academic Seneca in 2006. That is considered the most prestigious academic position in Taiwan. And he also elected as a World Academic Science in 2008 and the National Academy of Inventors of USA in 2015, and the International Association for the Study of Lung Cancer, the 2020 Joseph Cullen Prevention Early Detection Distinguished Service Award because of his contributions in leading the translational research in precision cancer medicine and the implementation of lung cancer screening in never smoker. And actually that's is the topic for Professor Yang to give his lecture today and to show us how do we identify some important message in the lung cancer in never smoker and find a strategy aiming for cure. Let's welcome Professor Yang.
Thank you, Professor Fang, for your kind introduction. Good evening, colleagues in Massachusetts General Hospital, and good morning, everyone. It's really my great pleasure and honor to speak in the Professor Tian-Yu Lin's Surgical Symposium and also the Massachusetts General Hospital NTUH Joint Surgical Conference. My talk today try to focus on lung cancer in non-smoker. I report to you the probably. Is that okay now? Sorry about the. Sorry about the high-tech problem. Okay. So this is my content of the talk. I try to convince to you that the incidence of lung cancer in non-smoker is increasing globally, especially in Eastern Asia. And then I report to you the precision management of lung cancer and impact on the survivor. And what is our strategy aiming for cure lung cancer? And then the early detection program by local CT screening in non-smoker. And then I will report to you our cancer moonshot program, try to identify the etiology on our strategy for prevention. If I have time, I will then report to you our recent works in the precision smart targeting. So as you can see here, the lung cancer, especially in men, the incidence is declining in the world. However, in female, the lung cancer incidence is still going up. And this trend is more striking in Eastern Asia. We all know that smoking is the cause of lung cancer, the major cause of lung cancer. In the States and in Europe, you can see very high incidence of lung cancer in smoker. However, in Eastern Asia, you can see that lung cancer in non-smoker, especially in women, is very prevalent. So this is a big gap, especially in female, that most of the lung cancer in female are non-smoker. I cannot move my slides, sorry. We started Stop Smoking campaign in 1995. At that time, in male adult, the smoking rate is about 55%, and the smoking rate declined to 27 now. The female smoking rate is usually kept around 3 to 5%. If we think that the smoking is the cause of lung cancer, we start anti-smoking campaign. Actually, it's very, very successful. We should observe the decline of lung cancer. On the contrary, you can see that the lung cancer, especially adenocarcinoma, is keep on rising, both in men and in women. This is the fact that lung cancer in Taiwan, non-smoker is more than smoker. Lung cancer is the #1 cause of cancer mortality in female. Adenocarcinoma accounts for 70% and non-smoker 93%. So if we consider what are the contributions of smoking in male and female, in men it's only about 27% and female 4%. This is a very striking result. Actually, if we try to estimate the correlation of air pollution and incidence of lung cancer, you can see this is a positive correlation in the area or in Taiwan that with higher air pollution, the incidence of lung cancer is higher. Next slide, please. I cannot control my slides. Okay. So our colleagues in National Health Research Institute, they try to explore the relationship between the air pollution and lung cancer incidence in Taiwan. You can see in these slides that no matter in smoker or in non-smoker, men or women, those who are exposed to higher PM 2.5 exposure, the incidence of lung cancer is increased, but the relative risk is not high. It's 1.22 to about 1.78, so it's not high. In 2018, I reported the story of never-smoker lung cancer in Taiwan. At that time, a professor in British Columbia, she also presented a very interesting story. She tried to correlate the PM2.5 and risk of lung cancer in never-smoker. She found that actually those who in never-smoker who had lung cancer, they opposed to the higher PM2.5 exposure. Among those never-smoker with lung cancer and high PM2.5 exposure, very interestingly, she found that 74% are female, and those are coming from Eastern Asia. This is the mutation landscape of lung cancer in Eastern Asia. It's quite different from Caucasian. You can see here in Caucasian, the most dominant driver mutation for lung adenocarcinoma is KRAS, followed by EGFR. However, in Eastern Asian, the most dominant driver mutation is EGFR mutation. And it accounts for nearly 50% of the driver mutation in adenocarcinoma, and KRAS mutation is only 8 to 10%. So the challenge of lung cancer in Taiwan, never-smoker predominant, adenocarcinoma predominant 70%, and female 40% lung cancer, 40% in all lung cancer population. Now adenocarcinoma, the EGFR mutation, nearly more than half of them. However, around 70% of the lung cancer are diagnosed in late stage. How to prevent? PM2.5 is an important factors. Can we develop a strategy for lung cancer screening? And can we identify the biomarker for guiding the treatment? I still have problem. Control my slides. Okay. So this is the precision management of the advanced stage non-small cell lung cancer. You can see the guideline here. You have to check the histology, squamous, non-squamous, and then followed by the gene testing, the driver mutation, and then start with target therapy. If those without driver mutation, you should check for the PD-L1 expression, and you should consider whether the patient is suitable for immunotherapy or combination immunotherapy. Because of the implementation of precision therapy, you can see the outcome of the patient dramatically improve. A typical case here, a stage 4 patient, the EGFR mutant. You can see here the 5 advanced stage bilateral diffuse metastasis. Usually, this kind of patient can survive only 3 to 6 months. Actually, the patient survived more than 5 years because he is a EGFR mutant. Although he's a never smoker, he's a EGFR mutant, and he responds very well to target therapy. And so that's why we can see he can survive more than 5 years. However, you want to eliminate lung cancer, what we can do? Because when a symptom occur or when a tumor detected, actually most of the patient in the day stage, the chance to cure the patient is much lower because the CT scan can only detect the tumor around 0.5 centimeter to 1 centimeter in diameter. Usually, there'll be around 10 to the 9 cells in the body. If the cancer cannot detect by CT scan, the still has, for example, if the tumor only around 10 to the 8 of the cells is less than 1 centimeter in diameter, it can miss by CT scan. So the lesion cannot detect by our conventional technology, CT scan or MR imaging, does not mean that you didn't have cancer. So the early detection before the patient symptomatic and patient still curable is very important. And also the risk assessment is also important. Some of the patients, they are more susceptible to the development of lung cancer because of the genetic susceptibility. This is the Lung Ambition Alliance. The Lung Ambition Alliance from the International Association Study of Lung Cancer who tried to reduce the lung cancer mortality and double the 5-year survival by 2025. We are one of the members of the Lung Ambition. Actually, the enhanced quality of care is important. It is true, and also deliver the innovative medicine. However, the most important part would be screening and diagnosis early. This is the most important to improve the survival of lung cancer. This is our result of lung cancer 5-year survival before we implemented gene testing and precision cancer therapy. You can see here the 5-year survival is about the average, the world average about 15 to 16%, but now the 5-year survival improved to 53.4%. This is a very striking, impressive result. However, you look at the improvement of 5-year survival. Which factor would be the most important? The precision therapy? No. You can see here, in the stage 4 patient, the survival improved from around 6 to 7% to around 16%. So this is a very modest improvement. The most important, the improvement of survival is because of the stage shifting. Before, most of the patients are diagnosed in stage 3 and stage 4 disease. However, if you switch the stage distribution to most of the patients diagnosed in stage 1 or stage 2, you can improve the survival because in stage 1 and stage 2 patient, the 5-year survival is much, much better than the stage 4 and stage 3 patient. So this is our result. You can see here, the stage 0 to stage 1 patient now increased to 61%. This can explain because of the increase of early stage patient, our 5-year survival significantly improved. The size of the tumor is very important. You can resect the tumor less than 1 centimeter in diameter. You have more than 95% of chance you can cure the patient. If you resect the tumor larger than 2 centimeters in diameter, then the chance of 5-year survival decline to less than 80%. This is the typical patient. The tumor cannot be seen by the conventional X-ray. However, you can see here, the low CT detect a 7-millimeter tumor and resected, the patient is cured. This is a stage 1A adenocarcinoma. If you look at the progression of lung adenocarcinoma, most of the lung adenocarcinoma progress very slowly. This is a typical patient, a tumor in the right lobe progress 10 years, still around less than 1 centimeter in diameter, and resected because the growing tumor, and the tumor confirmed to have mucinous adenocarcinoma. But sometimes the diagnosis is very, very difficult. This is another patient, slow progression. A tumor cannot be seen in 2014. The CT scan just shows some abnormality in the border of the left heart. However, during the follow-up, it seems that the tumor did not grow. In 2016, the tumor seems grow to around 7 to 8 millimeter in diameter. At that time, the physicians think that the patient still can wait. However, after 1.5 years, the tumor grew to 1.5 centimeter in diameter and developed proceeding from the curable, resectable to unresectable. So it's very, very difficult to diagnose the patient early to make the decision to operate such a tiny tumor. So our colleagues, our surgical colleagues is very, very talented and very experienced to develop the new technology of tubular vast surgery, endoscopic surgery. They converted surgical resection of early stage lung cancer became a very easy method. They can perform, they are aiming to develop this technology for outpatient surgery in eventually. So now we operate around 1,000 early stage lung cancer using this kind of image guided tubular uniportal thoracoscopic surgery. But we cannot scan every patient by low-dose CT because of the radiation exposure and the cost. We need to identify the high-risk population. This population can benefit from low-dose CT screening. We previously identified many biomarkers, some genetic susceptibility in never-smoker lung cancer. We hope that we use this biomarker to identify the high-risk subject that can benefit from low-dose CT screening. We also identify the familial genes that are associated with familial lung cancer. It is very interesting and very important that in never-smoker lung cancer, family clustering is very important factor. You can see here this family blue color, all of them had YAG1 mutation. Father, mother, they all had lung cancer, and 4 daughters, all never smoker, they have lung cancer. The only son is a smoker, he did not develop lung cancer yet. So this is the CT scan image, mother and 4 daughters confirmed to have lung adenocarcinoma. All of them never smoker. So familial clustering is very important. So we conducted low-dose CT screening trial. The subject are all never smoker or light smoker with family history of lung cancer or passive smoking, chronic lung disease, or high cooking index, or cooking without using ventilation. They have negative chest X-ray and then receive low-dose CT screening. We also take the blood urine for biomarkers and questionnaires. Totally, we recruit 12,011 subjects, and half of them have family history of lung cancer. We follow the standard protocol to follow the patient. This is the first-round lung cancer detection rate. You can see here, the first-round lung cancer detection rate is 2.6%. It's higher than national lung screening trial in the United States, focused on heavy smoker. The lung cancer detection rate in NAST is 1.1%. In Nelson is 0.9%. And the invasive procedure is 3.4%. The low-dose CT scan positive is 17.4%. We define positive is ground glass opacity larger than 5 millimeter, and the solid or power-solid region larger than 6 millimeter. Most importantly, lung cancer confirmed in low-dose CT screening, 96.5% are stage 0 to 1. That means that 96.5% of them screened by this low-dose CT scanning can be cured by surgery. The prevalence of lung cancer with family history is 3.2%. Without family history is 2.0%. This is a very important message. Family history, especially the first-degree lung cancer family history, is very important. It's a risk of lung cancer. Increase from 0, no family members is 2.0%, with 1 member increase to 3.1%, 2 members, 4%, 3 members, 6.7%. If 4 members with first degree, with 4 members had lung cancer family history, then increased to 9.1%. So it seems this is dose response in the risk of lung cancer. We also perform the SNP studies using the SNPs we identify to for the risk assessment. And why we do that? We want to develop a risk prediction model based on the family history, genetic accessibility, and some environmental factors. We try to develop a risk score to predict the lung cancer risk in never smoker. This is our preliminary data. You can see here the risk score include the environmental factors, family history, and how many SNPs the subject has. And then you can develop a risk score. Those subjects with higher risk score, the relative risk of lung cancer in never smoker is increased. So we hope that we can, based on this risk score prediction, to identify the high risk population that can benefit from low density screening. Finally, I will talk about the cancer moonshot program. We try to identify the etiology and the mechanism why never smoker develop lung cancer. As you know that the lung cancer in Caucasian and Eastern Asian, they are quite different. We have relatively high EGFR mutation. As the Caucasian is KRAS mutation, we have high never smoker with lung cancer, relatively early onset. So we perform a proteogenomic study, compare the paired tumor with normal, do the whole exome sequencing, RNA-seq proteomic, phosphoproteome. We try to identify the etiology and mechanism for never smoker lung adenocarcinoma. We do identify some different landscape of the genetic alterations. And some of the new druggable target has been identified in this subset. And most importantly, we found that in those early onset never smoker lung cancer, some endogenous factors, genetic factors play a very important role. Alphabet signatures is one of them. Alphabet gene's signature is controlling the gene editing. And somewhat in this early onset lung cancer, they tend to have more alphabet gene signature. So that can explain why they have early onset lung cancer. And we also identify the genetic environment, in addition to the genetic factors, some environmental factors play a very important role. And especially in Eastern Asian population, in air pollution, one of the components, nitropolycyclic aromatic hydrocarbon, is very important. Another one is the food preservative, nitrosamine. They all play important role potentially related to the carcinogenesis of lung cancer in never smoker. And most of these environmental carcinogens tend to mix together. In late onset lung cancer patient, those who had EGFR mutation, they tend to have higher association with the environmental carcinogen, especially the nitropolycyclic aromatic hydrocarbon. We previously did a genetic study and showed that because the EGFR is located chromosome 7p, and it is very interesting. Around the chromosome 7p region, there are many copy number alteration associated with the EGFR mutation. So it seems that the Eastern Asian never smoker chromosome 7p is very important. And interestingly, we identified two potential environmental carcinogens. The genetic alteration are all enriched in the chromosome 7p region. That highlight that the association between the environmental carcinogen and the chromosome 7p genetic alteration possibly relate to the EGFR mutation. And we also identify many proteomic pathways associated with the early oncogenesis of lung cancer, especially in never smoker. This is very complicated, but I want just show you that some of the pathways you identify that are very important. For example, this spot represents the protein network of the MCM2 complex. The MCM complex is controlling DNA replication. And in non-small cell lung cancer, the genetic alteration of this MCM2 or MCM complex is also a druggable target. Then we discovered a drug that can targeting this specific MCM2 complex, potentially develop a specific targeting agent for MCM2 complex disease. So we identified the alphabet signature associated with early onset lung adenocarcinoma and the environmental carcinogen associated with the that onset air polluted related lung adenocarcinoma. We also identified some biomarker that associate with the progression of early stage lung adenocarcinoma. So finally, it takes a few minutes to report to you our recent work on smart targeting, focus on the cancer stem cells and tumor microenvironment. Most of the conventional treatment for lung cancer actually targeting at the cancer cells, but in the tumor, they are still a subset of population. We call it cancer initiating cells or cancer stem cells. So we try to develop a strategy, target the cancer stem cells, and also new strategy targeting the tumor microenvironment. We develop a method that we can actually culture the cancer stem cell from resected tumor specimen. We use the cancer-associated fibroblast as a feeder. The cancer stem cell can grow on the cancer-associated fibroblast feeder layer, so they can maintain a stainless property. So we can use that to dissect the crosstalk between the cancer stem cells, cancer cells, and the cancer tumor microenvironment. But most importantly, we use this culture method. We are able to identify what kind of agent that can be used to kill the cancer stem cell or kill the tumor microenvironment. So we can repurpose the old drug. This is an old drug used in cardiology for more than 30 years. The drug is very useful that can kill the cancer stem cells. In combination with conventional chemotherapy, they can improve the tumor killing effect. So we can use this old drug, repurposing the old drug. Another very important is the tumor microenvironment. We all know that tumor microenvironment is very important, especially the immune microenvironment. We try to take another approach. In the tumor microenvironment, usually they are relatively acidotic. pH is around 6.7, 6.8. It's not 7.4. And the lactate is relatively increased. In this acidic tumor microenvironment, the cancer stemness the cancer stemness is higher, tend to develop drug resistance. So we develop a tumor microenvironment targeting agent based on the pH change. Some nanoparticles remain intact in pH 7.4, but they start to degrade if the tumor microenvironment, if the pH decreases to 6.8. So they can very smart deliver the drug to the tumor microenvironment. In the second generation, we use the pH and lactate to control the release of the drug. We use the lactate oxidase to sense the lactate in tumor microenvironment. And in addition to the pH, we can then release the drug to the specific tumor microenvironment. And finally, we can also use the magnetic-driven nanoparticle to lead to let the drug concentrate on the high magnetic area. So by this way, we can smart target the tumor and let the drug had higher concentration in the tumor area. So finally, I'll conclude here. Lung cancer in never-smoker is the rising global threat. The PM 2.5 is probably related to the never-smoker lung cancer. In our study, it seems that the relative risk is lower, but the treatable risk is high because everyone need to breathe. So you are exposed to the PM 2.5. The total CT screening for lung cancer in non-smoker with high risk is feasible. Our study showed that we can detect higher lung cancer in the non-smoker, even compared with those clinical trial total CT scanning in heavy smoker, such as the NRST. So the Cancer Moonshot program, we identify the potential pathogenetic and etiologic factors for lung cancer in non-smoker. So you ask me, can lung cancer become a treatable disease? We also say yes. Early prevention and early detection is important. Before lung cancer is incurable, then you can change the lung cancer, let the lung cancer become a treatable disease. Thank you for your attention.
Thank you. Thank you, Professor Yang. I think Professor Yang would like to entertain some questions. So is there any question from our colleagues in Massachusetts General Hospital?
Well, I have one question. So there's the issue, the prevalence of lung cancer in never smoker is very high, or the proportion of women is very high. Have you looked at a relationship to estrogen exposure, like to number of pregnancy, which would increase exposure versus say early menopause? Has there been any sort of studies looking at a relationship to estrogen exposure? Thank you.
Yes, there are some, because we performed a genetic epidemiology study about 10 years ago. At that time, some study related to the estrogen exposure do have some risk with the lung cancer in non-smoker. But among all these risk factors, we found that the most important risk factors is family history, especially first-degree family, is much higher than those other factors identified, such as the cooking film exposure, cooking use without using ventilators, or passive smoking. So the family history seems to play the most important role.
So,
Professor Young, I was going to ask a question about the screening trial. So first
Yes.
of all, thank you very much for a terrific lecture. Identification of high-risk groups is always very important for screening trials. And so when you started this lecture and showed that a high percentage of women affected with lung cancer are never smokers, the first thing I thought was, this is going to make a screening trial very, very difficult. So it's very surprising to see that the cancer detection rate of 2.6% is significantly higher than in the American studies of 1.1%. What do you think is allowing for that difference? Is it difference in technique of the screening, or is it greater reliance on family history? Thank you very much.
I think the family history is the most important factors. In this Dodo city screening trial, we focus on non-smoker. Half of them, they have family history. And we found that family history, especially the first degree family, is very important risk factor for lung cancer. So our government also take this result and will start to implement Dodo city screening, focus on both in heavy smoker and in non-smoker. But in non-smoker, we will focus on those with first degree family who had lung cancer. So this is part of our national screening program now. And in Hong Kong and Singapore, actually, they also take this protocol to start the, to apply for starting this kind of Dodo screening trial in Singapore and also in Hong Kong, in Chinese populations, especially. Somehow, maybe this population is most susceptible to some genetic risk factors and also they share the same environmental risk factors.
Any other questions from the audience here, or then? Oh yeah.
Okay, good morning, Professor Yang. I'm the medical student in the 5th year of the medical schools. And I want to ask a question that in the slide 12, yeah, the slide 12.
Slide 12, okay.
Okay, slide 12. Why the KRAS mutation is not included in the treatment algorithm of the lung cancer cells?
So we need your input. Actually, there is so far, no KRAS targeting agent. There are only 1 or 2 in clinical trial. There is no good KRAS targeting agent, no drug. So those with KRAS mutation, we can only start with chemotherapy or immunotherapy. So we need you to join us to develop KRAS targeting agent.
Okay.
Actually, we are working on that. You'll be interested.
Okay, thank you.
So you have a bright future. Okay. Is there any question? If there are no more questions, then we'd like to thank Professor Yang for your inspiring and excellent talk.
Thank you, colleagues in Massachusetts General. Thank you.
Now, we'd like to proceed to the next talk. The next speaker will be delivered by Professor Littlemore. And I think probably everyone will know that Professor Littlemore is the chair of the Department of Surgery in Massachusetts General Hospital and also the editor-in-chief of Annals of Surgery. But in addition to that, I think we don't know much. So I would like to invite Professor Ken Tanabe to introduce for us that, and also to introduce the speakers or other speakers from Massachusetts General Hospital later on. So I hand it to Professor Tanabe.
Thank you, Professor Wong. It gives me great pleasure to participate in the T.Y. Lin Surgical Symposium and Joint Surgical Conference with MGH and NTUH. As you pointed out, it's just 1 year ago that David Chung and I had the privilege to be guests of National Taiwan University Hospital, you, Professor Wong, Dean Ni, to participate in this conference, visit the Department of Surgery, and visit both the university and the Cancer Center. The collegiality and sharing of information led to many plans on how we can work together more closely in the domains of education and research. We departed on a flight back to the United States with many new ideas for cooperation just after enjoying a celebration of the Chinese New Year together with your department. The SARS-CoV-2 virus was not far behind in heading west, and the world has been consumed by the pandemic. Amongst the casualties of the pandemic, developing closer ties between MGH and NTUH has been one of them. We hope that the coming year will allow us to refocus and create joint programs. Certainly, your gracious invitation for MGH faculty to join you and participate in this special symposium is a wonderful opportunity. Thank you very much. It now gives me the utmost pleasure to introduce the next speaker, Dr. Keith Littlemore. Dr. Littlemore received his undergraduate education at the University of South Dakota and his medical degree from the Johns Hopkins University School of Medicine. He completed surgical training at the Johns Hopkins Hospital before joining the faculty at Hopkins, where he rose to the rank of professor of surgery. After 30 years at Johns Hopkins, he moved to Indiana University and served as their chair and surgeon-in-chief. In May of 2011, we at the Massachusetts General Hospital were quite fortunate to be able to attract Dr. Littlemore to the position of surgeon-in-chief and chair of the Department of Surgery at the MGH and the W. Gerald Austin Professor of Surgery at Harvard Medical School. Dr. Lillimo is a member of most surgical societies and has held office in many. He has previously served as secretary, president, and chairman of the board of trustees of the Society of Surgery of the Alimentary Tract, president of the Society of Clinical Surgery, secretary and president of the Society of University Surgeons, president of the Halsted Society, and I could go on. He is a senior director of the American Board of Surgery, and in 2018, he received one of the absolute highest honors, being elected to the National Academy of Medicine. In 2019, he was selected to the American College of Surgeons Academy of Master Surgeon Educators. Dr. Lillimo has deservedly won many teaching awards. Dr. Lillimo has contributed to over 530 journal articles and 140 book chapters. He has edited 21 textbooks. Most notably, and as it pertains to today's lecture, and as pointed out by Professor Huang, Dr. Lillimo is currently editor-in-chief of Annals of Surgery. His lecture is entitled Annals of Surgery, Update of Activity and Opportunities to Publish in the Future. Keith?
Thank you very much, Ken. And again, thank you to Professor Wong and all of our hosts at the National Taiwan University. A few years ago, I had the opportunity of visiting China and to give a talk similar to this, and it received a lot of interest, particularly because of the increasing academic productivity and excellence that goes on in the entire Chinese and Taiwanese areas. So I dusted off this talk and have hopefully updated a little bit on some of the activities that have happened in the last year, and I look forward to sharing it with you. I believe you have my slides, and so if someone would put my slides on, and I'll just say next slide when it's time to advance. If that's not the case, I could share my own slides, but
Yes, please share your slide with us. Yeah. Or you prefer us to show you?
no, I'm fine. I can do it. So I'd like to just give the disclosure that obviously I'm the editor-in-chief of Annals of Surgery, so anything that I say may have some bias towards that journal, but I've served on a number of other editorial boards, and so I have a fairly broad view of the concept of publication. I did want to give a little bit of the history of Annals of Surgery. It is clearly one of the oldest surgical journals in the world. It dates back to 1884. And this was the headline from the newspaper in St. Louis that announced this new journal. And if you just fast forward to this slide, it talks about the major selling points and key points of this journal. It was the first journal in the English language devoted solely to surgery. The editor-in-chief would be a Dr. Louis Pilcher. I'll speak more about him in a minute. They had an editorial board from the United States, from Canada, and Great Britain. The first issue was published in 1885. The publisher was in St. Louis, Chambers and Company, and it was published simultaneously in the United States and Great Britain. And they predicted great success. Now, little did they know that at close to 140 years later, it would still be going strong. This is the first table of contents of the journal back then. It was mainly a series of case reports. It included all aspects of surgery, including orthopedic surgery and related to fractures, kidney stones, vaginal hysterectomy, as well as some traditional general surgery. The journal has been published, it started with Chambers and Company in St. Louis. It then moved to the University of Pennsylvania Press for a short period of time. And then it's settled in with the J.B. Lippincott Company in Philadelphia in 1897. And it's continued that relationship with J.B. Lippincott now for over 120 years. In 1990, however, J.B. Lippincott was taken over by the company Wolters Kluwer in Netherlands. And so the Lippincott name still remains, but we're a branch of Wolters Kluwer. Next slide. Oops, I'm sorry, I'm doing the slide. I mentioned Dr. Pilcher. He was a graduate of the University of Michigan. He was served in the Civil War. He was a surgeon in New York. He founded the Brooklyn Anatomical Surgical Society and was an editor of an early journal called the Annals of Anatomy and Surgery. He published the journal for an amazing 49 years. He mailed the last issue immediately prior to his death at age 90. We've had a number of prominent editors since that time. Many of them were Philadelphia based. I think the biggest boost for the journal, however, took place in 1974 when Dr. David Sabiston became the editor-in-chief of Annals of Surgery. Dr. Sabiston was a native of North Carolina. He'd done his received his MD and his surgical residency at Johns Hopkins. His mentor was Alfred Blaylock. And in 1964, he went to Duke and served as the chair of surgery for 30 years. Dr. Sabiston made many advances in the world of cardiac surgery. He was probably the most prominent surgeon of his era, and clearly his power and leadership really transformed Annals of Surgery into the journal that it was. In 1997, Dr. Sabiston passed the baton to Dr. Leighton Rickers, Bing Rickers as he's known. Bing, at the time that he took over, was the chairman at the University of Wisconsin. He was a native of Wisconsin and had done his MD at Stanford and a surgical residency at Utah, and currently is the chairman emeritus at University of Wisconsin. He served as the editor-in-chief for 14 years. The last 6 or 7 years, I was very fortunate to work with Dr. Rickers as his associate editor, and he was kind enough to help support me to become the editor in 2011 when he stepped down. The Annals of Surgery has a lot of great relationships that they maintain with surgical societies over the years. They've been associated with the American Surgical Association since 1885, again, almost as long as the journal has been in place. It's had a formal relationship since 1931. Every year, the September and October issues of the American Surgical are dedicated, of the Annals of Surgery are dedicated to papers of the American Surgical. Earlier today, the program for the 2021 American Surgical meeting was just chosen. I will see that program tomorrow, but I'm sure that the program will be great and it'll be a great couple of issues. Dr. Sabiston started the relationship with the European Surgical Association in 1994, and it remains a very strong relationship. We had a very long and healthy relationship with the Southern Surgical Association, but that ended in 2005. It ended for a number of reasons, but most importantly, the volume of papers that Annals of Surgery received unsolicited from authors wishing to have their paper published in the journal has really taken up so much space that we can barely handle the associations that we are associated with now. So it's probably a good thing that we lost that relationship. They've had less formal relationship with the New York Surgical Society and the Philadelphia Academy of Surgery in their early days, but those relationships have been long gone. This is the current cover of the journal. It is the same gold that it's had since its really early beginnings. Many people don't see this journal anymore. The number of individuals who actually hold a hard copy of the journal in their hands has dropped significantly over the decades, and certainly now because of access to the internet and through services such as Ovid and other library services, actually subscribing personally to the journal or having your library subscribe personally is a unusual event. 2020, I don't think anyone has to say it was probably the most remarkable and maybe some cases the saddest year of most of our lives. But it has been a remarkable year for annals of surgery. And I would have to say that during the period of time when restrictions on surgical activity at the MGH wound down, we couldn't travel, we couldn't teach, we couldn't meet in person. It's one thing that kept me more than busy. In a typical year prior to 2020, Annals of Surgery had 2,500 and the most 2,700 submissions in one year. In 2020, we had 4,527 submissions, which is a lot of work when my fingers click on every one of those submissions. We've maintained the same acceptance rate despite the high number of submissions. It remains at 12%, I think one of the highest and most competitive journals in the world. However, with 12% of 4,500, it's created a bit of a backlog for us, and we're working hard to get those papers in press. I will talk a little bit about how we've focused on certain issues in the journal. When COVID came out in March or April, we felt it was very important for a prominent surgical journal to embrace sharing of information rapidly. And because of that, we have been, I will not use the term overwhelmed, but certainly received more than our fair share of papers submitted on the topic of COVID. Many of the early papers that we published came from Asia because of your area's exposure and experience. The acceptance rate for COVID papers initially was a bit higher. Overall, through the year, it was 17%. I think it's drifted down over the last 4 or 5 months. Because of factors going on in our country, the concern related to social injustice, diversity, inclusion, and issues such as that has also been featured in the journal. We've had far less submissions, but as you can see, we've highlighted the importance of those journals, accepting almost 50% of those submissions. Next slide. Oops, I keep doing that, I'm sorry. This is in early in this sort of the COVID area, the first pandemic in this United States. We decided that we would combine with our online access as well as our Twitter access to really highlight all these important findings, trying to get as much information out in terms of diagnosis of surgical conditions associated with COVID, interactions with COVID patients, and our elective surgical schedules, how to ramp down, how to ramp up, how to be safe in the area. And as I said, I think this was a major contribution that we did very early in publishing these papers online, open access, for our readers to have access to this all across the world. As I said, a few months later, at least in the United States, we had the outbreak of a lot of tremendous tough times related to social injustice, which brought to attention that many of our traditional values in the medical and surgical communities perhaps had lost our focus. And so we made an effort to promote equity and social justice, not just in the surgical workforce, but in surgical care. And then finally, in our understanding that in order to be able to look at papers with of a diverse background and with diverse topics, we needed to have a very broad editorial board and a broader group of associate editors. And so we've made effort over the last 6 to 8 months to advance the disparity or the underrepresented minorities, and particularly in surgery women, as members of our editorial board and in reviewing our manuscripts. This is our current editorial board. I think back to the days when Dr. Sabiston ran this journal entirely by himself. Every article that came through in a hard copy of paper, and he distributed them to the associate editors, and we would mail him back our reviews. Dr. Rickers took it to the electronic submission process, and the numbers started rising. When it was just Dr. Rickers and I, it was 1,500, 1,800 submissions a year. Now with over 4,000 submissions a year, it is clearly a work of a great team. And this is the associate editors that do a spectacular job. And finally, we have a couple of outstanding young surgical residents who are far more able to deal with social media than I am. And they've taken the lead on advancing our message through Twitter, Facebook, and other mechanisms. I mentioned earlier the importance of the composition of editorial boards. I'm proud to say a third right now of our associate editors for the Annals of Surgery family are women. We have only one underrepresented minority member. Annals of Surgery, the mother journal, has a large editorial board, still probably 3 to 1 men over women. We have 12 underrepresented minorities, so we have a lot of work to do. We have 30 international members of our editorial board, and 3 of which are from your area of Asia. I'm going to talk a minute about Annals of Surgery Open. It's a new journal that had its first issues in July. We have a more diverse editorial board there with 10 men, 9 women, and 2 underrepresented minorities. So this is Annals of Surgery Open. This hard copy does not exist. It is entirely an online journal. There's also open access. We might refer to, I'll talk about open access journals in a little while, but it was decided that there were many, many papers with a 12% acceptance rate that just were not making the bar for Annals of Surgery. And so we decided to focus on those papers that might have an interest in being published in the Annals of Surgery family on this open access journal. It is a little bit more limited in its content than Annals of Surgery, the traditional journal. Its perspectives focus on surgical history, surgical education, and clinical approaches primarily in general surgery. It's not really a basic science journal, and it's not really a journal of broad specialties. I'm going to speak briefly about the impact factor. As we all know, for decades, impact factor was how people measured the significance of the contribution of a journal. Impact factor refers to the number of times articles are published over a 2-year period and cited in the next year. So the 2020 impact factor that was released in the summer of 2020 looked at all the papers published in 2017 and 2018 and how often they were published or they were cited in the year 2019 by all journals of any type. For decades, Annals of Surgery held the highest impact factor of all surgical journals, but unfortunately in 2018, we were passed. We were passed by the journal JAMA Surgery, and I will speak about that in just a second. So this is the 2019 impact factor that was released in July of 2020. I give JAMA Surgery credit. They were the first journal in surgery to surpass the 10.0 mark in 2018 with a great year with publications. In 2019, they went up to 13.625. We're very proud that in 2019, we also surpassed a point of 10.0 for impact factor, being the second journal to do that. The rest of the journals on this list are a mixture. They're little non-mainstream general surgery, the Journal of Neurology, Neurosurgery, and Psychiatry, the Journal of Heart and Lung Transplant, Endoscopy, but there's also some very good general surgery journals such as BJS, JACS, Annals of Surgical Oncology, Diseases of Colon, Rectum, and Surgery, all in the top 40. What I do want to point out, though, is if you look at that right column, Annals of Surgery publishes more pages, more articles than any other journal, more than most any other journal. I think there's some that may publish more, but we publish substantially more than JAMA Surgery and some of the others. Therefore, our denominator, as one looks at the impact factor, is significantly greater. So if you look in 2019, Annals of Surgery had over 50,000 citations, over 5 times more than JAMA Surgery. So although our impact factors drifted down because of strategic editorial decisions by JAMA Surgery, I still think it's fair to say that Annals of Surgery is the most cited surgical journal in the world. This is the progression of our impact factors. As I mentioned, in 2017, we were a bit lower, below 10. We've moved up over the last 2 years, and we're happy to be over 10, and we like the trajectory of our increase. But impact factor, although it's important, is probably not the only key indicator in which a journal measures its success. As we've moved to online access for so many different sources of access to our journals, as you can see, we've focused on the website as a site of access. And as you can see, the numbers in 2020 exceeded 625,000, over 100,000 increase in the number of views on the website. Here are the visits by month. As you can see in the middle of the year, when I hope that the COVID pandemic papers were starting to get published, we had a number of visits that came up. Maybe this is a reflection that people were having more time for reading because we were operating a bit less, but it was a nice trend to see. If you look more to the right on this slide, the usage by countries, United States is top with over 60% of the usage, but again, several Asian countries, Japan, India, and China are all heavy users of Annals of Surgery online. Just for your own interest, these are the top read articles on Annals of Surgery for the year 2020. And it's interesting how the topics have changed. If you would think that the top 2 most read papers at Annals of Surgery would focus on a topic related to diversity and also bouffant hats, I would have been a little bit shocked. But it's good to see a couple of great surgical papers and very important guidelines. The American Association for Endocrine Surgery and Guidelines for Definitive Management of Thyroid Disease, the Safe Cholecystectomy paper that was published in July, and then some other papers that are extraordinarily important topics related to surgical areas. The top read articles of papers actually published in 2020. Again, many of the same papers here, but again, some focus on quality and safety, some important guidelines. But again, I'll point out that several papers are related to COVID were in the top 10 here, which again makes me feel good that we made the right decision to fast forward these papers through the peer review process and getting them available to e-publication. I mentioned earlier our great social media team. We have a large presence on both Facebook and Twitter. As of January 2021, our Facebook account had over 4,300 likes and close to 5,000 followers. Our Twitter account has over 42,000 followers and over 6 million impressions in 2020. So it's a great work that's done by these young colleagues. I'll focus a bit on the country of origin of our submissions. The rest of my talk will focus a little bit on helping your surgeons, the people in this audience, and tips on how to write a good manuscript to make it competitive for Annals of Surgery. The United States remains the top country in terms of submission of papers to Annals of Surgery with over 1,300. But the combined entities of China, Taiwan, and Hong Kong are second with over 700, twice as many as the United Kingdom and the rest of the countries. I acknowledge that the acceptance rate from these countries is a bit lower, but I think you should notice it's right on average for all papers submitted to Annals of Surgery, and I think this is tremendous progress. that papers from Asia have had in terms of getting accepted. So I would say keep up the good work, and I hope in the remaining slides I can give you some suggestions on how to be better. Just I mentioned a couple things, the importance of e-publication. EPUB is far, has a lot of advantages. It allows globalization. You're not dependent on mailing a hard copy of a journal. It's quicker access. The average paper from the time I accept it to the time it's available on EPUB for annals of surgery is somewhere between 6 and 8 weeks, which increases the citation time. It allows investigators to add the citations to their CVs to help with promotion and grant applications. It's certainly cheaper. It's available on your tablet, on your smartphone, on your computer. It allows multimedia such as videos and graphics, and it saves space. I have a traditional surgical office with tons of books and tons of journals, and I think every day, what am I going to do when I retire? Because no one will ever take all these books and journals that I have in my office, but I hopefully don't have to worry about that for a while. I mentioned earlier the concept of open access. Annals of Surgery, as I said, Annals of Surgery Open is open access. And open access has also a lot of advantages. It makes the scholarly works available to readers without any financial, legal, or technical barriers. It is funded by the institutions submitting the papers or by other organizations such as various governments, various societies. It can be published through your research grants, through public or private funding, or the authors can pay for it. Open access journals such as Annals of Surgery Open are entirely open access. Anyone with a computer can get access to the papers. There are hybrid models. The traditional Annals of Surgery is a hybrid model. And so if one wants to have open access for a paper published in Annals of Surgery, you can request it. And if you pay the cost of open access, it's available. There are other mechanisms which papers can be made open access. For example, if Annals of Surgery made all of our COVID papers for the first 8 months available for open access, just because we felt getting those messages out were so important. There are a lot of advantages. Again, arguments for, again, as I mentioned, the content is available to the public. It benefits authors who see their papers read more often, more cited. Academic readers at institutions who cannot afford the journal have access to it. Readers, whether you're in the public or in academic surgery or wherever, have access to it. Taxpayers who pay for research in our country or whatever country can see the results of the research for which they support, as well as patients and caregivers get access to up-to-date medical research. It increases visibility and citation, and it is a source of income for the publishing industry. I would just warn you, you have to be a bit careful. There are a lot of what we call predator journals out there. I would say that most of my faculty get an email like this once or twice a week, inviting someone to submit to a open access journal. You make a couple of clicks, you read about how your paper can be submitted, you get to the bottom of getting ready to submit your paper, and then there's a couple $1,000 fee to move through the process. So again, be a little careful when you deal with open access in certain journals. Certainly, in my opinion, e-publication will continue to grow. I would not be surprised in the course of the next 5 or 6 years that hard copies of journals will go away. The advertisements that support hard copy journals are becoming less and less available. So it may be the death of the hard copy journal. And I think open access will continue to grow because of the financial and access issues. I hope it will not eliminate the standard model for publication. So now, how to get your paper published in a high profile journal such as Annals of Surgery? First of all, you have to realize what my goal is as the editor. I certainly want to increase our impact factor. I want to maximize people wanting to read our papers. Mostly, I understand they will be online. And I want to drive people to our website and to our Twitter accounts to learn about what we're doing. People ask me, are there politics in surgical publishing? I would say probably not, but there are some biases. And we work very hard to eliminate those biases by having multiple diverse reviewers for papers. I don't think there's politics against or for any organizations. I do believe there are some biases. Those biases will exist until the decision is made that all submissions to journals will be completely blinded. Those biases can be geographic, they can be institutional, they can be based on individuals and past track records for publications. There can be biases in subject matter and in the types of manuscripts. An example of biases towards an institution is, as Ken mentioned, I spent a long time at Johns Hopkins. We published a lot of papers on pancreatic cancer when I was at Hopkins. And I think whenever Hopkins submitted a paper to a journal, people wanted to read it and thought it was probably important. I think it's a favorable bias. I would like to think that there are very few unfavorable biases, but again, every reviewer, every editor has their own opinions. Getting your manuscript published, I think, is important that you have a well-written manuscript that has excellent content, but even excellent content might not get accepted if the manuscript is not structured properly. A successful publication of a manuscript requires a structured outline, which is the cornerstone for publication. The outline consists of these features: introduction, methods, explaining your statistical analysis, presenting your results with well-constructed figures and tables, and a well-written, thoughtful, but not excessively long discussion. This was a paper now that's 15 years old, published in the Journal of Surgical Research by citing the key points to a good manuscript. A good manuscript describes what is known, assesses what is unknown, makes a clear statement regarding the question and hypothesis being addressed by the study, and then a discussion and a summary of the new information that has been gained as a result of the study. So if you would remember these 4 points, I think you'll be off to writing a good manuscript. Getting a paper written requires that you break the inertia to start writing. If you're thinking about writing a paper, the best time to write it is as soon as possible. You have to overcome procrastination and inertia, which are the biggest obstacles to writing a paper. One of the advantages to the papers that are going to be accepted at the American Surgical is the authors have a deadline to get them submitted by April. Without a deadline, these papers could, the work could linger for months and months afterwards. So if you do not have a deadline, you as a mentor or leader should instill deadlines on your junior faculty to get these ready. You should seek feedback, particularly if you're a junior author. The more feedback you get, the earlier it is, the more time you get it is important. It's key that you get feedback early, and that feedback can really make major changes and ensure that the paper is headed the right direction. And then certainly late feedback to make sure the manuscript gets the approval of all the authors and there's nothing left behind. You be better author by receiving feedback, and I would believe the more you write, it makes you a better author and makes the process easier. Mentoring, as I'm going to speak as the role of the mentor. When you're mentoring a junior faculty member, a medical student, or resident who's working on a paper, set expectations, set deadlines, give them follow-up. Do not accept excuses. We all are busy. If you're writing a paper with a surgical resident, they are working extraordinarily hard. But again, keep their eye on the ball, keep them pushing forward to get the paper submitted. The deadlines can be incremental. Say to me, I want the results, I want the tables first, and then we can focus on the discussion later. Nag means just don't let up. Keep reminding people that we have a deadline, we want to meet it. Manuscript revision. If your paper has been submitted to Annals and you get a electronic feedback from me that the paper you've had a chance to revise, the odds are highly in your favor that it will be accepted, probably approaching 75%. Never take the criticism personally. View the reviewer's comments as suggestions to improve your manuscript. Even if you don't agree with the reviewer, do not be argumentative. Do not pick a fight with a reviewer or an editor, because that will almost eliminate your chances of getting the paper accepted. If you're asked to make specific steps, such as shorten the manuscript or eliminate figures or tables, regardless how important you feel, if the editor or the reviewers think it's important, I think that's the thing to do. If you do have problems with English usage or grammar, get professional help. There are many sources available. Annals itself can provide help for you in terms of English speaking. If your statistical analysis is questioned, get professional help. Make your changes evident in the manuscript. If you cannot make the suggested changes, just respectively explain why. Don't take months to revise your manuscript. Get it back in a short period of time. And if it's rejected, take the reviewer's comments and look to those to improve your manuscript. There are a lot of journals that are out there, and you can certainly get it published if you improve it. When you do submit a revised manuscript, show your appreciation and gratitude to the reviewers for their input. Address their comments in a point-by-point response. Define the specific changes in your letter. Make the reviewers and editors' job easy by setting examples, by saying exactly how you've altered the manuscript in response to their comments. The editor expects, obviously, a properly formatted, appropriate manuscript. If there are instructions, follow the instructions in terms of word lengths, number of tables, number of figures. Select the right journal for your manuscript. If you're an orthopedic surgeon or if you're a urologist, if you submit it to Annals of Surgery, it's likely going to get rejected relatively early in the process. If your focus of your paper is on thoracic surgery or colorectal surgery, you should think maybe a specialty journal would be better. I said, follow the instructions, avoid common errors, such as improper formatting, errors in English grammar and usage. Please number the pages. As a reviewer, when I want to point out something and I say there's something wrong on page and I have to page through and count the pages myself, it just irritates me and it might lower your rating of your manuscript. So number your pages. Develop your hypothesis in your introduction, carry that through to your methods, results, and discussions. State your limitations of your study, and don't overstate your conclusions. Other areas are rambling too long in both the introduction and I would say in the discussion. Use abbreviations appropriately. No one likes to read a paper that has abbreviation after abbreviation. Make your statistical analysis clear and not difficult to follow. Same with your legends. Make them well presented, describing the presence of the arrows and the statistical analysis. Figures that are sloppy or poor interoperative photographs should be avoided, and make sure your tables line up and look good. As I said, always have your co-authors read the abstract, the entire manuscript. It's a requirement, basically, that most journals require that you sign off that you've read and reviewed the manuscript. It's sometimes helpful to have a new set of eyes look at someone naive to the paper, so that they can give input as to clarity in the presentation. And again, simple, clear, and concise is better than complicated, muddy, and verbose. The ideal paper, thus, is succinct, accurate, and clear, brief and interesting title. Author order is carefully considered and accurately represented. Those should be discussed well before the final draft of the manuscript is prepared, just so that people don't get upset. I have people contact me after papers have been accepted that they're not happy with the order of their names on the author list. And I say, that's your problem. You should have solved it before the paper was submitted. Clear, readable abstracts, mini abstract that hits on the points, introduction, clear, interesting, and compelling, methods, comprehensive, well-organized, results, objective, well-organized, with proper uses of tables and figures. Discussion should be thought-provoking. References should be accurate. Use of experienced and English writer, and even an experienced writer can streamline the process. And a short cover letter and a suggestion of reviewers is greatly appreciated by me. With 4,000 submissions a year, I don't know everyone who's an expert on every topic, and I seek all the help I can get. So, good data, well-written manuscript, and then work to submit manuscripts. The more you submit, the better your chances are. This is a famous Bostonian who said over 200 years ago, try and fail, but don't fail to try. More contemporary, one of my heroes was Michael Jordan, the great basketball player, describing his experience of taking over 9,000 shots in his career, lost 300 games, 26 times he took the game-winning shot and missed. He's failed over and over again in his life, but that's why he succeeds. And again, a famous hockey player. I know hockey's not quite as big in China and Taiwan as it is in Boston, but the famous Bobby Orr said, you miss 100% of the shots you never take. So a paper is never going to get published unless it's submitted. I thank the audience for your attention and the invitation to be part of this. I will just say in closing that anyone who has an interest in serving as a reviewer for Annals of Surgery, please contact me via email. Describe your areas of interest, your expertise, whether it be in colorectal, lung cancer, gastric cancer, many of the things you do so well in your country. We need experts in those areas, and we need experts who are able to read papers from your country and understand the the issues that come into things like randomization and stratification and all. So please reach out to me, and we're always looking for good reviewers. Again, thank you, Dr. Hong, and the organizers for the opportunity to be part of this very special symposium.
So thank you, Professor Lelamo. I think you give us a very important and also a very encouraging message. I think probably from now on to next year, you will find many submissions from our university hospital.
I hope so.
Yeah, and I find some thing very important is that you need to give deadlines to your young colleagues, and so we can have them prepare and publish in these very important journals. Yeah, I don't know whether any questions or comments from our colleagues here. You want to ask Professor Littlemore how to publish, or even what's wrong with your submission to Annals of Surgery last time? Yeah, if any. I just, our chest surgeons, I think they publish many methods of surgery in lung cancer. I just wonder, Professor Xu, have you submitted any papers to Annal of Surgery? Have you tried that first?
So thank you for Professor Limelo's speech. Actually, our colleague, Professor Jinxin Chen, he submitted several articles to your journal. I think the most important is about good design, because some clinical trial, there should be a prospective good design. So in our department, we still work together to design a good idea, then go to the clinical trial. So last time we submitted a paper is about the factory mesh to prevent the spontaneous pneumothorax. And unfortunately, it was declined from the journal. I think that the most important is about the topic. Maybe if the topic is to focus on the thoracic surgeon, or it could not be readable for the general surgeon, maybe it's difficult to publish in the journal. So what's your suggestion for about the specific, sometimes real disease like the pneumothorax management rather than the cancer surgery? Do you have any comment for the surgeon who focus on the, not non-cancer surgery, and how to create a good article for your journal? Thank you.
So we do publish thoracic surgery papers. I think you're right. Areas such as lung cancer and esophageal cancer are probably more of a focus of the journal. And I always hate when I get into a situation and people start talking about how many papers they've submitted and how many have been accepted, because number one, again, when we only accept 12% of our papers, the numbers can get a little bit low. I don't think just because it's a thoracic surgery paper, we will not accept it, but I think my most important thing is it should be a paper that would be a broad interest to readership across all specialties, and it should be a broad interest across all countries of the world, not just something that pertains to a local issue. So if it's a broad interest, both across specialties and across continents, I think that's the best.
Thank you. I think your message, we will, since we have your slides and we also recorded your talk today. So maybe we will, can I just use your slides and recording to show it to our colleagues? Is that
Right.
okay?
Yes, and you can certainly feel free to share my email with any of your faculty who would like to become reviewers for the journal.
Okay, I think many of our colleagues will be interested, and I think and also they should be very capable of reviewing papers for you. So if there is no more questions, then I think we would like to proceed to the next talk. Thank you, Professor Littlemore.
I am pleased to introduce Dr. Motaz Kadan. Dr. Kadan received his undergraduate education and medical degree at the University of Edinburgh, Scotland. After having fled the Gulf War with his family and emigrated to the United Kingdom at age 11, he completed his surgical residency training at Edinburgh before moving to the University of Louisville for a PhD degree in physiology and biophysics. He completed a surgery residency at Stanford University and then a fellowship in complex general surgical oncology at Memorial Sloan Kettering Cancer Center. At the MGH, we were quite fortunate to attract Dr. Kadan to join our faculty, where he now serves as the Kapontsev Family Endowed Chair in Surgical Oncology and an Associate Professor of Surgery at Harvard Medical School. He's active in teaching and serves as Director of Medical Student Sub-Internships, Site Director of our Complex General Surgical Oncology Fellowship, and Director of our newly established Pancreas Cyst Clinic. He's a member of several national organization committees, including Chair of the Education Committee for the SSAT, the Society of Surgery of the Alimentary Tract. Dr. Kadan directs a clinical outcomes research group that is amongst the most productive at our institution and simultaneously directs a translational research laboratory. He's authored over 135 articles. He is a superb pancreas surgeon, and today's lecture is entitled Locally Advanced Pancreatic Cancer. Dr. Kadan.
Okay, thank you very much. I hope that you can see my slides and you can hear me. Please let me know if there's any difficulty with the audio. First of all, I would also like to say that it is a real privilege and honor to be here speaking with you today. Thank you to Professor Wong and the delegation for inviting us today. I also would like to acknowledge that I work for the best people at the Massachusetts General Hospital, including Dr. Ken Tanabe, and the best surgeon in chief I know, Dr. Keith Littlemore, as well. And so it's a real privilege and honor to be surrounded by such special and important people all around today. So thank you for this collaborative effort that was set up. Today I'm going to talk to you about locally advanced pancreas cancer. This is something that we do at the MGH, and I'm going to try and give you a little bit of a story about how this developed at the Massachusetts General Hospital, even before my arrival approximately 5 years ago. let me just make sure here. Okay, so as you can see here, obviously the first slide on pancreas needs no introduction. It is a cancer that is rising in incidence, prevalence, and in death, and expected to continue to rise over the coming years. What we did learn early on from the MGH experience and others' experience is that surgical resection is important. So you can see here the MGH experience between 1987 to 2000, 1985 to 2006, among 499 resected patients. The 5-year actual survival was 19%, and the 10-year actual survival was 10%. And this is due to surgical resection. But we also learned that patients who underwent an R0 negative margin resection with wide, greater than 1 millimeter margins, compared with those who had close margins or an R1 margin, that median survival was substantially better, 35 months, compared with 16 months in the setting of close margins or 14 months in the setting of positive margins. And in fact, when R1 patients were compared to locally advanced patients who were not resected, median survival at that time was about the same, 11 months versus 14 months. And this was actually confirmed among several different studies that confirmed the importance of margin, as you can see here, as predictors of survival. At the same time that this was happening in 2011, the ACCORD trial was published, and that established the role of FOLFIRINOX as the standard of care chemotherapy regimen for metastatic pancreatic cancer. This publication from Conroy was published in New England Journal of Medicine that showed the significant improvement in survival, both overall survival and progression-free survival compared to the single agent gemcitabine. So the question that immediately came to mind, which was a very innovative question, is can we apply what we saw in the metastatic setting with FOLFIRINOX to locally advanced pancreatic cancer in an attempt to get an R0 margin, given what I just told you about negative margin resections? And so this is exactly what happened starting at 2011 at the Mass General Hospital. There's an attempt at therapy with FOLFIRINOX in borderline and locally advanced pancreatic cancer, followed then by surgical resection. And the case for neoadjuvant therapy is actually pretty straightforward in locally advanced tumors. It's to increase the R0 resection rate, but as well as tumor node positivity downstaging. And obviously, the additional advantages of neoadjuvant therapy, which apply globally, are that this ensures that patients receive systemic therapy, given that approximately 25 to 50% do not in the adjuvant setting because of complications or difficulty in recovery after surgery. Because pancreatic cancer is a systemic disease with poor outcomes, so it makes sense. Because chemotherapy provides a stress test of tumor biology, and it may allow us to identify patients who progress and may not benefit from surgical resection. But it also allows patients to be taken care of and optimized for future surgery. And this has successfully been applied to other cancers, as we know now. So this was one of the first reports that came out of our institution in the year of 2015. And the aim of this initial study was to evaluate the accuracy of imaging in determining resectability following neoadjuvant therapy. This was largely an unknown entity. And what we found, and Dr. Ferroni here published this paper, showed that 92% of patients actually ended up going an R0 resection in that initial series, despite being deemed unresectable after FOLFIRINOX. And so what they saw in the scan was that there appeared to be still some haziness around these blood vessels. By criteria, this would make them still unresectable, but in fact, this was not viable tumor because these patients underwent resection with a negative margin. And in fact, compared with patients who did not receive neoadjuvant therapy, FOLFIRINOX resulted in longer operating room times and higher blood loss. But in the same breath, it also caused lower operative morbidity. And in fact, among the initial series of patients, there were no post-operative pancreatic fistulas. So that's one thing neoadjuvant therapy certainly helped with. There was also a decrease in lymph node positivity, a smaller size of the tumor, decrease in some of the other pathologic predictors such as perineural invasion and lymphatic invasion, and overall an increased overall survival at a median follow-up of 11 months. And all of this was done with equivalent length of stay, readmissions, and mortality. So neoadjuvant therapy was now being applied safely based on this initial report that we had from 2015. And now we were starting to see less than 1 millimeter of residual tumor in approximately 16% of patients. And you just see focal nests left behind like this. So this was one of the initial cases in the series. This is a 41-year-old woman with a 3.6 centimeter tumor that you can see is abutting and encasing the SMA. I don't know if you can see my cursor, but if you can, you'll see that the vessel is there. The CA19-9 was initially 985, and after treatment with FOLFIRINOX, you would argue that this looks maybe about the same. The tumor looks smaller, but there's still encasement of the blood vessel. And this ended up being a 1.6 centimeter tumor that was resected off the blood vessel T2N0 with negative margins. This is one of my cases that I actually did recently, and I wanted to share with you this one with you because this is a very difficult case where the tumor, you can see, extends far posterior and to the left side of the abdomen from the uncinate process of the pancreas. And you can see here involvement of the SMA as well. And after the patient underwent neoadjuvant therapy, you can see there's shrinkage of the tumor, but it's still in a very awkward position and the SMA still appears to be involved. However, just like that paper showed, this is what the surgical field looked like. This is the portal vein that I was able to dissect out, and I had to extend the length pretty low because the uncinate process was involved. And you can see here the cleanly resected SMA margin. And this patient ended up having a YP-T1C N0 cancer, and the tumor was resected with negative margins. So then we turned around and said, well, is there a way to predict resectability and survival in patients after they get FOLFIRINOX? How could we tell who are the patients that would be successfully resected? And the simple answer is actually there was not an easy way. When we looked at CA19-9, you can see in patients who were resected compared with those who were not resected, they both had a decline in CA19-9. Even though there's a significant difference here, you can see the drop is not very helpful. It's not easy to know what's going on here in terms of trying to tell who's going to be predicted and who's not. And then the same here with size. You can see here there is a little bit more shrinkage in patients who were resected, but nothing too substantial or meaningful. The difference is 6 millimeters, even though that was statistically significantly different. But now we were starting to see some prolongation of survival in those patients. And you can see here in the FOLFIRINOX arm that the survival now, median overall survival was 43.7 months, compared to patients who were upfront resection was 25 months. And you might say, of course, this is selection bias because these are patients who went on to be resected and did not progress. And the answer is yes, because this is exactly what we should be accomplishing and hoping to achieve in pancreatic cancer. And in fact, when we looked at patients who were resected compared with those who were not resected, what this slide tells you after neoadjuvant therapy is that surgery still has an important role because these are all patients who progressed towards surgery, but those that could not be resected had a survival of 18.6 months. And so that led us to our phase 2 trials next. Our first phase 2 trial was a borderline resectable phase 2 trial that was an intervention of FOLFIRINOX 8 cycles plus chemoradiation in borderline resectable tumors. Our zero resection rate was 65%. And in fact, the median overall survival in all these patients was 37.7 months. But in fact, in resected patients, median overall survival was not reached in this phase 2 pilot that we ran. And 2-year overall survival was 72%. And these are numbers that we had not seen before. So then came losartan into the equation. And losartan, as you know, is an angiotensin receptor blocker. And it comes from the same category, roughly, of drugs such as ACE inhibitors. But this one acts on the receptor specifically. And we learned a little bit about losartan from Marfan's disease, which is a disease of excessive TGF-beta signaling. And in Marfan's, there is disruption of normal collagen matrix. And we learned from this New England Journal of Medicine paper that was completely unrelated to pancreas cancer at that time, that these angiotensin receptor blockers can actually reverse some of the disruption that you see with collagen. But then in the Steele laboratory at MGH, we also learned that losartan can inhibit collagen 1 production by cancer-associated fibroblasts that are isolated from breast cancer biopsies. And you can see here the attenuation of the effect of TGF-beta by losartan. And in fact, they were shown to decrease collagen 1 deposition in tumors in a dose-dependent manner, as you can see, with smaller tumors that were more easy to penetrate at this point, with improved intratumoral distribution of nanoparticles and nanotherapeutics. And in fact, when we went back and looked at all our data of all our patients retrospectively to compare those who had been on any form of ACE inhibitor or angiotensin receptor blocker compared with those who were not, there was a retrospective association with improved survival in patients who were already on this treatment beforehand. So this is what we decided to do for the locally advanced study that we had, is we used an intervention of FOLFIRINOX 8 cycles plus losartan plus chemoradiation. And the R0 resection rate at this point was 61%. And again, these are locally advanced tumors by criteria. And again, if you look at the resected patients, median overall survival in these very advanced tumors now is 33 months, and 2-year overall survival was 83%. Again, numbers that we had not seen before. And so what we were able to conclude when we compared the differences between both studies was that there was a similar resection rate, even though these tumors were very different, borderline resectable and locally advanced. But there were also 3 pathologic complete responses in the locally advanced study. And what this then led us to see is that there was a very big difference in the tumor size especially. And could that be attributed to losartan because of what I just told you about the intratumoral pressures, 4.9 versus 1.8 centimeters. And so the one thing we could say from the phase 2 studies is that certainly losartan warrants further study at this point. And so now we have a phase 3 study that is a multi-institutional study, and the principal investigator of that study is Dr. Ted Hong from the Massachusetts General Hospital. And so we have 3 arms that involve FOLFIRINOX, SBRT, and surgery, or FOLFIRINOX with losartan and then SBRT and surgery, or FOLFIRINOX with losartan, but with the addition of nivolumab at the time of radiation. So to try and include immunotherapy with that antigen release that happens with radiation. And the primary objective of this study, which is still opening but starting to accrue almost completely now, is to determine if the addition of losartan or combination of losartan and immunotherapy to FOLFIRINOX and radiation will result in an R0 resection greater than 65%. And we're looking forward to seeing the results from that study. This is a patient who I operated on, who I had enrolled with Dr. Hong and the team on Stand Up to Cancer, the same study we're talking about. She was in arm 3, so she got FOLFIRINOX, radiation, losartan, and immunotherapy. She was a 66-year-old woman with 3 weeks of right upper quadrant pain. She had a history of laparoscopic Roux-en-Y gastric bypass for weight loss surgery. We have a lot of that problem in the United States. And then she was also a radiation oncologist at the Brigham, which is one of the hospitals that is near our hospital. And we ordered a CAT scan on her, and this is what we found. You can see here there's a tumor that involves and narrows the portal vein more superiorly. And you can see there's 360-degree encasement and narrowing of the vein. Also, maybe I can show you here if you can see my cursor, but there is a small artery that runs back here. This is a right hepatic artery. It's actually in a replaced position, but it's not actually a replaced artery. It came off the celiac. It was just an abnormal takeoff of the right hepatic artery. And you can see here after treatment on this study with nivolumab, radiation, and chemotherapy, that there was a dramatic improvement in the response, and the vein is now open and the artery looks a little bit more clear. And we took this patient to surgery, and you can see here we're able to resect this. Here's the skeletonized superior mesenteric artery, and here's the portal vein where I was able to resect the tumor completely without having to do a vein resection. This is the left hepatic artery, and then you can see the right hepatic artery that came from underneath. It actually also came from the celiac, even though it looks like the position is that of a replaced artery. The final pathology on this was YP-T0N0, complete pathologic response. So then we decided to look at some of these phase 2 trials that we had and analyze the data in some different ways and look at how recurrence is different. And what we learned was approximately 56.1% of patients had now recurred over these 2 study time periods. Median disease-free survival was 17.2 months, and 56% of the patients. Interestingly, we saw that 82% of the patients had a distant recurrence and 11% had a local recurrence. And this was irrespective of the margin status, whether it was R1 versus R0. And this is actually a similar recurrence pattern to upfront resection and then patients getting adjuvant therapy. And in fact, when we looked at the timing and the patterns of recurrence, we found that among node positive and node negative patients to compare, we found that patients who were node positive had a faster recurrence within 11 months compared to node negative patients at 21 months. But there's actually no difference in recurrence patterns again. Most of these recurrences, whether node negative or node positive, were distant, and only few were local recurrences. So you can see here 76% and 64% in node negative, node positive were distant recurrences. I'd like to mention a quick word about intraoperative radiation therapy, which is a device here that you can see that we use in the operating room. This is the machine that we use to deliver intraoperative radiation therapy. So intraoperative radiation therapy allows direct visualization of the tumor and accurate definition of any target tumor volume. The normal tissue can be removed or shielded from radiation, and the electron radiation permits adjustment of the depth of the radiation beam. And what we learned initially from the early intraoperative radiation therapy, this was work that was done by Dr. Warshaw even, that in patients who were not resected, but got radiation in the operating room to the tumor instead, that most patients had recurred and survival was limited. But we saw something interesting, which is that 3% of patients were still alive at 5 years, despite no resection. And now we were seeing a small tail on the curve. So maybe we were helping a very small proportion of patients just by doing intraoperative radiation therapy. But in fact, when we compared the intraoperative radiation data more recently, and we looked at patients who got resection and intraoperative radiation therapy to attenuate the margin, you can see here that the median overall survival is 35 months in those patients. But what was most interesting was, again, the patients who were not resected but got intraoperative radiation therapy only, and those who were resected had almost equivalent survivals. So actually the radiation in the operating room was acting a little bit like just a resection patient without neoadjuvant therapy or IORT. Of course, the caveat is it's hard to know which is doing the work. Is it the neoadjuvant therapy or the intraoperative radiation therapy, or possibly both? And in the most recent study here, you can see that patients who got IORT and resection, 47 months nearly was the overall median overall survival, compared with IORT only 23 months. And these were the highest numbers that we were starting to see now for pancreatic cancer. What we learned was that IORT was well tolerated with minimal complications, that IORT alone was associated with some long-term survival, approximately 3% of patients initially, and that the addition of IORT to locally advanced patients who have undergone neoadjuvant therapy is associated with a survival advantage. One last thing I would like to touch on in my talk today, which is trying to get people through neoadjuvant therapy, is definitely a tough exercise that involves toxic chemotherapy, weight loss, sarcopenia, in addition to what the tumor can do to the patients themselves. And so we have a prehabilitation protocol where we do multimodal prehabilitation, including nutrition and exercise, to try and help patients get fitter and stronger to be able to better tolerate their chemotherapy and operation. Because as I mentioned, the disease, the chemotherapy, and the surgery all result in the debilitated patients. And these patients were coming to us very tired, very malnourished, and about to undergo a Whipple operation, which we know is not a good recipe. And so we created this trial to try and assess the feasibility of delivering a multimodal intervention, to determine its acceptability to patients and clinicians, but most importantly, to assess clinical and biologic outcomes for those patients who received the prehabilitation intervention. And we have a fitness program and a nutrition program for those patients. And we actually place them in different tiers, and we exercise those patients, and then we have them meet with our nutritionist and get a logbook for their protein supplementation of approximately 1.5 milligrams of protein per kilogram. And we have the folks from nutrition follow up weekly with them to ensure compliance. And so our main primary outcome of this study, which is also a phase 2, is to see mostly, at least if 50% of patients will complete approximately 50% of components of the prehabilitation program. We have a lot of secondary outcomes here that I can show you. And as you can see here, basically looking at feasibility and acceptability, but also looking at some of the kind of psychological assessments, some of the chemotherapy outcomes and cancer oncologic outcomes, including surgical R0 resection and nodal positivity rates. But very important to us, obviously, also looking at surgical outcomes, time to tolerance of diet, to adequate pain control, to return of bowel function, to fever-free periods, to independent mobility and discharge from hospital, but also readmission rates, complications, and mortality, because we're very interested to see if prehabilitation has an impact on these. But also here, there are some exercise outcomes that we looked at, some nutritional outcomes, and some other disease outcomes that occur in with exercise and nutrition. But the best part about this study, I think, is that we also will be examining with RNA sequencing blood collected from patients to see if there are changes at the molecular level due to these exercise and nutrition programs that may influence host defense mechanisms and innate and acquired immunologic mechanisms as well. The program is very nice because it fits in with our current neoadjuvant program, which is chemotherapy 4 cycles, 8 weeks, staging, chemotherapy 4 cycles, another 8 weeks, chemoradiation 6 weeks, 4-week break, and then surgery. And we're able to fit all the components of the prehabilitation at these different intervals that you can see here. And there is an exercise intervention and a nutrition intervention that were both implemented during the neoadjuvant therapy phase. So in conclusion, I would say that there is a spectrum in the approach to locally advanced disease, at least in the United States there is. We are a program where we use total neoadjuvant therapy, starting with FOLFIRINOX 8 cycles for 4 months. Then we do radiation 28 fractions for a total of 50 gray over 5.5 weeks. And then as long as CA19-9 is coming down a little bit, maybe some tumor shrinkage in size, we go for operative exploration, at least if there is no progression. And then what we do is when we get into the operating room, we do intraoperative biopsies. If the biopsies are all positive around the blood vessels, it means the tumor is still viable. And we probably may not be helping that type of patient. But if the biopsies are negative, these are the patients we like to proceed with the exploration. And then if there's any suspicion around the margin, we will deliver intraoperative radiation therapy. Or if we cannot remove the tumor, then this gives us an out with intraoperative radiation therapy for those patients. I would like to end by showing you the slide of my partners who I'm incredibly humbled to be surrounded by such talent and gifted people who have been so supportive as well and have actually led the field long before I have been even involved in. And with their help, we have an incredible program at the Massachusetts General Hospital in pancreatic surgery. We do over 200 pancreatectomies a year. Our mortality is down at 1%. Our median length of stay after Whipple is approximately 6 days. And this is largely in thanks to this spectacular team of pancreatic surgeons. And with that, I would like to thank you again for your attention today. And thank you for inviting us to be part of your symposium today.
Is there questions from here?
Professor Kotan, thank you for your excellent lecture. I learned a lot from your lecture. Actually, we began to have a conversion operation for patients with locally advanced pancreatic cancer after neoadjuvant. As you talked, we also have some patients that have remarkable pathology report, even the non-residual tumor cells or even small focus. But we still have trouble to predict the pathology report. As your talk mentioned, the outcome after neoadjuvant and surgery is the lymph node status. If patients have P ending, they have a much better prognosis than patients that have PM1 status. How do you predict the outcome, the pathology, the outcome before the conversion operation?
Yeah, that's a very good question. So I think for me personally, I would tell you that the answer, I think, still lies in the CA19-9. I think one of the most important predictors of how patients will do is CA19-9. I think what we need is more data to show more significance on that front. We are starting to see that now. In the MD Anderson study now, they were able to show that CA19-9 was probably the most important predictor of survival. I think if you have a trend of decline, it probably means that you've sterilized nodes. It probably means that you've shrunk any micrometastases or even killed them off. And you probably got a good result with the primary tumor itself. So at the end of the day, though, the only thing I would say about node positivity is it doesn't matter when you're doing the operation because it's not going to change what you do. I don't think that we would stop if we had suspicion that the nodal positivity was, or the nodes were positive compared to if the nodes were negative. So I don't know that it matters too much except for prognostication, but we will still do the same operation. We will still try and get the same lymph node basin, and the therapy has already been delivered before. So it doesn't matter because it doesn't change therapy, at least not now. Now, in the future, there may be a difference where we go back and say, okay, we should do more adjuvant therapy for some people. Maybe these are the node positive patients. Maybe these are patients with high CA19-9, or better still, is we can look at molecular markers like ctDNA or circulating tumor DNA, where we can then say that maybe those patients deserve more treatment for more aggressive cancers.
Thank you.
Thank you, Professor Qualton. Because of the time limit, we will proceed to next talk delivered by Professor Yuwen Tian. Professor Tian is our Chief of General Surgery, and he majors in pancreatic surgery. He leads a multidisciplinary team, including gastroenterologists, surgeons, and also the translational scientists. And he has developed some modification on pancreatic surgery. His personal pancreatic surgery right now is about 200 cases per year. So he has probably the largest series of pancreatic surgery in Taiwan. So let's welcome Professor Tian.
Thank you, Professor, for the nice introduction. Good morning and good evening, ladies and gentlemen. Today I will talk about a new procedure that people over the splenic artery. Okay. Sorry, we have some trouble inside. Oh, 好，下一张。In spite of recent advancement in chemo, radio, and immunotherapy, surgical resection remains to be the only potential curative treatment for pancreatic cancer. However, the 70 to 85% of patients have recurrence after the operation. There were many reported factors influencing the postoperative recurrence rate. Among these factors, the surgeon has the potential to influence only extent of lymph node harvest and resection margin. In mechanistic thinking, the operating method will play the most important role in margin status and extent of node harvest. In tradition, choice of the type of pancreatectomy is based on tumor's location. That is, people operation with transection of gastroduodenal artery for right side, and distal pancreatectomy with transection of splenic artery for left side pancreatic region. Conventionally, people is performed with pancreas transected and neck just above the supreme mesentery portal vein. But for head region involve the pancreas neck, left wall extension of pancreas. But for head region involve pancreas neck, left wall extension of pancreas transection line will be needed to get a clear margin. As described by Strasberg, the maximal left wall extent of pancreas transection is at the right of the point. The splenic artery contacts the superior border of pancreas. And they denoted this procedure as the people at the splenic artery WASAD. More leftward extension of pancreas transection line over the WASA point demands excision of splenic artery, and traditionally will be followed by a total pancreatectomy with splenectomy. In spite needed for margin-nectar resection, many surgeons remained hesitant to perform a total pancreatectomy in fear of the associated insulin-dependent diabetes. But more and more studies advocate total pancreatectomy to obtain a margin-nectar resection because the management of DM has improved substantially with recently developed long-acting insulin formulation. However, recent systemic review of more than 1,000 patients showed overall quality of life after total pancreatectomy is affected adversely, particularly by the impact of DM-related morbidity. Therefore, a method to have a better pancreas transection margin clearance than FIPO and a better preservation of pancreas endocrine function than total pancreatectomy will be needed for resection of central located pancreas cancer. But it may not be necessary to convert a WASAD to a total pancreatectomy after excision of proximal segment of splenic artery and vein. As shown in Walsh's procedure, spleen preserving the distal pancreatectomy with excision of splenic artery and vein have been widely and safe to perform for decades. You can, after excision of proximal segment of splenic artery, retrograde the blood flow from the left gastroepiploic and short gauge vessel may also be sufficient for not only spleen but also for pancreas remnant. We denominate this procedure as FIPO over the splenic artery WASAD. Here we report 20 consecutive WASAD used for treatment of centrally located pancreas cancer. The technique is a procedure. Take this 69-year-old male patient, for example. Preoperative CT showed a centrally located tumor invaded both gastroduodenal artery and the splenic artery, and also the anterior surface of supreme mesentery and the portal vein. Therefore, we plan to transect the pancreas over the WASA point at the left side. In brief, the procedure is performed after entering peritoneal cavity and confirmation of no micrometastasis. The rest sac was entered by dividing the gastrocolic omentum outside the gastroepiploic arcade. In preparation of division of pancreas, we first mark the planned transection line, usually at 2 to 3 centimeters left to the WASA point. We then divide the proximal and distal splenic artery. The pancreas and the spleen were divided as a whole with a staple at the planned transection line. Once the pancreas and the splenic vein were divided, the anterior and right border of the supreme mesenteric artery were cleared, and the specimen was tailored only by the superior and the portal vein. The supreme mesenteric vein and portal vein were cross-clamped, divided, and then reconstructed. Pancreas stump was closed without the main duct reconstruction in the first 2 cases in concern of ischemia-related poor wound healing, but pancreatic jejunal cirrhosis anastomosis were performed for all subsequent 18 cases. Next. You can see we transect the pancreas at the body. Contrast enhanced CT performed 1 week after the operation showed well-enhanced pancreas and spleen remnant. Actually, the 6 of the 20 reported VOSA procedures were converted from VASA after positive frozen section of intraoperative pancreatic margin. You can see the additional resection with a segment of splenic artery. Patients have this procedure will enter into a registry approved by the IRB of our hospital. A pathology, the Professor Zheng Yuming read oral pathology and defined a positive microscopic margin as cancer cell being at or within 1 millimeter of the margin of the section. CT image performed before and at 1 week after operation were analyzed by one radiologist, Professor Chen Bangbin. He will calculate the functional residual volume by measuring all normal pancreatic tissue preoperatively, excluding the area of pancreatic cancer and residual pancreatic tissue postoperatively. Evaluation of change of glycemic status was performed with blood tests at 1 day before and 3 and 6 months after the operation. Demography of the 20 started patients were listed below. The median age of this cohort was 67 years. 65% of patients were male. SMPV resection without splenic vein reconstruction was performed in all 20 patients. The median operating time and the blood loss were 289 minutes and 700 cc. No reoperation has been performed because of infection of pancreas and or spleen. There was one reoperation for removal of the inadvertently stable NG tube by staple used for gastrojejunostomy anastomosis. No readmission within 30 days after operation. The median length of hospital stay after operation was 21 days. No in-hospital days or days within 6 months after operation. We have one. You can see the CT performed 1 week after operation show well enhanced pancreas and spleen remnant in all 20 cases. You can see. The pathology data showed 11 patients, 55% have oral margin clearance more than 1 millimeter. But all 20 studied patients has pancreas transaction margin clearance more than 1 millimeter. The mean number of resected lymph nodes is 29, and the mean number of positive lymph nodes is 2.好像弄到最后了。哎，上去。 glycemic change after VOSAD. 6 months after VOSAD, DM medication in this 20 studied patient is insulin NTUH. Oral hypoglycemic agent in 6, none in 12. Since the section extent of VOSA is between the VASA and the total pancreatectomy, we compare it with 18 VASA and 26 the total pancreatectomy performed for treatment of pancreatic cancer at our hospital in the last 3 years. There is no significant difference in demography among 3 groups. There is also no significant difference in operating time among the intraoperative blood loss, gastric and major complication rate among 3 groups. No significant difference in margin status and number of positive nodes between VOSA and total pancreatectomy. But compared to VASA, VOSA had a higher rate of R0, more than 1 millimeter at the pancreas-parenchyma transection margin. Glycemic change after VOSA is as good as that of after VASA. A retrospective review of more than 700 patients who underwent a VOSA operation showed only 1.9% patients required the operation because of splenic infection. Compared to VOSA's operation, VOSA procedure demands the additional resection of right gastric and right gastroepiploid artery, with the left artery preserved as the sole source of blood supply to stomach, distal pancreas, and spleen remnant. However, compared to VOSA's procedure, VOSA procedure has longer distal segment of splenic artery preserved, which in turn allows preservation of more communication vessels between left gastroepiploid and splenic artery. This may account for the successful preservation of distal pancreas and spleen remnant in our initial 20 consecutive patients after VOSA. Compared to conventional PD and VASA, the VOSA procedure has pancreas transected at the more distal pancreas, which will lead to a small main pancreas duct orifice on cut surface and makes the reconstruction more difficult. To our surprise, only 1 of the 20 patients with pancreas duct reconstruction had a clinical level than the POPF. The fact the higher ID cell density, compared to conventional PD, the VOSA heads will have a small volume of pancreas remnant. Therefore, less so the exocrine cell mass in pancreas remnant after VOSA may account for the low POPF rate. Although functional residual volume of pancreas remnant after VOSA is small, ranging from 30.6% to 56.6%, glycemic status is surprisingly good. We attribute this excellent preservation and endocrine function after VOSA procedure to first, the regional difference in eyelid distribution in human pancreas. Found that eyelid distribution density is 2-fold higher in the tail compared to the head and the body region. And the second, remove of the diabetogenic pancreatic cancer tissue. Penolat reported that pancreatic cancer secretes diabetogenic product, which causes DM in nearly half of the patients and often resolved after tumor resection. And in one of our studies, reported that change in the food passage route after pancreatic duodenectomy is quite similar to that after loose and wide gastric bypass operation. Both have food bypass duodenum directly into distal jejunum and have DM resolution after operation. There are a lot of surgical margin of PD specimen. Among these, the neck margin is the most amenable to surgical intervention, as the surgeon can often take additional pancreatic body parenchyma in an effort to create this margin after intraoperative frozen section analysis. Therefore, during people for pancreatic cancer, a frozen section of neck margin is typically assessed. And if positive, additional pancreas is removed to achieve an R0 margin. However, the analysis of the effect of this practice in more than 1,000 patients showed additional resection to achieve a negative neck margin after positive frozen section is not associated with improved overall survival. Possible explanation for failure of this practice include a positive neck margin is a marker of poor tumor biology in patients with pancreatic cancer. Second, some of the paraffin sections are zero in the 72 patients in this study were not paraffin section are zero more than 1 millimeter because another study published in Surgery reported that the conversion of PD to total pancreatectomy instead of additional resection to achieve an RN resection improves survival in patients with isolated neck margin. But isolated neck margin, positive margin means all other margins are negative. Therefore, in the face of positive the frozen section, the neck margin during pancreatic duodenectomy, if all other margins are negative, we should choose total pancreatectomy. But if one or more other margins are positive, we should choose additional resection. The problem is that it's difficult or even impossible to ascertain the status of other, especially SMA margin during operation. We believe that VOSA will be the best choice for this difficult situation because it has a better pancreas transaction margin clearance than VOSA and a better preservation of pancreas endocrine function than total pancreatectomy. Conclusion. In our initial 20 case showed VOSA can be safely performed and the pancreas endocrine function can be well preserved after VOSA procedure. Therefore, in consideration of VOSA, most total pancreatectomy for pancreatic cancer will be unnecessary when all other margins are negative or even harmful when one or other margins are positive. Thanks for your attention.
Thank you, Dr. Tian, for your excellent talk. Sorry about the technical problem, and I hope that you all see the important slides at least. So any questions from the audience here and all our MGH colleagues?
So I have a question. This is Keith Lillamo in Boston. I want to congratulate Dr. Tien for a nice presentation and some excellent results. We all, as you acknowledge, it is the one margin that we can easily revise, and this technique certainly describes an excellent technique. This technique reminds me a bit of the operation we do call mid-segment pancreatectomy, where we take out the neck of the pancreas and save the head and save the body and the tail. And one of the things that we've done with that and that's for benign lesions usually, one of the things we've done in the reconstruction for a mid-segment pancreatectomy is anastomose the tail of the pancreas into the back wall of the stomach as a pancreaticogastrostomy. I believe you describe all of your cases being pancreaticojejunostomy. Have you considered trying the pancreaticogastrostomy? That tail of the pancreas oftentimes flips up nicely and then can invaginate well into the back wall of the stomach, and it's a little easier technically sometimes to do than to really do a good anastomosis far to the left of the celiac axis.
Thank you for a nice question. Because we also performed the central pancreatectomy, and after central pancreatectomy, we also performed pancreaticogastrostomy for the reconstruction of pancreas stump. But after VOSA, because VOSA transects the pancreas at the more distal, but if you perform the pancreatic gastrostomy, you must mobilize the pancreas stump for at least 3 to 5 centimeters. And it's difficult to perform the pancreatic gastrostomy in the after VOSAD. Besides, in the VOSAD, we dissect the right gastric, right gastroepiploic, and the splenic artery. And we worry about the stomach, the blood supply to the stomach. That's why we do not use the pancreatic gastrostomy for reconstruction. But you are right. When you transect the pancreas at more distal and more distal, the pancreas duct on orifice on cut surface will have small caliber. It's sometimes to perform the pancreatic jejunostomy anastomosis, it will be easy. But because we worry about the blood supply to the stomach and the short segment preserved, so we use the pancreatic jejunocirrhosis anastomosis.
So, any other question? If not, then I hand it over to Dr. Tanabe to introduce our next speakers.
Thank you, Professor Wong. I am pleased to introduce Dr. James Cusack. Dr. Cusack is an associate professor of surgery at Harvard Medical School. He's the director of the MGH Peritoneal Surface Malignancy Program and director of the MGH Global Surgery Initiative. He received his undergraduate education at Dartmouth College and his medical degree from Emory University. He trained in general surgery at the New England Medical Center here in Boston before completing a fellowship in surgical oncology at MD Anderson Cancer Center. His initial faculty position was at the University of North Carolina Department of Surgery, and we were fortunate at MGH to recruit him to our faculty in 2000. Dr. Cusack ran a translational research laboratory and was a member of the team that discovered that NF-kappa B inhibition sensitizes cancer cells to chemotherapy. He's the author of over 100 publications in the fields of surgical oncology and basic science. Dr. Cusack's current research interests are studies of the relationship of diet to microbiome and colon cancer tumorigenesis, and detection of peritoneal surface malignancies using cathepsin-activated fluorescent nanoparticles using near-infrared imaging technology. The title of Dr. Cusack's talk today is Cytoreduction and HIPAP for Metastatic Colorectal Cancer. James.
Thank you very much, Dr. Tanabe, and thank you, Dr. Huang, and the organizers for the opportunity to share this talk with you today. I'm going to share my screen, see if we can pull up my talk here. And do my slides appear pretty good shape? Okay, excellent, thank you. So this is a somewhat of a controversial topic. We've been searching for answers to figure out what the exact benefit of using hyperthermic intraperitoneal chemotherapy to promote better responses to complete cytoreduction, i.e. removing all metastatic disease involved in the peritoneal cavity when it's derived from colon cancer that has spread into the belly cavity. So I'm going to focus my discussion and organize this in terms of just briefly describing what does that cytoreductive surgery entail, talk about how we try to assess this both from a preoperative standpoint as well as from an intra-abdominal standpoint. We're going to talk a little bit briefly about patient selection and what we understand from different types of spread of disease from colorectal cancer. And then focus to a greater degree on the morbidity and mortality of this type of procedure, because this has been some of the controversial aspects of this approach, particularly as perceived by our colleagues in medical oncology, who've looked to the traditionally high rates of morbidity and mortality associated with combining cytoreductive surgery for peritoneal carcinomatosis when it is administered in conjunction with hyperthermic intraperitoneal chemotherapy. We'll also look at some of the recent data still, which is about to come out in publication form, but has been presented nationally from both retrospective studies, a few prospective randomized clinical trials, as well as a more recent study from Europe, which continues to draw questions about the specific benefit of hyperthermic intraperitoneal chemotherapy. And then we'll finish by focusing on some of the future directions that we might be able to look forward to. If we look first just to seeing how do patients who have different types of metastatic disease from colorectal cancer, we see that patients who have peritoneal disease that is spread to the abdominal cavity tend to do worse than patients who have either lung cancer metastases from colorectal cancer that is resectable or otherwise, or liver metastases. We've seen dramatic trends and improvements in surgical resection of liver metastases. We see longer-term outcomes from a resection of lung metastases, and patients who have peritoneal spread of disease typically do worse of those three types of patient populations. And then just in terms of just giving you an example of the types of patients that are referred to us for consideration of cytoreduction, I just want to point out on this patient of mine that we resected early on in our program, which we opened up in 2011. These patients tend to have the concentration of peritoneal disease in certain regions. In females, the ovaries may be significantly involved. These tend to be sites where you have essentially a safe harbor, if you will, of cancer cells, and they're able to grow within the gonads. You also see a predisposition for the tumors to grow along the peritoneal surfaces, up along the right hemidiaphragm, also involving the surface of the liver, particularly on the right side, less so on the left side. But as you can see in this case, you see a lot of extensive involvement of both the spleen and the left hemidiaphragm. So the scalloping that we sometimes see along the right side and the right hemidiaphragm is matched also by peritoneal spread of disease. Patients who have extensive involvement of loops of small bowel raise questions about whether those patients can undergo a resection. Obviously, if there's too extensive an involvement of the small intestine, then that patient may not be amenable to complete cytoreduction. As you can see in the photograph here, this patient's small bowel seems to be uninvolved. However, there is disease involving the omentum, and obviously the right and left ovaries are very enlarged with metastatic disease. So when these patients are assessed for surgery, we're looking to see if we can ultimately achieve a complete cytoreduction, which means removing all tumor, leaving nothing left less than or nothing greater than 0.25 centimeters in size as residual disease. It is felt that hyperthermic intraperitoneal chemotherapy can penetrate small nodules, small deposits, for instance, if they're involving the serosa of the small bowel or the mesentery of the small bowel that cannot be surgically removed, that they may be amenable to treatment with the intraperitoneal chemotherapy. The resections that are performed for these patients involve removing all sites of disease, bowel resections, the large intestine and colon are amenable to complete or total colectomies if necessary. Omentectomy, another frequent site of involvement of disease that can be performed, cholecystectomy. Less likely to pancreatectomy, however, splenectomies are frequently performed. Peritoneal stripping, the entire peritoneum may be stripped from the peritoneal cavity to remove disease. And these are all different types of procedures which runs the spectrum of general surgical operations, sometimes all of which need to be performed in a single setting. And obviously, this all adds up in terms of the potential for toxicity related to surgery. Adding heated intraperitoneal chemotherapy obviously increases the risk of having complications related to that surgery. We use a peritoneal carcinomatosis index, or PCI, to sum up the extent of disease so that we can compare one group of patients to another and try to get some sense of how these patients do based on the extent of their disease. I find personally trying to assess this PCI preoperatively is limited, other than if we do see evidence of small bowel involvement. Oftentimes these patients are not amenable to complete cytoreduction. And as I mentioned before, another staging system is completeness of cytoreduction. If we see that the patient has disease that's going to remain after the surgical resection, that amount of disease would preclude the patient from undergoing complete cytoreduction. So if remaining disease is over 0.25 centimeters, that is not a complete cytoreduction. Patients who have less than that as remaining disease, or ideally patients who have no residual disease, are those who we think will do the best. And I'll show you some data to support that. So these patients, obviously, we feel that the patients need to be in ideal, as much as possible, performance status before surgery. As Dr. Kadan had mentioned, prehabbing patients is really critical in these patients. Oftentimes they may be considered for systemic therapy before they undergo surgery. And in those cases, we can spend a lot of time, if they're overweight, which is our problem in the US, for many of these patients, we can try to improve them. And I ask patients to lose 1 to 2 pounds per week going into surgery. And oftentimes that may be up to 3 to 6 months of preparation, involving increased physical activity and training, and also just weight loss. If the patients are very debilitated, similarly focusing on physically rehabilitating them and increasing calorie intake may be the issue. Patients who have certain types of cancer from the colon do more poorly than others. That's a general perception. The patients who have signet ring cell features of their tumors tend to do worse. Those who have evidence of intraparenchymal liver metastases or lung metastases are generally excluded. There's some exceptions to that. If they do have minimal liver involvement that might involve a lesser extent of a liver resection, might be candidates for combining those procedures with a cytoreduction and HIPEC. But obviously, if there's an extensive small bowel involvement, multifocal disease, extensive serosal involvement or mesenteric involvement, those patients may not be candidates for this. I'd also say that if there's evidence of biliary obstruction, bile ducts are dilated, that would also raise a red flag. Those patients are frequently not candidates for complete cytoreduction. Long segment ureteral obstruction, if it's unilateral, those patients may be amenable to either a ureteral resection and reconstruction if it's a more distal area, but if it's up high, those patients may need to undergo a nephrectomy, and the patients therefore need to have excellent renal function if that's to be considered. So if we look at the completeness of cytoreduction, I always think of when patients are asking me, well, what should I expect from surgery? I said, if we can get everything out, that gives us our best chance for the patient's outcome, a best chance of having a long-term outcome or benefit from the surgery. And so you can see, again, if we have patients who have no residual disease, those patients do much better than if there's significant volume of disease left at the completion of the surgery. And by using the PCI index, similarly, the patients who have a very low PCI, very few quadrants involved with disease, very small volume of disease, those patients are going to do better as well. The apparatus that we use in surgery, there's 2 different techniques that are employed for this. Paul Sugarbaker, who has really been the pioneer in this, although I would just put one historical notice that cytoreduction for malignancy was first described here at Mass General about 60 years ago for the purposes of rendering a patient free in the setting of ovarian cancer. So this is something that has been around for a long time. Dr. Sugarbaker added chemotherapy as a means of improving outcomes to cytoreduction or surgically removing the disease. And I'd say historically, this is where the controversy has come from, is because there's been a high rate of complications associated with these surgeries. When we started this program 10 years ago, the mortality rate, perioperative mortality rate, was someplace between 2 and 6% for the procedures, and patients had long hospital stays and lots of complications. So it was very important to go into this type of procedure confident that you could minimize the negative impacts of the procedure on the patient outcomes. The way these are done, there's various ways to administer the chemotherapy. It can be 30 to 120 minutes of chemotherapy administration. Typically, the core temperature is maintained below 39 degrees as we do in ours, but the temperature of the patient's intraperitoneal cavity may be up at 42 degrees or in some centers 43 degrees centigrade. We use a cooling blanket to keep the patient's core temperature down. If necessary, if they're approaching 38.5 to 39 degrees centigrade, we actually do pack the patients in ice to keep their core temperature down. And then we just generally agitate. This is called a closed technique. The technique by Paul Sugarbaker is an open coliseum, where actually the abdominal cavity is open and he essentially swirls chemotherapy or hot chemotherapy in the peritoneal cavity during the course of the intraperitoneal portion. And that would be done at the completion of cytoreduction and prior to reconstruction of any of the intestinal tract. Again, we use different types of external circulator pump that heats the chemotherapy and fluid. We usually use about 3 to 4 liters in the circuit, 2.5 of which are inside the peritoneal cavity at any one time. And again, we run, in our center, we run this for 90 minutes of perfusion using typically mitomycin C, but also oxaliplatin, carboplatin, cisplatin have been used in different settings for different diseases. When you're considering these types of procedures, I think it's really important to recognize that there are a variety of different teams that are involved with this, from nursing, the pharmacy, anesthesia teams, critical care teams, a perfusion team. All of this needs to be tightly controlled, and a lot of communication needs to go into making sure these patients have an optimal outcome. The issues that may be related to the chemotherapy alone may be toxicity related to the chemotherapy, nephrotoxicity, neutropenia, bone marrow suppression, hair loss, all those are potential complications related to the chemotherapy. As I mentioned, these operations are extensive. They can last a long time. They can be 8 to 12 to 14 hours, and some patients have extensive disease. While the morbidity usually is around 20% at large, high volume centers like we have, the morbidity may be along the lines of 20%. And this may involve things like anastomotic leak, infections, pleural effusions, pneumonias, and then again, related to the chemotherapy, maybe along the lines of bone marrow suppression or renal failure. Mortality rate really should be in the range of 2% or less at the high volume centers. Centers getting started may have problems with this type of challenge initially, and there have been a number of programs that have opened up in the United States, which were then subsequently closed or could not open because of the concerns about having a high mortality rate associated with these types of procedures. The length of stay, as you'll see from some of the data I'll present, may range from 1 to 2 weeks, and that should improve over time as well. The recovery for the patients, though, does take months. I just want to point out some of this was a study from the University of Pittsburgh in terms of how long does it take a center. This is a center of several surgeons who did these procedures. How long does it take them to become proficient at performing a complete cytoreduction? And there's definitely a learning curve to this. And what they found is that just the likelihood that any one case would be able to achieve a complete cytoreduction took about 80 cases. When we looked at similarly how to decrease the morbidity associated with the procedures, that took a higher number of cases, up to about 180. And similarly, this length of the ICU stays seems to taper off again around 80, 90. The hospital stay seems to sort of level out in terms of the length of the hospital stay after a big procedure like this, someplace around 80 to 90. And so these are very interesting studies just to really graphically identify what that learning curve looks like. And similarly, when you look at these different types of the disease likelihood of disease progression or overall survival, again, you see that there's a good oncologic outcome that's achieved someplace for the average patient going through these type of programs, someplace in that 80 to 90 range for these types of procedures. And that's been borne out by a couple of studies. So generally, the completeness of cytoreduction, the morbidity, mortality rates may improve over time, but obviously there's a long startup time. Approximately 180 procedures are needed to improve operative outcomes, and about 90 procedures are needed to be performed by any one center to achieve oncologic outcomes that are on par with the expectations. So it takes some time. If we look at just our early experience from the first 5 years of running our program, in the area of the colorectal surgery. Actually, this is all comers. So this is both primarily appendiceal tumors, but it also includes colorectal, mesothelioma, a smattering of gastric cancers, but primarily appendiceal, as you'll see in a second. We looked at our outcomes, and we found that our median PCI, which is about average for most large series performed, was about 14.5. We achieved completeness of cytoreduction at about 88%. That means CC 0 or 1. Estimated blood loss for most of these was about 300 cc's. 14% required transfusions. Most patients were extubated. ICU stay was about 2 days, and we've actually decreased this and eliminated the ICU stay in the subsequent cohort of patients particularly since the pandemic, actually. Median hospital stay in our center is about 8 days, as opposed to these longer periods of time that you'll see in a second. 30-day readmission rates about 17%, but both our 30-day and 90-day mortality rate were 0%. So our efforts to really organize our team in advance we were able to achieve acceptable perioperative mortality and morbidity. As I mentioned, most of our tumors that patients that we take through cytoreduction and HIPEC are in the area of appendiceal tumors of one variety or another. These tend to be spread throughout the peritoneal cavity. About a quarter of these patients have colorectal cancer, but also we have a predominance of mesothelioma, ovarian cancers in some of these patients. That's another area where we have prospective data to support the use of cytoreduction and HIPEC for that patient population. In terms of does the HIPEC, intraperitoneal chemotherapy, help and add benefit to surgical resection or these radical resections? That has been the difficult question to ask. Early data showed that there was encouraging results, and I'm going to just delve into this a little bit more. There were several studies that were performed early on that looked at the use of combining cytoreductive surgery and HIPEC. They all showed good outcomes compared to what we might expect, around 20 months or less for median survival for patients who have peritoneal spread of disease. And then these patients, they had a much better outcome than what would be expected. Similarly, median survival for patients undergoing these combinations. This was done in the era when we didn't have good 3-4 drug regimens of chemotherapy. And so the criticisms for many of the earlier studies is that it wasn't compared to contemporary chemotherapy, or again, multi-agent chemotherapy, and therefore unfair comparisons. And so some of the other ones that were prospective randomized studies, good outcomes in terms of longitudinal data, following these patients out for a long time. They saw, again, some suggestion of benefit, but again, these were done prior to the era of effective triple agent modern therapies that involve using either oxaliplatin or CPT11 or irinotecan type combinations. But they were encouraging, and they suggested there was a potential benefit for adding HIPEC. So a lot of the emphasis and focus of centers doing these type of combinations of cytoreduction and HIPEC really were focused on this Prodigy 7 study that was performed in Europe. Multi-center study done by experienced surgeons looking at a prospective randomized trial of patients to receive either HIPEC or without HIPEC, but undergoing similar types of pre-treatment and surgical debulking down to less than 1 millimeter. So good aggressive surgical guidelines and targets for doing the surgery and then randomization to one of these two types of treatments. In the inclusion criteria, these patients had to have colorectal cancer, no hepatic or pulmonary metastases, PCI less than 25, so those are smattering. The patients had intraperitoneal disease up to a PCI of 25. Macroscopically complete R0 or R1, so the minimal residual disease was the criteria for inclusion in the randomization. They needed to be treated, the patients needed to receive systemic therapy up to 6 months, and they were no patients were to be previously treated by HIPEC. In terms of the different combinations, there was the target was, or the intraperitoneal treatment was oxaliplatin. Some of the criticisms from the US was around this 30 minutes. Most centers in the US would use 60 or 90 minutes or more. Our center uses mostly mitomycin C for 90 minutes. And then this was also administered with intravenous therapy at the time of surgery during the HIPEC administration. The mortality rate at about 30 days was about 1.5%. Total mortality rate for the study was 2.6%. This data was presented at ASCO in 2018. It is really in press, but I don't think it's actually, we have a publication date, but this data is supposed to be coming out imminently. It's a publication, but it's taken about 2 years to get it here. The morbidity of the operation itself, there was some, and looking at just HIPEC versus non-HIPEC, we had a higher rate of complications related to the HIPEC group. This was not statistically significant here. However, in the mortality rates, excuse me, the morbidity at 60 days, so the longer term complications was actually a little bit higher and was deemed significant in this patient's clinical study. The hospital stay, interestingly, I just mentioned that our hospital stay the median is about 8 days. In the HIPEC group, this was 18 days hospital stay, 13 days for the non-HIPEC group. So significantly longer than in our experience here. This is the key take home from this study, is that everybody was trying to figure out, well, is there a benefit to patients receiving the HIPEC? And in this particular study, which was powered to assess whether there was a benefit or not, showed that there was no significant difference in the two groups receiving HIPEC versus non-HIPEC as it was administered in Europe for the 30-minute oxaliplatin infusion. And it was 41.7 median survival in months versus 41.2, 1 year and 5 year survival also similar in these two groups. In terms of the relapse-free survival, similarly, no significant difference between the two groups. You can see the curves are pretty much similar. There was one forced plot. This is a subset analysis looking at the patients from the standpoint of were there certain groups of patients that might, or subsets of patients that might do better with HIPEC. Now, the study was really not powered. This wasn't one of the primary objectives at the outset of the study to determine this, but when they were teasing through the data, they found that patients who had intermediate volume of disease in the 11 to 15 range for a PCI seemed to have done better in terms of undergoing HIPEC than patients who had either had this larger number of PCI. And there was no significant difference in those who had less disease at the time of surgery. For the entire population, as you can see in this study, similar to other studies, PCI is correlated with outcome. In the 11 to 15 range, though, those who had received HIPEC versus those that did not seem to have a significant survival advantage. Again, the study wasn't powered to address this particular question, and this study has been criticized because of this subset analysis not being a completely valid way to assess this. Nonetheless, it was a curious finding and suggested that maybe there was something more to look at these in this particular patient group to see if there's a potential role of HIPEC. So in terms of morbidity, postoperative safety outcomes were comparable between the two groups. There was mortality rates that were similar. Long-term complication rates were worse in the HIPEC group. 60-day morbidity was 21% for HIPEC and 13.6% in the non-HIPEC group. And obviously there was a much longer hospital stay, as we identified, in the patients who underwent HIPEC. So the conclusions for this study is that cytoreductive surgery certainly improves overall survival. So if we compare this to the typical outcomes of expecting 18 to 20 months median survival, 41 months of survival in this group was somewhat shocking to everyone who looked at this study, in that there was a significant, much higher benefit from undergoing aggressive surgical resection of peritoneal carcinomatosis. Yet adding HIPEC to an aggressive surgical resection did not seem to benefit in this study as it is used. HIPEC using oxaliplatin, therefore, at 30 minutes, if administered at 43 degrees, did not seem to improve overall survival compared to patients who underwent just the cytoreduction alone. So again, in terms of looking for future directions, this is a very interesting group. It's the patients who have intermediate volume of disease. Maybe they'll maybe benefit from additional HIPEC. Maybe we should be considering different types of treatment intraperitoneally. Maybe it should be a longer period of exposure to treatment. So this is all room for opportunities to explore this anew and how to address this. I would just say in terms of how the U.S. Teams, there's now, when we first started our program, there's probably maybe 20 centers that did this in the country. There's now over 100 centers that do this type of procedure. So it's been expanded dramatically across the U.S. I'd say most large volume centers do have reasonable and acceptable overall, I'd say, perioperative morbidity and mortality. However, again, we still haven't answered definitively whether the HIPEC administered as we do in the US has an impact on terms of the patient's outcome. So we need to figure out what to do. There are a variety of different variables we could look at. And I would just compare this in terms of, does this make a lot of sense? If we look historically at, infusional 5-FU versus bolus 5-FU, you've heard I've heard about this in terms of our medical oncology colleagues dealing with this issue in terms of pancreatic cancer, colon cancer, how this made a difference. So I think when we consider it doing something different that may just mean longer period of exposure time during surgery, it actually may be significantly different. The only way to address this is in the context of a clinical trial, a prospective randomized clinical trial. In the US, we have organized ourselves in terms of our Eastern Cooperative Oncology Group to try to figure out a way to answer these other questions, whether longer dwell time. Currently, the draft of the multi-institutional center is looking at 120 minutes of exposure using mitomycin C, a similar approach to how we do it here at MGH currently. I'll also note that since there's been such an explosion of different centers across the country using this, we were able to organize ourselves into a Chicago consensus conference that was organized by Karen Taraga at University of Chicago to look at a variety of different peritoneal carcinomatosis syndromes, so gastric cancer, appendiceal cancer, colon cancer, ovarian cancer, a variety of different scenarios to see if we could develop some algorithms and to guide the treatment and management of patients. And these were just published in the Annals of Surgical Oncology and Cancer, sort of jointly published in 2 different journals and these various different publications to look at how to best manage these using the consensus. This is all not data driven. Some of it is by practice and preference, but it does identify some of the opportunities to evaluate these different questions in the future. But there's a lot more to be done. So I want to thank you once again, the organizers, for allowing me to share my perspective on cytoreduction and HIPEC, and I'd be happy to take any questions if there's time. Thank you.
So thank you. Is there any question from here? Yeah, Dr. Lee.
Thank you so much, Dr. Kusa, for your so comprehensive review, and congratulate you for your good data from your hospital. You just mentioned for intermediate PCI, probably HIPEC have some benefit for the patient. And my question is there any indication for the patient for the second time HIPEC if he received the first cytoreduction and HIPEC, and after that it is recurrent? In what situation will you perform the second time? Thank you.
Well, thank you very much for that question. It's an excellent question, and I think that the answer of repeating hyperthermic intraperitoneal really has to do with the toxicity that is related to the treatment. I don't know of any patients that have been treated more than 3 times with hyperthermic intraperitoneal chemotherapy. One of my patients who had mesothelioma over the span of 6 years underwent 3 procedures that were involved cytoreduction and repeat HIPEC with different agents on 2 of those occasions. Each time you go back, the operative intervention is much more challenging, which is with extensive adhesions throughout the abdominal cavity. Not everybody, every patient will have those type of extensive adhesions, but that's something you should expect. And the toxicity on the patient, the difficulty in terms of the bowel function recovering Typically, I tell patients it'll take 3 weeks to 3 months for their bowels to function normally after HIPEC. That can take its toll and take a longer period of time for recovery on the patients undergoing repeat HIPEC. And one patient of ours that we shared who had actually urachal cancer that Paul Sugarbaker and I shared, he had done 2 cytoreductions and HIPEC'd on the patient. Patient also had radiation therapy. And his wisdom was, do not consider doing a 3rd time repeat HIPEC. We were with just surgical cytoreduction able to render the patient disease-free. And for urachal cancer, that patient is now the longest surviving patient with now 10 years under his belt from one of our first patients. But 10 years, actually started before, 12 years out because he had the first 2 HIPECs before we opened our program. But he has no evidence of disease. So in some diseases, this clearly makes an impact, but the toxicity was really profound. He had white scar tissue fibrosis throughout his abdominal cavity. And when he came back for a gastrectomy, it's his last operation that I did, it was just very difficult to find the stomach amongst all the scar and fibrotic tissue. So it can be done in select patients. I think it's optimistic to think a patient will come back for it, because typically when they recur, they oftentimes will have pain, they'll have multifocal serosal and mesenteric involvement. And so while we say it's feasible, it's practically speaking, it doesn't happen very often. Thank you for your question.
Thank you. Okay, Dr. Chen.
And I want to ask a question about, do you perform the early postoperative intra-abdominal chemotherapy, like just the Sugarbaker's early protocol? He will suggest the early postoperative chemotherapy for 5 days. Do you do these things?
Thank you very much for the question. Early postoperative intraperitoneal chemotherapy is done at a few centers. I wouldn't say that it's caught on broadly. The data have been somewhat mixed and not as compelling as I'd like to see. Dr. Sugarbaker is a fervent supporter of it. However, the data have not been real crystal clear in terms of the additional benefit. And as you just saw from the data, first demonstrating a benefit from the HIPEC is one challenge that we've not completely addressed. And I might just note that for the way we've dealt with the data that has been presented out of the Protege 7 study is that for patients who have colorectal cancer and that have come to surgery for cytoreduction, if they've benefited from systemic therapy up front, we're not giving HIPEC at the time of surgery. Other centers have used the reverse logic. I think Dave Bartlett is one who was at Pittsburgh and just relocated recently. He uses the reverse logic. If they respond to systemic therapy before surgery, he would give them HIPEC. But I think the morbidity and mortality associated with giving the treatment is clear. The additional benefit from receiving HIPEC is not clear. And similarly with early postoperative intraperitoneal chemotherapy, we just don't have very strong data to support its use. So we do not use it at our center.
Thank you, Dr. Kusak. I think because the time is limited, I just, as Professor Kusak will be giving us another lecture in the March when the annual meeting of Taiwan Surgical Association. So prepare your questions, and then next time we will see you, because the time is a little bit late. So I think we better move on. Thank you. Thank you very much, Professor Kusak.
Okay, I'm very pleased with the opportunity to introduce our next speaker, Dr. Heidi Ye. Dr. Ye received her undergraduate education at Harvard College and her medical degree from the University of Pennsylvania. She completed a residency program in general surgery at Penn before completing fellowship training in transplant surgery there. Her initial faculty position was at the University of Pennsylvania, and we were fortunate to recruit her to MGH, where she now serves as an associate professor of surgery at Harvard Medical School and Associate Director of the Mass General Hospital Liver Transplant Program. Dr. Ye serves on the Executive Committee of the American Society of Transplantation. Dr. Ye's research program has been funded continuously by the National Institutes of Health since 2011, which really is a remarkable feat. Her research interests include ex vivo liver perfusion, development of a dynamic online method to assess liver viability during perfusion, strategies to improve liver regeneration, and disparities in access to transplantation. She's published over 100 articles. She really is a wonderful physician and an amazingly gifted surgeon. The title of Dr. Ye's talk is Ex Vivo Machine Perfusion in Liver Transplantation. Dr. Ye.
Thank you so much for that wonderful introduction. Let me see if I can share my screen here. Is that working? Okay.
It's working.
Okay, great. Thank you very much for the opportunity to speak today. It is an honor to be part of this symposium, and I wish that I could be in Taiwan in person. This is going to be quite a changing topic. I am a transplant surgeon and will be talking about technologies for perfusing livers outside the body that have come into increasing clinical application in liver transplantation. Liver transplantation is the only cure for end-stage liver disease and unresectable hepatocellular carcinoma, and I think that will be the only mention of cancer in my talk tonight. Liver transplantation is very different in the United States than in Taiwan. Taiwan has robust living donor liver transplantation with over 80% of transplanted livers coming from living donors, and has developed advanced technical innovations and immunologic protocols for performing these complex operations safely for both the donor and the recipient. In the United States, we are dependent on deceased donors, and less than 5% of our transplanted livers come from living donors. We transplant only about half the wait list each year, and 15 to 20% of the wait list dies before a liver becomes available. At the same time, a large number of donor livers are discarded for poor quality. While our interest in machine perfusion arises from our need to expand the deceased donor liver pool, I hope that I can also demonstrate the potential of ex vivo liver perfusion for developing other transplantable liver types and the treatment of liver disease before patients even reach the point of needing a transplant. The current standard in deceased donor liver transplantation is to flush the organs with ice-cold preservation solution, store them on ice for transport from the donor hospital to the recipient hospital. Although this was a major advance in organ preservation decades ago, there is still ATP decay even at this low temperature. As you can see here along the blue line, the amount of ATP drops by 50% within an hour. And we have shown that ATP levels strongly predict how well the liver will function after transplant. Instead of packing the donor liver on ice, machines have been developed to perfuse organs with oxygen, nutrients, and in the case of lungs, even ventilate. Organs can function on pump just as they do in the body, the heart beating, the liver producing bile, and the kidney making urine. There are many temperatures at which ex vivo machine perfusion can be done. The first to be clinically reported in 2010 is hypothermic perfusion at 0 to 4 degrees Celsius. The first report shows evidence that even at these cold temperatures, some ATP regeneration occurs with protection against reactive oxygen species, but functional assessment at this temperature is limited. Subnormothermic perfusion occurs at room temperature and has the advantages of not requiring heating or cooling systems. It is associated with significant metabolic activity and ATP regeneration, and so it allows us some functional assessment, but it has not been in clinical use. Normothermic perfusion is body temperature perfusion and is the most physiologic. The main concern with normothermic perfusion is the potential for warm ischemia time if there is pump failure. In contrast, if a hypothermic pump fails, the system reverts back to static cold storage, which is our current clinical standard. Normothermic perfusion is in fairly wide clinical use, and I will discuss the results of some clinical trials in a minute. Hyperthermic perfusion, or up to 40 degrees, has also been investigated for the potential advantages of activating the heat shock response pathways and for superfast metabolism, but it is not yet in clinical use. There have been a number of gradual rewarming protocols developed based on the theory that sudden temperature changes are detrimental to livers, and that each temperature perfusion carries different advantages that the liver can be exposed to. Only a very small series of livers have been transplanted clinically, and it is not clear that the extra logistic complications of gradual rewarming protocols carry enough benefit to be worthwhile. I will spend the rest of my talk primarily on normothermic perfusion, as it is the most commonly used and also has the most potential for broader application. There have been 2 large randomized controlled trials of NMP, one in Europe and one in the United States. The basic design of both was that livers preliminarily accepted at offer for transplantation were randomized to either normothermic perfusion or static cold storage. The final decision to transplant organs was made after observation during perfusion or at procurement in the static cold storage arm. Analysis of the European study results have been published, and they found increased organ utilization rates with perfusion and decreased rates of early allograft dysfunction. The US study has released only preliminary results so far, but they also found decreased rates of early allograft dysfunction. Notably, they also saw significantly lower rates of ischemic cholangiopathy, a complication that sometimes leads to transplantation even with otherwise normal liver function, because the bile ducts are more sensitive to ischemic damage than hepatocytes. One of the big debates in normothermic perfusion is whether organ utilization increases because having functional data increases surgeon confidence in the organs, or because perfusion actually improves liver quality. To help answer that question, we have taken livers declined for transplantation and put them on NMP, then done RNA sequencing over time to evaluate gene expression changes over a period of 6 hours. We divided the livers into 2 groups. One group shown in green, which clear lactate quickly and also have high portal flows, which we labeled as viable livers. The other group is these shown in red, which clear lactate either slowly or not at all and also have low portal flows, which we labeled as non-viable. On principal component analysis shown in the upper middle graph, viable livers have similar gene expression profiles before perfusion, and their gene regulation patterns are fairly similar over the 6 hours of perfusion. The red or non-viable livers, in contrast, have varying gene expression prior to perfusion, and although this continues throughout the 6 hours. The bottom middle graph here is a volcano plot, with the upper panel showing the viable livers and the lower panel the non-viable livers. The blue dots are genes that are down-regulated, and the red dots are genes that are upregulated. The first column compares 3 hours perfusion to pre-perfusion. The second column is 6 hours perfusion to 3 hours, and the third column 6 hours to 0 hours. You can see that the viable livers upregulate and downregulate gene expression much more than non-viable livers, with most of the change happening between 0 and 3 hours and much less occurring between 3 and 6 hours. The other thing to note is that the difference between the viable and the non-viable livers is most striking at 3 hours and much less at 6 hours. This on the right is just another representation of the genes being expressed, with darker colors being greater change and lighter colors being less degrees of change. All this suggests that normal perfusion actually changes the state of the organ rather than just passively preventing decay. When we look specifically at which genes are getting upregulated, We see on this slide heat maps of genes and the signaling pathways as labeled for a number of genes involved in the injury response. I'm going to focus primarily on this blue one on the right because it's easy to see, but the similar pattern exists in all these on the left as well. The first column here is non-viable livers at 3 hours, and you can see there is very little change in signaling, while in the second column, the viable livers have upregulated a significant number of inflammatory pathways, such as toll-like receptor and TNF receptor signaling, or cytokines like IL-6. In the fourth column, the viable livers have upregulated a second set of pathways further downstream, such as death receptor and apoptosis signaling. I think what's really important here is that at 6 hours, the non-viable livers are just starting to upregulate the same genes that the viable livers had been upregulating at 3 hours. So there seems to be some delay in the non-viable livers. When we look at regeneration pathways such as HGF and VEGF, which drive hepatocyte replication, the viable livers are just starting to upregulate these pathways at 3 hours and don't really get going until 6 hours. On the right is quantification of some Western blot data looking at the ratio of LC32 to LC31. These are isotypes of a protein involved in autophagy, one of the major repair or salvage pathways of an injured cell, where LC32 is the active form. So higher LC32 to LC31 ratios indicate more active autophagy. And you can see that the non-viable livers on the right at 6 hours have much less autophagy than the viable livers on the left. And similarly, you can see that the non-viable livers have done almost nothing at 3 hours in terms of upregulating the survival pathways, and at 6 hours are just starting to upregulate the same pathways that the viable livers were doing at 3 hours. All this put together suggests possible targets for converting non-viable livers to viable livers, and also suggests that non-viable livers could further improve with just longer perfusion times. All of this work was done in normal livers, but our lab is particularly interested also in steatotic livers. Steatosis is becoming an increasing reason for decline of donor livers for transplantation, and the incidence is increasing with the obesity epidemic in the United States. Steatotic livers are at high risk for graft failure, particularly those with macrosteatosis, or the very large lipid vesicles that distort the cellular anatomy and cause changes in microcirculation. Fatty livers have lower baseline ATP stores, higher baseline oxidative stress, and poor response to ischemia reperfusion injury. We can see all of these characteristics during normothermic perfusion of steatotic human livers. Here, the blue livers are the steatotic livers and the red ones are the non-steatotic livers. And you can see they release much more ALT than the non-steatotic livers. They clear lactate more poorly and they take longer to start producing bile. Sorry. Again, the blue bars here are the steatotic livers, and oxidative stress is worse in the steatotic livers. They have lower rates of reduced glutathione, higher levels of oxidized glutathione, and very low levels of N-acetylcysteine, which is an antioxidant and also a precursor for glutathione. Although hepatic artery resistance is fairly similar in both non-steatotic and steatotic livers, the portal vein resistance of steatotic livers is higher. This may be due partially to simple geometry of the large fat vesicles impeding flow, but vasodilatory pathways in the steatotic liver are also impaired. The important vasodilator nitric oxide levels are lower in steatotic livers, as well as upstream regulators of nitric oxide expression, such as thrombomodulin and KLF2. The good news is that machine perfusion does appear to restore ATP stores in both steatotic livers almost as well as they do in non-steatotic livers. Because machine perfusion appears to be a useful platform for studying steatotic liver physiology, we have performed metabolomic and lipidomic analysis of steatotic livers and found deficiencies in lipid oxidation in steatotic livers, and correcting these may be an approach to improve the function of steatotic livers. So we turned back to a rat steatotic liver model to investigate using machine perfusion to remove fat from livers. This first photo is a picture of a biopsy from a steatotic rat liver with 60 to 80% macrosteatosis, where the white or the clear areas represent the lipid vesicles. In the middle panel, you can see that 6 hours of perfusion has eliminated the fat from the portal triads and decreased the fat to 40 to 65%. In the last panel, we have added a number of defatting agents that promote lipid mobilization, mitochondrial utilization, and extracellular export of lipids, and this decreases the fat content to 10 to 25%. When we analyze the levels of ketones, glucose, and lipids in the perfusate and tissue, we see that fat is mobilized by the defatting agents primarily to mitochondria for beta oxidation and not necessarily export out of the cell. On the right, we see that defatting agent does increase expression of fatty acid metabolic genes. Defatting agents are also associated with improved liver function as seen by increased urea production, better lactate clearance, and better bile quality seen in the blue lines compared to the black lines. Markers of liver injury such as ALT and inflammatory cytokines are also decreased with the addition of defatting agents. Some of the components of this cocktail have failed to be FDA approved for clinical use in humans, so we are looking among recently approved FDA drugs for defatting that have similar mechanisms of action to create a clinically applicable solution. In addition, we think that machine perfusion of steatotic livers gives us the opportunity to study fatty liver disease in situ. The current standard of care is to diagnose fatty liver disease by biopsy for clinical indications of liver dysfunction, although there is some movement towards diagnosis by recent advances in imaging techniques. However, the indications for these tests are often not apparent until steatosis is fairly advanced. One of our collaborators is interested in identifying the exosome signature in the bloodstream of patients with early steatosis so we can diagnose non-invasively, inexpensively, and begin treatment early. Exosomes are membrane-derived vesicles filled with cell proteins, DNA, and all types of RNA, and so they may represent a very good indication of metabolic activity inside cells and the contents of the cells. This is an electron microscopy of exosomes budding off the cell surface, and on the right, an exosome under fluorescence imaging. As one step in identifying the exosome signature of fatty liver disease, we will collect exosomes from the perfusates of human livers at varying stages of steatosis. This graph below is actually from another group that was published in 2015, showing differences in microRNA which characterize different stages of fatty liver disease, which is promising for our exosome signature search. But the advantage of looking for exosomes in pumped livers as well as in patient serum is that there are many systemic diseases and disturbances associated with fatty liver disease, and separating the livers from the patient will allow us to differentiate which exosomes are released because of liver disease intrinsically and which are a systemic response. This platform can also be used to test potential drug therapies and interventions for fatty liver disease. I'd like to spend the last few minutes introducing a few projects our collaborators are working on that are even more innovative. In addition to pharmaceutically or metabolically improving livers during perfusion, normothermic perfusion can be used as a platform to genetically or otherwise permanently modify livers prior to implantation. One of our collaborators is working on developing biosensor cells that would secrete baseline levels of anti-inflammatory molecules and then increase secretion in response to inflammatory signals. then acting as a liver-specific and adaptable immunosuppressive system that could eliminate the need for systemic immunosuppression in transplant patients. As a proof of concept, we added luciferase-expressing fibroblasts to our rat liver perfusion system, and you can see over the course of 6 hours of perfusion, the cells spreading from the central areas to the periphery of the liver. As a note, we did change the media here at 3 hours to remove any fibroblasts that were just circulating in the media. And for the next 3 hours, we still continue to see luciferase expression both in the perfusate and in the tissue. In addition to improving the current supply of livers, there are big efforts to find new donor liver pools, including genetically modified pigs. With the advent of CRISPR technology, the promise of xenotransplantation has exploded with the ability to easily modify, add, or subtract multiple genes in a single animal. The preclinical model of xenotransplantation is to transplant pig organs into non-human primates. And here is a picture of a pig liver transplanted into a baboon. Unfortunately, 8 days later, the liver looks like this from a combination of interspecies incompatibilities, both physiologic and immunologic. These include the presence of preformed antibodies circulating in the bloodstream, platelet and RBC sequestration and destruction because of receptor incompatibilities, clotting factor incompatibilities, endothelial cell and complement activation, all culminating in severe thrombotic microangiopathy. Machine perfusion can be useful in studying many of these problems that involve interaction of the liver tissue with circulating factors in the recipient, which we mimic by circulating human blood through pig livers on the pump, saving us the ethical and financial cost of baboon transplantation. On the left is a pig liver just put on the pump, being perfused with human blood, which looks nice and healthy. Several hours later, it looks just like the transplanted liver in the slide before. One of the other advantages of perfusion is we can measure lab values and perfusion parameters more easily and more frequently on pump than after transplantation. And here you see the platelet count dropping as they are trapped inside the liver, checked every hour. And then decrease in liver flow as the sinusoids get plugged up with microthrombi. And here you see the increase in lactate as the liver begins to die. Normothermic perfusion is being used to test the ability of a variety of interventions to interrupt the thrombotic microangiopathy that normally follows liver xenotransplantation. If xenotransplantation were to become clinically applicable, the ultimate goal would be to have a bank of organs of different sizes available to choose from. As I mentioned at the beginning, current cold storage limits are on the order of hours and not useful for organ banking. But days or weeks of storage capability without organ decay would be helpful. One group in the lab has been cooling livers below freezing temperature while avoiding any damage by ice crystallization and membrane stiffening. They developed a technique for cooling rat livers to -6 degrees and then rewarming and transplanting these livers back into rats. This graph shows that 100% of livers supercooled for 3 days survive after transplant, and over 50% of them survive even after 4 days of supercooling. At normal cold storage temperatures, all these livers uniformly fail after 3 and 4 days, unsurprisingly. They are now working on scaling this up to human livers. Here in the upper left corner is a supercooled human liver, and below is the protocol for cooling, storing, thawing, and then testing these livers, all using machine perfusion. Even in the case of living donation, one can imagine how indefinite storage capability might be useful. For example, if a mother was donating to her child, it would be wonderful if she could donate her left lateral segment, have it stored for a couple weeks while she recovered from surgery so that she can then take care of her child after the transplant instead of being in a hospital bed herself. Finally, another collaborator is working on building new livers in the lab. She can remove the cells from a liver, leaving only the extracellular matrix as a scaffold. then repopulate the matrix with primary hepatocytes. In clinical application, scaffolds could be 3D printed, taken from donor livers from damaged hepatocytes, or even pigs, completely sidestepping the issues with cellular incompatibilities. The new hepatocytes could be derived from the recipient's own stem cells to avoid the issue of rejection entirely. She is currently working on reconstructing the blood vessels and bile ducts, but when we put these decellularized and then recellularized livers on the pump, they are able to produce urea and synthesize albumin like normal livers. This represents the work of more people that can fit on this slide. So I try to acknowledge them by citing their publications along the way. But I also wanted to make special thanks for some of my colleagues who sent me the photos and graphs that you saw on the slides today from unpublished work. And I'd be happy to take any questions now.
Thank you, Dr. Ye, for your inspiring talks. Is there any questions from the audience here? Our transplantation members, do you have any comments or questions?
Thank you very much for your excellent talk. I'm quite interested in the defatting procedure treating the fatty liver. Yeah, because many of our donors have fatty liver. We usually let the donors to reduce their weight. Maybe they have to spend 6 months or 1 year to do that. So if you can defat those liver graft, then we can transplant those liver maybe in a shorter time. But is the defatting procedure, is there any negative effect when you do the defatting procedure? And is the defatting you see in the pathology is really reflecting the good liver function of these livers?
That's a great question. So in the rat livers, defatting is associated with better liver function, and they do appear to perform better. We haven't yet transplanted them back into rats to know if they do perform better after transplantation. We've tried to do defatting in human livers, and it's been a little discouraging because it doesn't work as efficiently as in the rat livers. So even after 12 hours of perfusion, there's very little change in the fat content. There's a little bit of improvement in function, but the alarming thing is that the transaminase levels actually increase compared to control. And so we are, like I mentioned, looking for other agents that we can use. We are also performing RNA sequencing on the fatty livers to see if we can identify specific gene targets that are different from the normal livers that might be better targets instead of these drugs that are used in vivo.
Okay, yeah, thank you.
Thank you. It seems there is no more questions. Then we thank Dr. Ye for your excellent talks. And now we'd like to move on, and I would like to introduce our next speaker, Dr. Jinxin Chen. Dr. Chen is our previous chair of thoracic surgery. Now he moves to our new cancer hospital to become the deputy director of the hospital. And he's going to talk about the new advance in surgery for early lung cancer. Let's welcome Dr. Chen.
Thank you for the kind invitation by our head professor, Huang Junsheng, and my dear colleagues, both from Massachusetts General Hospital and National Taiwan University Hospital. So today it's my great honor and pleasure to share you about our experience for surgery for early lung cancer. So as you all know that lung cancer is the most common cancer death, both in Taiwan and worldwide. So right now there are almost 10,000 patients die of lung cancer each year in Taiwan. And the recent large prospective randomized controlled clinical trial showed that low-dose CT lung cancer screening can reduce mortality in high-risk populations such as heavy smoker. So in 2011, in America, another CT trial showed that low-dose CT screening can reduce 20% of mortality. And the recent published Nielsen trial also showed that lung cancer screening can reduce 20%, 26% of mortality in 10 years. So right now, there are more and more patients with early lung cancer was detected, followed by low-dose CT screening in Taiwan. So you can see a lot of patients around 1 centimeter or sub-centimeter lesion can be detected by low-dose CT screening. So today, my topic I will introduce some new advances in surgery for early lung cancer, especially in our hospital. So the first part is about the smaller and less incisions. So right now, about 95% of our lung cancer patients underwent uniportal thoracoscopic surgery. And then I will talk about the last pulmonary resection. We call it sublobar lung resection. Then third is about the precise localization. We used image-guided localization for small lung nodules before surgery. So then the last part, I will talk about the fast anesthetic recovery. We used non-intubated anesthesia for thoracoscopic surgery. So I think everybody agreed that a smaller surgical incision is associated with a better recovery and less pain. So since 1992, thoracoscopic surgery has become more and more popular worldwide. So right now, initially about 20 years ago, a lot of patients received traditional thoracotomy, about 30 centimeter wound. Then we changed to multiportal thoracoscopic surgery about 20 years ago. But right now, most of our patients only receive uniportal thoracoscopic surgery with chest tube. And recently, the chest tube even not required. So we call it uniportal tubeless VATS. So the second part is about the pulmonary resection for lung cancer. So traditionally, lobectomy was required for small lung cancer. But because of low-dose CT screening, there are more and more patients with very small lung cancer. So right now, more and more patients, they can receive sublobar resection, such as wedge resection or segmentectomy for lung cancer surgery. And more data show that these sublobar resection also have equivalent long-term survival especially in stage 1A disease. This is my operation number. You can see that the blue bar shows operation number is increasing in recent years, but the red line here shows the rate of lobectomy. So right now, our rate of lobectomy is decreasing. Less than 30% of our lung cancer patients required lobectomy. Most of them just receive sublobar resection, such as wedge resection or segmentectomy. So there are a lot of studies show that in stage 1 disease, either using lobectomy or sublobar resection, the survival and overall survival and disease-free survival is equivalent. And in our hospital, our team also show that when in patient with CT1N0 stage 1A disease, lobectomy and the sublobar resection have the same overall survival. Is very, very good. Our stage 1A disease, the 5-year survival rate is about 94%. Also the disease-free survival is also comparable. So for the third part of my talk, I want to introduce some precise tumor localization methods. So because right now the tumor is smaller and smaller, so we have to use a specialized method to identify the tumor during surgery. We call it localization. So most surgeons prefer CT-guided localization. And in our team, we prefer to use dye localization. But recently, we also start to use bronchoscopic guided localization, such as EMB. So you can see here, this is a patient with a 1 centimeter part solid ground glass nodule in the right upper lobe. So for this patient, before the operation, we sent patient to the CT room for localization. We used patent blue dye on the surface of the lung. So during surgery, it is very, very easy to identify the nodule and do sublobar resection, even under uniportal thoracoscopic surgery. So there are two methods for preoperative CT-guided localization. The first one is in the CT room. So when the patient was in awake consciousness, he or she was sent to the CT room for localization. So he can cooperate with our radiologist. Then after localization, the patient will send back to the ward, then waiting for the surgery. So for this method, it is it is very efficient. We performed more than 2,500 cases. But the problem is that when the patient was more nervous or cannot cooperate with our radiologist, the procedure is a little bit dangerous. And the second method is used a hybrid OR. So we have operation room equipment with the CT scan. So we can send the patient to the operation room. Then under general anesthesia, the patient can do image acquiring, then localization planning, and the dye marking, and finally surgery at the same time in the hybrid OR. So I will show you some slides for our operation in the hybrid OR. So you can see this is in our operation room. We have combined CT acquired. The nodule is here. Then this is our radiologist, Professor Zhang Yunzong. He did CT-guided localization using blue dye. Then we acquired the image again to make sure the needle is in the right position, then inject some blue dye. So right now we can easily identify the tumor and do definite surgical resection. So by using two of these methods, recently we published a paper showing that both methods were safe and feasible, and the operation result was very, very good. The accurate rate for localization is almost 100%. We also used another method by combination of CT-guided and the bronchoscopic guided localization in our hospital. So using bronchoscopy, we can use a map on the surface of the lung. Then we use the CT to confirm the location. And finally, we can resect the tumor very precisely. So right now in our new cancer center, we have advanced CT equipment. The first one is Phanon CT, the combined CT. The other is the traditional sliding CT. So both operation room can do this CT-guided localization, very efficient and very safe. So finally, I will talk about the faster anesthetic recovery. We used the non-intubated thoracoscopic surgery. So I think for selective intubation for one lung ventilation has been a milestone for thoracic surgery. It was introduced in 1940s. It can provide one lung ventilation, so can provide adequate oxygenation and keep quiet and wide operation field. So it was considered mandatory for thoracotomy and thoracoscopic surgery. However, it also associated with some complication or problems. All these patients have to be intubated using muscle relaxant and ventilator. So sometimes have intubation trauma or barrel trauma. So since 2009, we start to use non-intubated thoracoscopic surgical technique in our hospital to prevent intubated associated complication. So initially we used awake procedure, but later we shift to sedative procedure. So this is our anesthetic setting. We use it targeted sedation. We monitor the end-tidal carbon dioxide. We use bispectral index to maintain the consciousness of the patient. And we did not use any neuromuscular blockade. So please show this slide. This is our initial case that we used awake procedure. So from this side, you can see the operation is the same, but on this side, you can see the patient was clear and he can move and can talk to you. So this patient received wedge resection, and after the recovery, he recovered very, very good and can transfer bed by himself. But later, because the operation time is getting longer and the operation procedure become more complicated. So right now, most of our cases, we use sedative method. We use intravenous anesthesia and for many kinds of surgery. So by using this technique, we did many cases of wedge resection. And then we can do some more complicated segmentectomy for lung cancer. And we can do non-intubated thoracoscopic lobectomy for lung cancer by combination with vagal block to inhibit coughing during the surgery. And our results show that using non-intubated technique, it is safe and feasible for old and poor pulmonary function patient can decrease complications. So I think right now, because many of our patients only receive wedge resection, so sometimes we did not place any tube, such as chest drainage. We call it tubeless, means no endotracheal tube and no chest tube drainage. So I think right now, the surgery for early lung cancer, we have moved from thoracotomy to uniportal thoracoscopic surgery, from intubated one lung ventilation to non-intubated anesthesia, and from chest tube drainage to no chest tube drainage. So we call it tubeless method. So I think we do not have time to see the video, but you can see that so traditional thoracotomy requires a quite large wound. But right now, many of our patients only receive one small incision. If lobectomy or segmentectomy, complex anatomical surgical procedure, we will place the chest tube. But for those with only very small peripheral wedge resection, we prefer to use a tubeless technique. So we have such kind of non-intubated thoracoscopic surgical training program since 2011, and a lot of doctors from Europe and Asia came to our hospital to learn this technique with our team. So our operation number during the past 10 years, we have increased 5 times from initially about 200 cases until 2019. We have more than 1,200 cases, every year in our hospital for lung cancer surgery. So in summary, for the surgery for lung cancer, I think the trend is precise localization, minimal incision, and the fast anesthetic recovery by using image-guided uniportal thoracoscopic surgery without endotracheal tube and chest drainage. So we call it image-guided uniportal thoracoscopic valves surgery. So finally, I would like to thank for the kind invitation of our head professor, Huang Junsheng, and thank you for your attention. It's my great pleasure to take any questions and comments from the audience. Thank you.
Thank you, Dr. Chen, for your excellent talk. And right now, we can have some questions from the audience or from the colleagues from MGH.
Great, Dr. Chen, thank you so much. That was a really fantastic talk. I was very impressed.
Thank you very much.
So I'm Jeff Yang. I'm one of the thoracic surgeons at Mass General, and I've actually never heard of the tubeless technique until today. I was wondering how often do you need to put back a chest tube in those patients?
Okay, I think we only select patients for peripheral lung lesion, and usually only for wedge resection. Although there are some literature in Japan show that they can even do it for lobectomy or even segmentectomy with some sealants. But I prefer not to do that. I only did wedge resection. So for those patients with peripheral lesion, wedge resection, so we can do that. About 10% case can do this. And we already published 2 papers in Annals of Thoracic Surgery. Maybe you can
fantastic.
Yeah, thank you.
And then in terms of for those patients that did not get a chest tube after the surgery, how often do they need a chest tube be placed back?
Okay. We recently we published a prospective randomized trial, 100 patients, 50 in the with chest tube, 50 without chest tube. Because our patient selection is very good, so no patient required replacement of the chest tube. But we have about we have 2 patients required because the lung collapse more than 5 centimeters. So we have to do a needle aspiration for those 2 patients. Otherwise, it's okay.
Okay, thank you very much. It's very impressive.
Thank you very much.
Thank you. So if there is no more question, then we move to the next topic by Dr. David Zhang. David, you want to start your talk?
Thank you. So what about Jeff? Let me just ask questions.
The other chest surgeons will move to another room. So that will be about 5 to 10 minutes to start another talk there. And, and we will stay here for your talk. Yeah.
Okay, great.
So we can do it now. Yeah.
Okay. All right. So if there's no, if we could go ahead and get started, I'll go ahead and get started. Thank you. Okay, thank you everyone for the opportunity to be here and present. Let me just make sure that you guys can hear me. People can hear me okay and see the slides?
Yes,
Great,
yes. Everything is fine.
Great, all right. So the topic of my talk is basically sort of following up on Dr. Lilimo's talk a few hours ago about publishing. And this is the talk that I used to go through sort of some manuscript writing tips with our residents and our junior attendings. And so I just want to sort of share that with you today. And we can certainly follow up with questions about paper writing. So the way I think about paper writing is I think about sort of there's 2 parts. there's there's always a why and there's a how. And the why part of the talk, the paper is really about sort of how you frame the questions interestingly. And then this gets at sort of the topic and how you frame the topic interestingly. And I actually really believe that if you can frame your paper interestingly, the how is probably not as important. And we've seen this many times where an interesting topic with not as much data actually get accepted than a paper with lots of confusing data. So I think the key is really to think about the why and then before we think about the how. So when it comes to why, and this really relates to the topic of your paper, there's really sort of two sort of common way people present their why. One is they say that something is not known. They say blah, 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 a certain thing, a certain outcomes, a certain procedure, a certain population outcome is not known. It's a very common one, and so I don't think it's exactly wrong, but I actually think that the paper would be more interesting if you can actually not just say that something is not known, but identify what is the controversy. The more controversial your topic is, the more interesting your paper is going to be. And so let me take an example, an extreme example. Imagine, and we all know parachutes. We know, and I think we all believe that parachutes work. And so no one has ever done a study on parachutes. But that doesn't mean that doing a study on parachutes would be interesting because there's no controversy. And so in clinical trials, the concept is called clinical equipoise. You would never do a clinical trials unless you have clinical equipoise. And it's really the same thing for every research project, every research paper. There should be an inherent controversy. Just because something is not known doesn't mean that you need to know about it. Again, think about the parachutes. And so keep that in mind. So just saying that something's not known is probably not enough. What would be interesting is if you highlight what is the controversy and what is the debate. So, and sort of by definition, the debate means there's two sides to the argument. There's one group that says you should do this. There's another group that should say you should do this other way. And then your goal of the study is to say why one or the other is better. And so in your introduction, I would really highlight the controversy. Again, keep in mind that you might be writing to an audience outside of your specialty. And so what you may know about the topic, people may not know. And so it'd be helpful for you to really lay it out for them, what you believe, but also what does the other side believe? And the more controversial it is, the more interesting it is. And I think this is a very common question that comes up in papers because people are very passionate about what they do. And then the question is, well, if it's so interesting, why do we have to even do a study on this? So, so the point is you have to make sure that you can frame the debate. And so that your topic should be debatable. There should be legitimate debate about this. So for example, if you have a question, if you say a question of your paper is, do elderly patients have worse outcome than younger patients? I don't think that's really debatable. No one's going to argue that elderly patients have worse outcome than young patients. That's not a debate. I think 99% of people will say yes to that question. So that question is not interesting because there's no debate around this. However, if you say that is age an independent factor in outcomes, then that becomes a legitimate question. Some people think age is independently affecting outcomes, irrespective of comorbidity. Some people think it's not. And some people say that age is just a correlate for comorbidity, but if you are someone who's old but have no comorbidity, you should be okay. That's debatable. And so framing it as age as an independent outcome, then that becomes debatable. Then the paper becomes more interesting. What you want to avoid is what I see a lot is what I call sort of circular logic. You have an answer and you ask the questions in such a way that the only answer to that question is one thing. So for example, and you see this a lot, in the toy store, with little kids asking for toys. They say, I don't have this this toy. And the mom says, why do you need a toy? And the baby says, oh, I don't have a toy. Well, it's a circular logic. The only way to solve that problem is to get the toy. So same thing here, you need a TV. The question is not you really don't have a TV. The true problem, to frame it in a way that's actually debatable, is you don't have an entertainment option at home. then you don't actually have to get a TV. You can get a TV, or you can get high-speed internet and watch internet stuff, or you can become a surgical resident where you have to have no time to watch TVs anyway. So you don't even need a TV. So a good question has more than one answer, because again, there's got to be a debate. If there's no debate, there's no interest in this topic. So again, this is why I said before, has not been done is not good enough to make people interested in your paper. That could be a surgical logic. You should really think about why it should be done. Is it going to change the way people think, or is it going to change the behavior? So what you want to do is, what I tell people is, don't think about a research question, think about a hypothesis. And the difference is this: a question is usually open-ended. You usually start with what, why, when, and how much. But a hypothesis is closed-ended. It's asking for a yes or no answer. And this is because, at some point you have to do statistical testing, and all that statistical testing is going to give you is a yes or no answer. So you got to ask questions in a yes or no format. And this is no different from a clinical HMP. When you do a history and physical, you start with open-ended questions, but at some point you start asking very close-ended questions, asking for yes or no responses from the patient, because what you want to do is lead to a certain diagnostic test that you want to decide to order on the patients. So having open-ended questions is actually not good enough. You want to make sure you have close-ended questions. You have to have a hypothesis. And Dr. Lillimo mentioned this, your paper should have a hypothesis. And I think an easy way to define a hypothesis is a question that's asking for a yes or no answer. It has to be that specific. It's not asking for a number. If the question is, what is the rate of complication? That's an open-ended question. It's asking for a number. But if you say the question is the complication higher in this group versus this other group, then it's asking for a yes or no answer, then that's a hypothesis. Hypothesis has to ask for a yes or no answer. So that's how you would really set up your topic. And again, I think if you set up your topic in an interesting way, you're probably more than half of the way through getting your paper accepted. Because I really believe that the issue is most of the time is really not having an interesting topic. And then so that leads to sort of writing the introductions. And again, what I would really highlight in an introduction is not just the fact that something is not known, but what is the debate? What is the pros and the cons of whatever thing you want to talk about? So you set up this debate, and then you say, what is the data that you propose to settle this debate? What I would do, and I think this is very common in the surgical literature, it's a little different in the medical literature because they tend to talk a lot. And I think their papers tend to be a little bit longer. In the surgical literature, you want to be very focused. So I will actually avoid a lit review in the introduction. What I would do in the introduction is literally just talk about this debate. What is the debate and how do you settle this debate? You want to avoid doing a literature review because the literature review end up, if you were the reader, when you read the literature review, it's very easily getting distracted by what has been done, because there's a lot of literature by definition. There's a lot of things that's been done on what's been done, but it doesn't. The literature by definition would not tell you what needs to be done. So if you do a literature review, it may make the reader wonder. So why are you doing this? Why, if all that has been done, then what's left not to be done? So I would avoid a literature review here. You can try to summarize it in a few sentences with a lot of references, but don't go into details. I'll keep it in the introductions. So lit review, going to the discussion. In the introduction, just lay out in debate. Talk about what the pros and the cons are for your debate. And then part of your introduction, you should also think about your target audience. Is your target audience clinical? Is it going to be other surgeons or is it going to be non-surgeons? It is possible that sometimes you'll be writing for the medical audience. If you're talking to the gastroenterologist, you try to convince them to send you patients or not send you patients. Your target audience will be very different if you were versus if you're writing for a surgical audience. You could be writing for the government, for policymakers, for administrations. In the US, people do a lot of patient-oriented, patient-reported outcomes. So you might also be writing paper for the patients as a target audience. So you think about that in your introduction and make that clear. Who is your target audience? What do you want them to do differently? And then you think about what data would do it for them. Again, the whole point of writing paper is to convince people to change. It's not just to provide knowledge, it's to convince people to change. So you got to think about who they are and what kind of data will convince them to do something differently or think differently. Paper is all about driving change. And that's an important point. I think if you remember nothing else from my talk, Just keep this in mind. It's a very common concept that people say that the point of research is to provide knowledge. I actually don't think so. Knowledge for the sake of knowledge is not that interesting. Knowledge that drive behavior change or thinking changes is more interesting. So you got to be clear on what changes you were trying to target. And then you get into the methods, and the methods, these are sort of the basic steps of pretty much any methods paper, methods of any paper. You describe the source of your data. You describe the inclusion exclusion criteria. It's no different from a clinical trial. You will talk about the inclusion exclusion criteria. You think about your outcome measure. You might talk about covariates if you're doing an outcomes analysis, any sort of confounder. And then you describe your statistical analysis. And in most cases, you could probably use this sentence here. You can say unadjusted analysis will perform a categorical variable with a chi-square and for numerical variable with a t-test. This sentence is probably true for 90% of the papers out there. And then if you're doing a sort of an outcomes research type of paper, as Dr. Yang is also about to talk about in the other room, you might sort of add another sentence about how you do multivariate statistical analysis. So that's the methods. And then you get into results, and the results basically have three parts. There's what's called a univariate, bivariate, multivariate. This fourth thing is sort of optional. I find it helpful. I use it in my papers because I think it helps your paper become more convincing, and I'll explain why. But basically, your paper should have these three tables. And as Dr. Lillemel said, and I think you might have noticed when he says that talking about colleagues and talking to residents about getting papers from them, he always talks about get the tables first. You want to make sure your results are so clear that people can understand your paper by just looking at your tables. In fact, in a lot of journals, that's what they do. A lot of reviewers just skip straight to the results table. And if they can understand the paper from the table, then they will read the rest of the paper. If they cannot understand the table, they actually won't even bother to read the paper. So you've got to make sure the tables are clear. And the tables are basically three parts here. Your univariate table is basically this sorts of single column table. It's basically your variable one at a time, describe every single characteristics of your patient population. Your table two is what's called a bivariate table. And essentially it's making comparison between your control groups. And again, this brings up the fact that a lot of time we don't really do comparative study. We actually just have a descriptive study. If all we have is a descriptive study, then what we have is probably just a very, very long table one describing your patient population. But a good scientific study should always have a comparison group. And so when you have a comparison group, then you have two columns, group A versus group B. So that's table number two. Table one, again, is everybody. Table two is comparing your comparison group. And then table three is when if you're doing an adjusted analysis where you do multivariate analysis, then you do multivariate analysis adjusting for confounder, and you identify the independent effect of different variables. And that's essentially your three sets of tables. The table might be very long where you break it up, but you should essentially have these three types of table in your paper. And then what I said is, like I said, I would also sometimes go a step further. When I finish analysis, I would do subgroup analysis. Basically means I'll repeat the analysis in different pockets of the populations that I study. And the idea is if I find the same results in different subset of patients, more or less the same, then my conclusion is a lot stronger. If I could say that the results are no different when I look at elderly patients, when I look at young patients, when I look at male, when I look at female, and the results are all the same, the results are consistent, it makes your results a little bit more believable. And so I usually put this in to the extent possible. I would do a subgroup analysis to sort of help make the paper more believable. Then you get into the discussion, and these are sort of the main things that I talk about in the discussions. I summarize the main finding in my paper. I talk about other paradigms that are similar to me. I will rule out counter arguments, and then I have a sort of a section to talk about anything that's interesting but it's not relevant to my main findings, strength and limitations, and implications. So obviously we start with summarizing your main findings. And then the next paragraph, what I would do is I talk about sort of other findings in the literature. Let me go back again. So essentially what you're doing is you talk about what you found, and you talk about other people that might agree with you. And then you talk about people who disagree with you. And then you go ahead and address those counter arguments. Again, a good paper is about a debate. So you talk about people who's on your side, and you talk about people who's on the other side, and how their argument is now weaker because of your paper. this is how I would sort of begin my discussion. What I say, what other people that agree with me say, and then what the other side say. So for my side, the people who agree with me, you can find literature that have similar findings, or if your thing hasn't been done, you might also describe the mechanism of action, biological, physiological mechanism for what you're finding that was supported. And this is where I would put the lib review. Again, this is to buff up your argument. So I would put the lib review here because you want to make sure that it looks like there's a lot of people that agree with you. And then I will rule out, then a good debate is always about knowing what the other side's going to say and address it before people bring it up. And so I will go ahead and put, then after I talk about my side of the argument, I'll go ahead and say, the other side might say this, and I go ahead and bring it up, and I go ahead and try to address it. And there's usually, it turns out there's a few different, actually, but very common counter arguments that people bring up. And so they more or less fall into these 4 different categories. A lot of time people will say that your data is inaccurate, there's some data inaccuracy, and that's probably true. But the fact is, there is no study that has perfect data. So having inaccurate data is actually not as big of a problem as people think, as long as you can be convincing to people that your data, your inaccuracy is random. If you have random errors, then what it would do is just dilute the differences between groups. And so whatever you're finding, you can actually argue that it's a conservative bias, because if you can actually clean up the data errors, then the effect might be even stronger. Because an error, if that's randomly distributed, would be on both sides, and what it would do is dilute the difference. And so data inaccuracy is not as bad as people think. The key is you just want to be ready to say that you might have some errors in your data, but it's likely randomly distributed. So it's not going to affect your finding. You want to rule out these statistics, and then when people attack your data, the other thing they might attack is sort of your analysis. They will attack your statistical analysis. And this gets at sort of, there's 2 general types of conclusions you might be making. You might conclude that something exists, and then you might conclude that something doesn't exist. You might say that you found something novel. Then the other side might invoke what's called a type 1 error. It was a random chance that you found this. However, if you're actually, your conclusion is more that you say that something doesn't exist, there's no difference between this surgery and this surgery, then your critic might say you have a type 2 error. And so you got to be able to defend the other side. It depends on what your question, what your conclusion is going to be. And so the way I explain type 1 error and type 2 error is, type 1 error is sort of the examples of hypochondriacs. You ask enough doctors, somebody will say that you're sick. That's the definition of a hypochondriac. And that's what type 1 error is. Type 1 error means if you do enough tests, something would be abnormal, but that doesn't mean it's real. Type 2 error is the other direction, where, and my example for this is someone who's lazy. If you ask someone to look for the car keys, he looks to the left, looks to the right, he doesn't find the car keys. Is the car key really not there, or he hasn't looked hard enough? So type 1 error is you look so hard, you find something, but it's not real. Type 2 error is you're so lazy that you didn't actually look, and you claim it's not there, but it's really because you didn't look. Clinical analogy of this is, for type 1 error would be like doing a Chem 20. 1 out of 20 tests is probably going to be abnormal just based on random chance. But if you think it's really not real, what you would do is just repeat the test and it will go away. Type 2 error would be like ordering an ultrasound instead of a CT, an underpowered test. So if you concluded that something exists, you find a new finding, your critic is going to say that you might have committed a type 1 error. And so then you have to be ready to you have to be ready to say that, no, my finding is real. It's not a random, spurious finding. There's a couple of things you could do when you prepare for this kind of debate. What you would say is you might do a statistical debate where you say you do what's called a Bonferroni adjustment. And what that means is basically instead of using p equal to 0.05, you use p equal to 0.01 as your threshold. And ultimately, the way you counter type 1 error is if you have an external validation, but obviously an external validation is your next study. And this is why, because you cannot do external validation, so what you would do now is do a subset analysis. This is the idea. This is why I've advocated doing internal validation, the subset analysis. When you do different subgroup analysis within your study, you are essentially repeating your study and showing that the results are reproducible. then you address the counter argument that this finding is a spurious finding. And again, if your conclusion is something doesn't exist, there's no difference between surgery A and surgery B, then the other side might say, well, it might be a type 2 error. You might just not have looked hard enough. You don't have enough sample size. And so the problem here is, obviously, the easy solution is to get more sample, but that may not be possible. And so what you might want to do is make sure you do what's called a power calculation. And anyone with basic stats training can actually do a power calculation in 3 minutes. And so you can do a power calculation to show how much power you have. And this is the concept of subgroup analysis that I talked about. It's very helpful for addressing type 1 errors. So I talk about my finding. I talk about people who agree with me. I talk about people who might disagree with me, and then address them. And then I talk about other interesting findings. There's usually sort of interesting, but not really relevant finding that you found, because we collect so much data in any study that we do. So I would probably reserve one paragraph just for these interesting findings, and I will address it. And I'll say, these are the topic for future studies, but I just want to acknowledge that I noticed this. So what I found, other people agree with me, what people might disagree with me, they might say, and I might respond to them. Interesting things. And I talk about strength and limitations. What are the strengths of my study? What are the limitations of my study? And the point I would make here is just make sure that you're balanced. A lot of time, people end up doing too much strength or too much limitations. You just want to be balanced. There's strength and limitations in any study. The worst thing is if you don't mention limitations and the reviewers come up with it. And so it's a lot, as long as you come up with limitation, no one will fault you for having limitations. And once you address all the study issues, what your conclusions are, what your strengths and limitations are, what I would do is at the very end, I would talk about implications. Implication means what are people going to do about this based on your study? And there are two things. There are obviously future studies. Every study has a future studies, but just by talking about future studies is not really good enough. I would really talk about sort of some actual thing you can recommend based on your study. And I put this after the strength and limitations because the limitations of your study essentially falls into future studies. The strength of your study essentially allows you to make certain recommendations. And this is why I put the implication paragraph after the strength and limitations paragraph, because they really kind of flow right next to each other. My study has certain limitations and strength, and therefore I can conclude that we're ready to do this, but we might also want to study this. And so this is how I structured the discussion. Summarize your finding, summarize people who agree with you, summarize what the critic's going to say and go ahead and respond to it. Other interesting finding, strength and limitations, and then what are you going to do about it? Implications in terms of future studies and what actions you can recommend. And at the very end, I decided to add this, listening to Dr. Lillimo's talk, because I suspected that he would invite people to be reviewers. So we actually have this other talk, training people on how to be good reviewers. I'm happy to do that at a different time if people want. But let me just sort of summarize in this one slide here, some key point that I would do, which is, again, you could go through the same format that I just described, because reviewing paper is really the same as writing paper. You're just now reading it. So you can follow the same format that I just described in terms of writing paper in your reviewer papers. But the only thing I would sort of suggest is there is really no wrong analysis. A lot of time people say that you did this wrong, you should do this, you collected the wrong paper, patients, you collected the wrong data. The problem is if you are the author of the paper, it's actually very annoying to get a review saying that you need to do more work. And I actually think, and so I think that would be a definition of not a constructive criticism. I'm a believer that there's no wrong data, there is just wrong interpretation. And so instead of asking people to collect more data, suggest a better way to interpret their data. So this gets at what Dr. Lillimo was talking about in terms of over interpreting, and overgeneralizing from your data. And so a lot of times, instead of saying that collect more data to justify your conclusion, what I will say is tone down your conclusion. Think about a different study. Don't think about a different study, but think about different ways to interpret the data with different conclusions. I think this is what people will consider constructive criticism. because you're not saying that their study is wrong. You're just saying that the writing is not as good as it could be. And it gives them a way to save their paper. It's an easier way to save their paper than to do a new study. So as a reviewer, I encourage people to do this. Don't criticize the work that they did, but criticize their writing and suggest ways to improve on the writing. And then lastly, I'll say it again, your point is not to say that the study is bad, but try to suggest ways to improve and or different journals that might be more appropriate, etc. Again, the whole point of review paper is to provide constructive criticism, and it's not to criticize and destroy people's. And so that would just be the take-home message that I'll give if you ever get to the point of reviewing paper. And again, I'm happy to do another session on reviewing papers if you guys are interested. And then that's it. Thank you very much. I'm happy to take any questions.
Thank you very much, David. I just wonder, any questions from here, from the audience, from our NTUH colleagues, and also some Taiwanese colleagues also here. So I think it's a good talk, and especially that we start from Dr. Liedermo's talk and then come to David's talk. So I think that is quite encouraging for our colleagues here. So maybe we can submit more papers to end of surgery, and hopefully that we can get some advice from David. Yeah, maybe before we submit to end of surgery. Yeah, and
I'm happy to. Yeah.
Yeah. So I think I know it's already pretty late, and so I would like to thank you for helping us to organize this symposium, and I think I hope that maybe we will have another chance to do it again. I mean, if possible, in annual base, and also maybe we can think about something else. Yeah, because the as I say, that thanks for COVID-19, so makes the this kind of virtual meeting be more comfortable for everyone. Yeah, but also because of the different time zone, so we need to keep you late. So we are very sorry about that. Yeah, but I think we'd like to thank you once again, and maybe we can do a photo together. Let's do. I think we will put all your photos. Oh, not. I mean, right now we can show everyone, right? Would you mind to wait? Is Dr. Tanabe here?
I think Dr. Tanabe is still in Jeff's room.
Okay. And how long will that be? Oh, it's in Q&A section already. Yeah. So I think we can invite everyone here, and then we can have a photo. So then maybe we can do我们每一个人到我们站前面，然后它上面就有他们的照片，然后我们就大家一块照这样子，是不是？这样可以吗？哈，好，我们就这样会挡到上面吗？你先把他们放到上面去。请往前啦！对啊，待会。好，来，请，我们就先照嘛，我们先照，来。
Dr. Tanabe is back.
Oh, wow. Okay, we're going to get a photo with them. Okay.
So thank you very much, Dr. Tanabe. Thank you for staying up till now. Can you hear me?
Yes.
Okay,
Thank you
you want
very
to say
much.
something?
It's really a pleasure and an honor to join you.
Uh-oh. I hope we show up on their screen.
好，哎，老师你看一下左边那个可以吗？那个议程这样子。
常伟他要海报，他要海报。
在哪里啊？哪里？哪一个？这个吗？
对。然后就这一页显示。
对吗？好。
快点！第一排可以站，第一排还有位置，第一排可以站，站第一排就好了。好来，各位一起拍啊！好，跟国外的 speaker 一起哈，来1、2、3，来跟这边呢，口罩拿下来好不好？好，一次哈，来，请看这边。好，1、2、3，排到完成。
赞。
排到完成。赞。好，都拍到了，谢谢。
Thank you. I hope you have a good night, good evening.
Thank you.
Good rest.
Thank you very much.
Thank you so much.
Thank you. Hope to see you next time.
Thank you.
Thank you, Dr. Tanabe, for staying.
Yes, thank you for staying so late.
Yeah. Thanks, Jeff. We'll catch up.
Thank you, David. Yeah.
Bye.
All right. Thank you, guys.
Good to see you, Yawen. Thank you. Yeah.
Bye-bye.
那个，请外科部的住院医师留步。外科部的住院医师请留步。那个住院医师请到前台集合。住院医师请到前台集合。住院医师先站上来。
片讲，就是等一下2点开始，就节类出口2点开始下午的议程，这样从成。为什么要有人把麦克风插在这里面？而且还插人。你笑脸。我放在你下本酒哎。你那有讲嘛？下晡讲。我还好啦。你们都是那个阿伯鸡的减重派的，都不用吃。
如果今天本次明天要从今天就继续讲，在公告上给他讨论内容。那点快到了。
外面的住院医师跟那个很多住院医师啊，住院医师让 MGH 进来坐等了解他，我知道。
直接开始。
我们就直接开始了。
各位来宾，我们现在2点有15分钟的 delay， 不过我们现在就准时开始2点我们会先以这个那个李教授会先跟我们讲一下我们这个播放这个纪念影片的那个题言。
好啊，大家午安哦。首先要谢谢，这个是要稍微介绍那个陈教授的一些，因为其实首先要感谢OK 好，要感谢我们全体的那个的同仁那么特别是叶启坚，他把这个整个的这一次的那个纪念文集去 organize 另外还有一些过去的回忆的那个那也要谢谢那个我们的注意室的同仁那这个部分在纪念文集里面叶启坚有详细的介绍，我们想谢谢他因为很多年轻的对陈教授可能都不了解，甚至都没有接触过，只有听到而已所以我这里只有想用几张的 slide 把它 figure out 就我的了解把它 figure out 出来那特别是给我们在年轻一代的他知道他其实这个是我可能陈教授给我的唯一的一个描述而已了好，我所认识的陈凯模教授陈老师其实我是这样，他给我的感觉就是一个日本教育出来的那么他做事很执着，那么对他认为对的，他就一直很坚持他这种感觉。还有一个他对老师非常尊敬他对他等一下我们会看到另外他给我感觉就是你第一次碰到他的时候会感觉很严肃外面好像很冷一样可是你跟他接触久了以后，你就发现到其实他也有很温暖也有很风趣的一面所以就是说望之俨然即之也温那么而且他讲话都很直接很直白，所以他就雷公也很大声那还有一个对他的学生对学生他会注意到学生的将来会怎么样，就有没有前途，他会关心说你的前途好有没有需要做什么更进一步的训练。那还有一个他对台大很关心台大的那个未来对台大外科的未来，还有这个定位在哪里那还有一个我跟他的接触他很少谈到他家庭的事情都是在讲说我们跟我们一般的供大家学生，然后或者是说我们这一届的事情这样子。那么其实那个陈教授辈分相当高我们看这高天成下面林廷佑其实这里面就许书任、陈汉洪启仁他们是同学那在这里。那么这个是高天成院长过世以后那么林廷佑教授他在服官的情形那么可能那时候对于老师的敬重这是可以说大概可能是有一直都有这个传统的观念所以其实他对林廷佑对林廷佑教授是非常的。就是说，他言听计从一样，就是说，所以我在里面跟他写说，一日为师，终身为父，他每次都一定谈林批的事情，我这里就是因为我自己在做这个，所以当时我在做这个时候，我都把它列，因为他当时最先开始，他其实是涉及到很多关于肝脏的手术，那另外器官移植其实他是比较少接触，可是他对没有去做肝脏移植，没有做 器官移植这一块哈，坦白讲，它的言谈之间哈，就有露出遗憾。所以我一直把它列为是这个 group 里面的。那当然，后来它最主要还是在 GI 了。那这里面没有列出来。其实在我的认知真正是陈教授的摘传其实是张金坚才是摘传。那么像陈敏如教授啦，李志宇教授都是 mix 的。我会想，陈敏如教授应该是林批的下面的弟子才对。我不知道我想的对不对这是陈教授、李进教授还有洪锦教授，其实他们是同学。那三个人坦白讲都是很有个性的人而且都是很好强的人。那再来看这个那么陈丕呢，他其实他真正的在我们外科的系统里面应该是讲说他是在消化系统是大家会比较知道他。其实像后来做了，他虽然后面做很多的乳癌方面的研究，可是大家在感觉认定他主要还是在消化外科方面那他是第一任的那个做发起的人他有一些大概5-60个人做一个开始的发起人他当第一任的这个理事长其实那时候张金珍教授是他的秘书长。那么这也是我们在消化外科里面他大概也是我的印象里面大概是唯一一次的颁一个终身成就奖是给陈海模教授。好，那么他其实他的在平常在科里面呢，他跟他接触，他都会谈说哪个人的训练好不好，哪个训练够不够所以他后来他到国泰医院的时候他就在《自由时报》发表了一篇这个外科住院医师的起源传承，他在描述他当时受训的情形受训以前的受训是在外科相当辛苦，而且那是外科有淘汰，所以每个人都要尽量努力表现自己做的，让老师能够觉得他这个做得很好，那才有机会上升，才有机会升任所以他常常会，我是认为他过去的这种历练让他会去关心到学生将来的发展。好，那这个是肝脏移植，我们第一次在台大的肝脏移植是从他上任外科主任以后才决定要发展肝脏移植，所以这是我们在做动物实验的时候第一次成功的时候，他很高兴，他就跟这只狗合拍一张照片，其实他也是很关心我们在做的发展怎么样这个是李延吉教授当外科主任的时候，设立一个外科的传承传承的那个历史传承的那个的特别演讲那么这是陈楷模教授所做演讲的时候的情形。他那时候讲的题目就是说台大外科以我那这个也收录在这个文集里面这有他的录音档的一个改写出来的。好，那么我想我觉得陈教授他后面他最在意的是林天佑的这个肝癌研究基金会的将来那时候这个他这个是在这2012年的时候因为这以前是独立举办演讲会那么这一年的时候，我们请了这个是塔纳卡，是那时候在京都大学的一个做肝脏移植的对不起，这个好，在前面。 在前面。哦，这个是首尔大学 Professor， 这个是中文大学的哦。那时候都是请2个到3个国外的 speaker 来演讲啊。那其实透过这个基金呢，还有透过他消化外科的关系啊，他认识很多日本方面还有这个的那个一些国外的学者啊。那这也是我们这是我记得2009年，在举办亚洲外科协会的时候，这个是马古吉啊，这个马古吉，他跟他是蛮熟的，他来好几次。那这是 John Wong， 就是当时在香港大学的外科主任啊。好，那这是每年在林教授的生日到了之后哈，他都要带着我们去他的墓园去致意啊。那么最先开始是他，后来他行动比较身体比较不方便的时候，那时候就变成换我来代理，跟他们去。那我们这个是在跋杯啦，我们去都要跋杯。这2个铜板到现在都一直都留着同一个铜板，那么今年我跋杯的时候我跋不杯了，所以我就交给田委员，到田委员跋杯。那他一直很注意到这个foundation的将来。这张是就一张，我是把它 summary 是它的一个情形。那这里面有提到2个地方，一个是高天成的教育学术基金，还有一个是林天耀的医学研究基金。这2个事实上都老师他们所创立出来的。我是期待这2个我是当一个过渡时期的人，希望带这两个基金能够好好的在外科是一个外科的一个资产。那么它能够给外科所有的能够利用，也同时利用这个来扩展到影响到我们台湾的一个外科的医疗。我大概简单把这个把陈斌他的自己的用心简单这样报告一下。好，那后面可能是另外有那个好，谢谢。
因为时间的关系所以我们接下来会直接接下来我们下午的学术演讲。那下一个演讲是我们会邀请三军总医院的詹教授来为我们讲解胃癌的一些主题。那我们请林明灿老师。
各位先进，今天很高兴邀请到我们消化外科的理事长詹德全教授例会演讲。那我简单介绍一下詹德全教授，他是主要国防医学院毕业，非常优异的表现，担任过总住院医师。那另外也曾到 National Cancer Center 进修，日本的 National Cancer Center。那回来以后就担任3种的一般外科主任，然后担任外科部主任。那今年呢，他高票获选我们消化外科的理事长，他的主要也是消化外科，特别是在胃癌上面很多的 publication， 还有先进的一个报告。那我们热烈掌声欢迎詹德全理事长。
各位先进大家午安。那刚刚听到李伯煌李教授在介绍林天佑陈楷模教授的事迹其实跟我们非常相似。我们之前在施存仁教授生前呢，也是每年会带我们去跟我们的老师张先林教授坟前这个致意。那当然也看到李伯煌教授介绍台湾消化系外科这个历任理事长。看到这个历任理事长，我想都是当代的一时之选包括林明灿教授、陈敏福教授、张金燕教授李伯煌教授都是非常一时之选可以是风云人物。那我为什么会敢这么说呢？因为我的名字也会放上去开玩笑。那今天跟各位介绍一下 这个要用英文还是中文？中文哦。今天跟各位介绍一下我们对于 Stage 4的 gastric cancer with peritonic carcinomatosis PC 要它的另外一个治疗方式 conversion surgery。当然直到2020年呢，这个 gastric cancer with PC 仍然是一个 terminal stage。那 NCCN guideline呢仍然 recommend 只有 best support care 或者是 palliative systemic chemotherapy。但是呢，我们看这个PC 的病人如果用 conventional treatment， 它的 nature history 在2000年 cancer 报告了125位PC from gastric cancer 的病人他的 median survival 事实上只有6.5个月，不是很好。那即使现在的 modern 的 systemic chemotherapy 甚至加上 target therapy 它的 survival 是好像还是有 limited 大概6到18个月那5年 survival 几乎是可以说是奇迹所以说病人几乎没有 cure 的机会对于这一类病人。那我们可以看到systemic chemotherapy 它的效果如何？这几个 series 呢尤其2017年这个比较大型的 series 都不超过1年所以可以说它的 systemic chemotherapy 效果非常大。为什么呢？可能就是这个PC 的病人呢，他本身是 resistance to systemic chemotherapy 当然有可能是因为 plasma peritoneal 的 barrier 那化疗药不太容易进入到 peritoneal cavity 里面。那这是从国健局回馈给我们 data， 我们看我们台湾第4期的病人即使随着并没有因为时间的这个推演而得到比较好的结果那目前在全国大概只有 2.8% 左右好，所以呢，一些 regional therapy 像是 cyto reduction 加 HIPEC 就已经被发展出来一个新的治疗方式，看可不可以改善 gastric cancer with PC 的病人那事实上呢，这个 outcome 是 disappointing 的事实上，比起这个 systemic chemotherapy only 好像并没有好的太多事实上，这个有一个meta analysis 他们认为 cyto reduction 加 HIPEC 只有增加4个月的 survival benefit 但是我们如果看它 subgroup 事实上有些病人真的是可以得到 benefit 包括哪些病人？最主要是他 PCI 也就是这个 peritonial carcinomatosis 的 index 比较低的然后我们手术的时候可以 complete cyto reduction， 这种病人似乎可以得到比较好的结果譬如说这个如果达到 complete cyto reduction， 事实上他5年 survival 可以到达 23%虽然不是很高，但是对于 PC 的病人这个数字是令人这个惊艳的那各位可以看到若病人 PCI 小于6，或者是而且有 complete cyto reduction， 他5年 survival 可以到达 23%相反的呢，若 PCI 大于19的所有病人1年以内就死掉了那如果incomplete cyto reduction 病人2年内也都死光光所以我们知道这2个因素特别重要，但是不幸的呢大部分的病人PC 的病人呢发现的时候就已经有比较高的 PCI所以大概只有30%的病人如果我们手术能够完成 complete cyto reduction就像我们这个病人是28那我们还有什么方法为这些病人来做一些什么？除了传统的化疗以外那因为这个 neoadjuvant therapy 的进步所以conversion surgery 也慢慢被发展出来希望能够改善survival那其中有2个方式，一个是所谓的 bidirectional intraperitoneal and systemic chemotherapy 就简称是 NIPS 这个是由 Nemura 在2006年所提出来的那在2007年又是他也提出一个 laparoscope HIPEC 加 NIPS 来希望可以 减低这个 PCI， 然后来帮忙 complete cyto reduction。好，那我们可以看这些 series 它所报道的 clinical outcome NIPS 那我们可以看到它这个 conversion rate positive cytology 大概可以从70% 到将近几乎快100%，97%，而且对于它的 median survival time 也有帮忙这几乎都15个月到这个24个月这当然是比较不错的成绩。但是相反的如果我们只用 systemic chemotherapy， 它的 conversion rate 大概只有不到50%就是可以把 positive cytology 变成 negative 的比率。那在这篇文章里面，有人 Muna 他 conclude 说，如果我们加上 HiPEC 加 NIPS HiPEC 加 NIPS 事实上是可以比较有效的降低 PCI。而且 median survival 也可以从14上升到19%。所以目前 conversion surgery 事实上慢慢被发展成对于一些 PC 一个很好的方法当然 gastric cancer 它效果还是比较不令人满意那其他的包括 ORCA， 包括这个mucinous 这个peritoneal都是比较好的效果那我们最主要 conversion surgery 它的目的呢，刚开始呢，我们先 down stage 然后 eradication of free cancer cell 那最后呢，如果 response 不错的话，我们再用 cyto reduction surgery 加上 HiPEC 来提高它的达到所谓的 R0的resection 来 improve survival。那我们呢，就收集了127位 Stage 4 gastric cancer 病人在我们医院治疗，他时间从2012到2020，那这刚开始呢，大部分的病人是接受best supportive care 或是 palliative chemotherapy，当然我们从2015年开始呢，开始执行这个 cyto reduction 加 HiPEC 因为已经进了这个 HiPEC 机器。那2016年呢，因为这个outcome 还是不尽理想所以我们在2016年呢开始做 conversion surgery 有34个病人进行 HiPEC 加6个 cycle NIPS 其中有27个人可以进行 cyto reduction surgery 那这95个这个 PC only 的 case 呢，分别接受这4种不一样的 treatment 那在这一组 HiPEC 加 NIPS 的病人呢，有27个接受手术，那其中有3个 disease progression，有3个incomplete 没有做完 NIPS，那有一个病人在做完6次的 NIPS 以后，他不愿意手术因为没什么症状，他觉得他自己很好，就不手术了。当然这是一个很花时间的手术我们先要把他这个 peritoneum 剥下来。peritoneum 剥下来，甚至它 mesentery 这个 mesentery 这个 peritoneum 上面有也要把它这个掀下来所以通常是花8到10个小时左右如果比较严重的 PCI 的 case。那在 diaphragm 上面的这个 tumor seeding 也一样，把它整个剥下来就整个 peritoneum 像剥皮一样把它剥下来。那当然有时候碰到不好处理的我们就用电烧把它烧掉。就是烧掉，但是要小心，这个小肠容易造成这个 thermal injury， 有些病人会 delay 的 perforation 这是 disaster 那我们这个 case 分成4组当然这个不是 randomized 的看起来呢，在这2组就是有积极手术的 case 它比较多的病人有 T4 的 lesion 那也是 N2 也是比较多N2 比较多，但在做这个 HiPEC 加 NIPS 病人大概有60%的病人都合并有 ascites 那比较这个做之前和做之后，它的一些 data 包括 PCI， 我们可以看到从平均17降到8那 ascites 呢也从1900多降到400左右那 ECOG 呢也是有比较进步positive cytology 也变少了所以看起来是有帮忙的 那当然，我们把这27个有做 conversion surgery 的病人跟这15个 cyto reduction 病人这个比较一下，事实上经过这个 HiPEC 加 NIPS 以后，它的 PCI 值降到8，两组事实上差不多。那 organ resection 呢也没有太大的差别。那两组的病人大概都有70%以上的病人可以达到 complete cyto reduction 就是RN resection 那当然最重要的 anastomosis leak 那两组事实上没什么太大的差别但是都有一位病人 expire 那看他的 survival 事实上有接受 conversion surgery 的病人他好像效果最好当然这个有时候有一点 bias 因为我们已经把那个 response 不好的已经 exclude 掉了但是他这个效果呢大概是 18.8 个月。那当然年纪轻的或是他 initial PCI 小的少的或是没有 ascites 有比较好的 outcome 当然可以 complete cyto reduction 的病人他的效果也会比较好。那 performance status 比较好的，它的 outcome 也比较好但是一旦发生有 major 的 surgical complication 它这个prognosis 就非常差了因为我们没办法后续的治疗那我报告一下我们的经验像这个38岁的这个先生我们 laparoscope 看的时候到处 diffuse 的peritoneal seeding它 PCI 是27，那我们经过了 HiPEC 加 NIPS 以后，大概3个月以后再进去 laparoscope staging 进去看这 peritoneal 上面都变得比较干净所以我们就做这个 cyto reduction。那这病人当然活了32个月，但是不幸最后还是因为 PC 这个 relapse 死掉了那这个是61岁的男性他第一次进去的时候发现也是 PC而且有合并有 cirrhosis of liver 但是没有 ascites PCI 大概是22那我们做了做了6次的 NIPS 以后再进去看干净很多，当然 cirrhosis 还是依然 cirrhosis 但是可以看到这个phosphorigman 这些这个 seeding 都变得比较少了所以我们也是这个进行 cyto reduction 目前这个病人活了34.8个月目前还活着是不是 cirrhosis 反而活得比较久不晓得那这个47岁女性 initial treatment 是被当作是 ovarian cancer 治疗，但是 pathology 认为是 meta 的做个胃镜才 confirm 是一个 gastric cancer with Kuchenberg tumor 那我们在2-3个礼拜以后再做 laparoscope 进去看也是看到其实已经 PC 了已经 PC 像这些 pelvis 这些都是 peritoneal 上面都是一点一点那我们一样也是做了6次的再进去看呢事实上这些 peritoneal 上面就变得很少，当然这边还有一些有可能是 scar 的东西那这个PCI 降到7，所以我们这个也是手术。那目前23.4个月还存活了当然这个钟先生就进去的时候也是各位以前我们看到这些就直接关起来算了但是我们给他治疗PCI 是28ascites 大概1500 cc， 那我们治疗以后第二次看起来非常的干净PCI 只剩6但是这个 case 因为发生了一个 major complication 就是 GI leak 后来这个一直治疗这 GI leak 最后还是因为 pneumonia 在开完 cyto reduction 以后5.5个月就 expire 了那当然这43岁女性她也是进去就是到处都是尤其是像这个小肠上面都是一 seeding 的现在这种通常都没办法手术因为你小肠没办法切太多如果大肠是没关系把它切掉也还好像这个看到也就是35个PCI 35大概3700 cc 的 ascites 那做完 NIPS 以后呢各位可以看到它这 peritoneal 上面很干净小肠上面好像已经没有一点的这个 tumor当然这有可能是 scar 死掉的 tumor 当然我们这个病人也是给他开刀但是这个病人也不幸因为 pneumonia 在开CRS 以后3.2个月死掉所以各位可以知道一旦有complication 发生它 prognosis 就会很差 那这个柳先生，各位也可以看到哦，满坑满谷的这个整个肚子都是这个 tumor nodule， 非常非常的多，尤其是 mesentery 上面。哦，那我们把它做了这个 NIPS 以后，哎，看起来是好很多，当然还是有一些残余的，但跟这个比起来是好很多。那我们这个也是做，虽然它 PCI 还是比较高一点，12。哦，我们还是给他做 cyto reduction， 大概目前还是活着哈，10.5个月了。那这个吴先生呢也是一样，进去比较年轻啦，42岁啊，进去的时候也是这样子哈。那做完以后看起来也是比较干净，好，但是这些看起来是 scarred 啊，好，我们给他三分哦 ，PCI 3分 ，survival 目前是15.7个月，还 survival。好，所以呢，我们的感觉哦，就是这些病人哦，做完这个 laparoscopic HIPEC 加 NIPS 以后，是让他 quality of life 哦会改善。那为什么呢？我们认为可能是一些 ascites disappear 哦。那因为这些 PC 的病人哦，大部分都合并有这个 migraine ascites， 尤其有时候会 massive ascites 哦，会造成很多 complication 哦，叫 poor appetite、cachexia 啊这些。哦，但是如果用这个方式呢，降低它的 ascites， 事实上是可以在一段时间内有效的改善病人的这个 quality of life 哦。那当然最严重的就是 GI leak 哦，大概文献上报告大概5到40% 的病人哈，有这个 GI 会造成 GI leak 哦，一旦发生 GI leak 哦，不管对病人对医生都是 disaster 哦，会有一个 negative impact on 这个 survival。好像我们的 series， 我们的病人呢，哦，有6个，造成 GI leak， 哦，只有1个呢活超过1年，其他5个都是1年内就死掉了哈。所以当然这是我们的简短的 summary 哦。那事实上这个 procedure 似乎是一个reasonable 的这个 therapy 哦，对于 gastric cancer with PC 的病人啊，尤其是有 high P 这个 PCI 的病人哈，那直接手术似乎是不太明智的哈。那当然这个 procedure 可以有效的改善病人 quality of life 哦，尤其是有 ascites 的病人哦。那当然 conversion surgery 啊，在没有更好的 systemic therapy 出现之前呢，或许是一个很这个给病人或是给医生本身有个希望的病人。当然我们要 selective 病人哈。一般来说是对于 neoadjuvant therapy 有 good response 啊，这个手术以后它可能效果会比较好。对于那个response 不好的病人哦，你即使再怎么样处理哦，可能效果也不会太好。好，那我现在就简单的报告到这里，谢谢各位。
非常谢谢詹主任的精辟而且初步有好的成果的演讲。不晓得各位先进有没有问题？哎，李副院长。
早上哈，我有问过那个 Dr. Q Mask 哈 ，Kusa 还 Dr. Kusa， 我今天在同样的问题再请教你，就是说哈。那个现在文献 review 还有实际上的经验看起来，如果说 PCI 呢在11到15之间呢，那做 cyto reduction 加 HIPEC 对临床上统计上是好像有一点帮忙啊。如果太严重了或者太轻了，大概看不出来这样子。那但是这些已经都是 Stage 4的病人了啊。如果说做完1次以后，后来如果是在CC complete 的那个结果是0或者1，看大部分也是可以到这个程度。那以后如果他在 recurrence，你们有没有做repeat HIPEC 的经验，或者你们的看法是怎么样？
其实 PCI 多少可以手术啊，就 depend on tumor 的种类了哦，像是 ovar cancer 啊，或者是那个粘液性的肿瘤，它通常可以允许 PCI， 甚至20几它都还开。但是一般来说 gastric cancer， 他认为至少12以下，甚至有些 paper 认为6以下，它效果会更好。那 recurrence 事实上我有几个经验，但是我们这种通常很难开。那我们进去哦，也是只是再洗一次 HIPEC， 然后再摆一个 port 哦，可以给它 做所谓的 NIPS 啊，但是你如果要做 cyto reduction， 那大概机会不高了。如果你第一次已经做了 cyto reduction， 要再做的机会不高哦，可能会对病人或是对医生都是很 suffer。我认为不要轻易尝试啊，因为很容易把肠子弄破。对。
好，因为 HiPic 加NIPS 哈，因为是一个新的一个 modality， 所以未来我们期待詹主任再有一些新的累积一些更新的经验，特别在胃癌这方面。那因为时间的关系，我们再次热烈掌声，谢谢詹主任哈。
好，我们请理事长留步，那个老师，我们有那个感谢函跟礼物啊，要致赠给我们理事长。我们下一个 section 是我们那个郑安理院长会为我们带来关于肝癌的一些讨论。那我们请那个陈所长帮我们介绍。
谢谢给我这个机会来介绍郑安理教授。我想郑安理教授大家应该都很熟。郑教授从台大毕业以后，他到目前为止都还一直留在台大。然后他在肝癌上面的成果，其实大家都有目共睹。现在全世界大概有7个药是被核准使用在肝癌的 systemic treatment 上面。有3个郑教授是 major 的 contributor。在过去几年，其实他除了肝癌，他也对台大的癌症中心医院做了一个很大的 contribution。今天他来跟我们介绍肝癌的治疗在这些 systemic treatment 有这么大的一个改进以后，对肝癌的治疗到底发生了什么样一个变化？那我们就谢谢郑教授，谢谢。
非常谢谢陈理事长的介绍。今天也非常荣幸可以来参加我们林天佑教授的一个 surgical lecture。也刚好陈楷模教授的一个等于是纪念的一个会议的当然，林教授应该是在我大3的时候退休的，所以我们大概所有人都要听过林教授的大名才能够毕业。那陈楷模教授更不用讲了我虽然在内科，不过每天都还是被雷公震到，就当时的这个陈教授的大名。今天我很荣幸来讲这个 talk 因为过去的10年，这个肝癌从不可治疗疾病现在已经变成越来越容易治疗的疾病那这个改变当然是从比较 advanced stage 开始，所以我今天的重点在讲，那这些治疗对于 surgeon 到底有什么影响？对外科医师它的影响是什么？那这个是我们今天的重点所以我特别提到，大概对于这个 stage guided treatment 因为目前比较 dominant 的 treatment agonism， 比方说 BCLC 它就是一个很典型的什么 stage 做什么治疗，什么 stage 做什么治疗比方说 A 那它才能够开刀等等的，那这个都是所谓 stage guided 的 treatment algorithm。但是那个是在这个世界上没有有效的治疗 systemic therapy 的时候，那今天呢，很短的时间里面，世界发生很大的变化，所以未来我们要合作的是怎么样把这些用来跟所有 stage 的病人共享，而不是只有用在末期的癌症。那这边就有一张 slide， 就是介绍过去13年肝癌全身性治疗的演变。我们知道在2007年之前，没有一个化学治疗是被认证的，所以也就是说没有任何一个药物可以治疗肝癌。但是在2007年，我们出现第一个药物，这是一个 TKI， 就是所谓 tyrosine kinase inhibitor。那这个 TKI 叫 Sorafenib。 那时候在亚洲的成绩是 response rate 3%，survival 7个月啊。那这个成绩啊，至少我不敢跟陈定信教授报告，他每次看到我们这成绩就说：“哎呀，你们不要再搞了啦，开玩笑吧，这个啊100个只有3个 response，喝可口可乐也会消了。”我那时代确实是这样子。那这个治疗不怎么样，毒性也相当的大，哦，所以虽然是唯一的药，但是呢，大部分医师并没有把它看得那么重要，哦，虽然是第一个 FDA 核准的药。那经过了10年呢，我们有另一个药叫 lenvatinib， 它还是一个 TKI， 但是它的 response rate 比较高一点，不过 survival 是差不多的，毒性也差不多，哦，这就是在 TKI 的时代。那诸位都知道，从2017年开始，肝癌也进入免疫治疗时代，啊，就是所谓 checkpoint inhibitor 啊 ，immune checkpoint inhibitor， 那可以用单一治疗，看起来呢 ，survival 15个月 ，response rate 15%，其实跟 TKI 差不多。那唯一的差别是它毒性比较小一点，哦，毒性比较小一点。这是到2017，那这过去的那一年，其实是一个蛮震撼的发展哦。这个 study 发表的时候，大家看到它的 response rate 突然跳到30%，这个数字就大家有感了哦。10个病人就有30个肿瘤会显著消下去，有5个人末期的肝癌可以完全消掉，哦，所以这是一个极大的变化。那 survival 就跳到20个月，那最重要是毒性是没有什么增加的，哦，所以对病人来讲，这个治疗是接受度最高的，因为每3个礼拜打一次，没有什么太大的感觉，啊，有30%的病人肿瘤会显著消下去，最重要是生活品质会大大提升，病人的症状会消下去，啊，所以他觉得活得比较好了，不像在 TKI 的时代，医师跟他讲你肿瘤有消，但是病人说先生我吃甘苦，就是我们当时的感觉，因为那个药的副作用都要慢慢去克服。所以在2020呢，我们终于看到一个很重要的一个进展。那展望未来，哦，我们可以看到以后各种各样的 combination， 尤其是 checkpoint inhibitor 加上 TKI， 它的 response rate 可以超过40%， 它的 survival 可能会超过25个月。哦，到那个时候，我们可以说肝癌的 systemic cell 成绩已经跟很多很不错的肿瘤类似了。那这个时代上就变了，哦，所以这是一个我们过去13年的变化，哦，这个 response rate 从几乎没有到可以到40%， 那 survival 从不到4个月，现在可能可以到25个月。好，那今天的主题呢，不是要谈这些对于末期癌症的治疗，我们要谈的是，那这些治疗对于外科医师会有什么样的改变？哦，第一个，它会使我们的开刀呢，可能可以更 aggressive 一点。哦，这个等一下我再解释。第二个，它会使疾病呢，从 right to left migration。大家如果是做肝的，可能知道 BCLC 肝耐 Stage A 开刀换肝，B 要栓塞 ，C 要做药物治疗，都写得清清楚楚。它的 guideline 里面开宗明义就讲 ，We don't allow left to right, we don't allow right to left migration。如果是一个 metastatic disease， 你绝对不要给我开，听起来合理啦，但是这个观念可能慢慢就要改了。等一下我会跟大家报告。那另外一个就是我们从这个上面这个马上你各位看到这个不同。我们这是 BCLC 肝癌，我刚刚也解释了，可以开刀的病人是什么 ？solitary， 这个 liver function 要好，又要 solitary， 又最好不要太大，长的位置也要对那可以开。那这种开刀就是我们过去 dominant 整个欧美社会的当然我知道我们台湾不这样开的。 不过在全世界的共识是这样开。在那个时代，我们也没有什么好药。如果大家还记得，我们只有一个索拉芬尼，效果不是太好，副作用还蛮明显的。所以当时我们是很保守的。如果要做 adjuvant， 就开完刀做 adjuvant， 我们还是选这一群病人来做。所以说到目前为止，唯一一个大型的 adjuvant trial for liver cancer 就是用索拉芬尼，非常保守，只用在 BCLC 可以开的病人。那我们预期 median survival 会是5年，但是做出来呢，结果是我们预期是5年，不过最后呢，看起来可能会超过7年。我们知道超过7年的 survival 的病人，在其他的 cancer 不是做 adjuvant 的 candidate。通常我们不会去做 adjuvant for the low risk， 因为它已经那么好了，实在不需要再去做化疗了，做什么再做那么久。所以那个是过去，因为我们没有药。那现在我们有了有效的治疗，那会发生什么事？肝癌必须归队，肝癌必须归队，肝癌必须回到所有的 cancer 一样。adjuvant 是要给 higher risk 的人用的 ，low risk 的人基本上不需要做 adjuvant。你如果看目前所有重要的4个大型的非属力临床试验来探讨 adjuvant 是不是要用，现在有4个trial都是大型的，4个处方包括刚刚我提到的 atezolizumab 就是 atezolizumab 加 bevacizumab， 这个 response rate 高达30% 的这个处方，另外 single agent 的，还有另外一个 combination 就 durvalumab 加 bevacizumab， 这个都是大型的临床试验，他们的病人呢都是 beyond BCLC resectability， 是 BCLC 的 criteria 里面不应该切除的。同时呢，还有2个 study，atezolizumab 跟 pembro， 他们甚至可以包括有 portal vein invasion 的病人。意思就是你只要开干净了，接下来就是 adjuvant。这个观念在所有其他 cancer 都是这样，只有肝癌不是那现在回到正常了，只要你开干净之后，1个月后 imaging study 没有看到 tumor， 那你就可以进入 adjuvant。那这就是这4个研究他们都是在 adjuvant study， 在2年后，这4个研究都会陆续发表。发表之后，我们预期啦假定 any one of them 是 positive， 那我们以后 adjuvant 的对象就不一样了，我们会针对这些比较 high risk 的病人。当然我们都知道，我们在台湾开的病人很多都是这里的就是 BCLC 不能开的，但是在台湾是开的，在其他国家也是开的但是在过去这一群病人是欠涉未明那未来这一群病人你本来就该开，把它开干净，进入 adjuvant。那我们这样做，当然我们知道这个比较危险的病人复发率比较高嘛，他的存活率可能会是这样，不像我们在 BCLC-A 那些病人。但是呢，我们经过 adjuvant， 我们希望他的 survival 会 improve 20%， 就是我们未来的希望。那另外一个有效的这个免疫治疗，我现在强调的是免疫治疗，它会让我们的 treatment 从 right to left migration。以前 BCLC 不允许 right to left， 但是未来 right to left 会是一个常态。什么叫 right to left？ 我们先要来看免疫治疗跟 conventional， 不管是化疗、标靶，它的 tumor 剩下的 tumor 有什么不同？比方说你有8颗 tumor， 那你给他做免疫治疗，它剩下4颗，其他的4颗也变小，达到 PR 的 criteria。那这样的 tumor 在标靶治疗也有在化疗我们也看过但是你看在标靶治疗时代 ，responder 的 survival curve 其实是长这个样子。那你如果比起免疫治疗的 responder 呢？这边虽然写 CR、PR， 其实大部分都是 PR，CR 很少很少。PR 的病人，他的 survival 是可以经常都会超过好几年，有70%，他的 tumor remission 会超过1年。很多人说，那你 immunotherapy 之后的 tumor 刚我用 conventional therapy 的 tumor， 它差在哪里？它有很大的差异啊。这个差异将来会是外科医师一定要知道的。啊，这个就另外一个 study 啊，一样，这是最新的，2020发表的，一样 ，durable remission 常常会长达2年、3年、4年，所以这个时候我们外科医师做 local regional therapy 的医师，我们大家都要再坐下来讨论。那你剩下这3颗再来怎么办？剩下这4颗你要怎么处理？啊，这会是一个每天要面对的问题。那第一个，我们来看到底差在哪里？用 conventional treatment 化疗或是标靶跟免疫治疗，它剩下的 tumor 长得差在哪里？它最大的差别 ，residual tumor conventional 是比较 short response， 它基本上是一个 apoptosis 啊，如果大家还知道细胞凋亡，标靶治疗、化学治疗都造成细胞凋亡，凋亡之后没有 immune reaction， 在旁边是没有什么免疫细胞，剩下的肿瘤如果是免疫治疗呢，它是 durable response， 它会处于一个所谓 quasi immunoequivalent 的状态，一个准免疫平衡状态。这是什么意思呢？我们来看 neoadjuvant 的病人，这是一个做 neoadjuvant 的，这个他做 neoadjuvant 的免疫治疗3次以后，这个肿瘤如果用 mRECIST 来看，它事实上是空掉了哈。那这个是一个 neoadjuvant， 所以他们就把它开下来，所以这事实上就是一个 responder 剩下的 tumor 它长什么样子？这是开刀前的 tumor， 就是开刀后用过免疫治疗，很明显的用过免疫治疗的 tumor， 你切下来以后里面就是免疫细胞，它不等于一个 cold death。如果是用化疗或是标靶，它死掉的状况我们叫做 cold death， 它死掉但是旁边没有免疫反应，这个是免疫细胞去杀死癌细胞，所以旁边是充满了免疫细胞。这是另一个病人是肺癌的。肺癌的 neoadjuvant 早在4年前就完成研究了。那 neoadjuvant， 你如果做 CT， 你还是看到还有 tumor， 你因为 neoadjuvant 你就把它切下来，这里面几乎全部都是免疫细胞，只有 less than 10% 的 cancer cell。那这个 tumor 呢，在经过免疫治疗以后，它变大了，看起来似乎变大了，但是你把它开下来之后呢，里面是没有半颗 cancer cell， 它里面全都是免疫细胞。也就是说，免疫的治疗是让免疫细胞去攻击 tumor， 化疗或是标靶，它是直接把癌细胞杀死，而且是 apoptosis， 所以它不 induce immune reaction。这个差别对外科医师特别重要。理由是这样，这个也许大家在基础医学的时候念过，一个 cancer 是怎么来？当它从正常细胞开始变成癌细胞的时候，人体不会无动于衷，人体会产生 immune reaction， 要把它赶走。但是过了一会儿，几年之后，慢慢的进入一个 equivalent state， 就是说你没有办法赶它走了 ，cancer cell 已经跟你可以共存了。但是到我们面前的 tumor 全部都是 escape， 当 tumor 来到我们面前，那就都是很糟糕，因为它已经 escape， 免疫细胞是没办法压制它的，所以我们治疗的都是 escape cell。但是 escape cell 在用免疫治疗之后呢，它可以 back to equivalent， 它会再度处于一个 immune equivalent 状态，它也可以被 eliminate 之后呢，它就 durable remission。这些病人呢，是我们又把它 eliminate。本来是 escape， 我们又把它 eliminate， 但是有一些 residual tumor 呢，它事实上处在 equivalent 状态。这些 tumor， 比方说它在那边存在2年了，其实那个 tumor 里面增加了免疫细胞 ，tumor cell 没办法再长，但是也不会死。如果你这时候把它 kick 一下呢，它又可以回去 escape， 所以那时候你就看到有一颗 tumor 又 progress。这就是我们日常看到了。那我们把它做个 scheme， 就肝癌目前的成绩，未来也许更好。我们现在的成绩 做免疫治疗之后，对不起，我们给他做免疫治疗之后呢，现在是有 5% complete response， 现在是 5%， 这些病人当然就看不到肿瘤，我们暂且把它称为 immune elimination。这些病人我们不准备做什么，但是呢，他会有25%，他是处于 partial response。记得 partial response 70%都会 durable， 他会一直在那边，也有大概5% 是 minor response， 是 minor response。这些加起来也许将近20%，它处于一个 equivalent 的状态。那这些病人要怎么处理？如果他是 resectable， 他可能适合做 resection， 虽然他是从 advance 跑回来。如果他暂时不能 resect， 比方他还有剩下6颗，那我们可以 observe， 等到有一天有一颗长起来 ，isolated escape， 我们可以把这一颗拿掉。那这是一个在跟过去的治疗是全然不同。我举这个例子来看，这个病人本来的 tumor， 那我们给他做免疫治疗，24个礼拜后，比较明显的慢慢的不见，这个大的也变得比较小一点，但是在第4、4个礼拜的时候，你看到其他的都还是 under control， 但只有这一颗，它的下端出现一个 escape。那这个 escape， 我们是不是该把它拿掉？在过去的观念里面，我们绝对不会做这个事情，理由是其他的 tumor 大概过一阵子就全部长出来，但是我们现在知道，其他的 tumor 是 under 一个 immune suppression， 它会 durable， 这一颗 escape 会杀死病人，所以我们决定把它拿掉。拿掉之后呢，没有再给药了。过了2年，病人还是全身都是 disease free。这也是免疫治疗造成的 remission 跟其他的 conventional 极端不同的地方。那一颗 tumor 拿下来，你可以看到一个 typical 的 escape。这个 escape 是怎么 typical 呢？它没有免疫细胞了，免疫细胞都被挤在旁边，它就是一个 new clone。我们身体的免疫细胞再也不认识它了，再也杀不死它了啊！当然了，我们临床实际上看到状况会比这个复杂，会比这个复杂。我刚刚讲的是最简单的 scenario， 不过事实上呢，我们知道 durable remission secondary escape 可以是 isolated， 也可以是 multiple。比方刚刚那个病人，他本来有5颗，只有1颗 escape， 但是他如果有3颗 escape。那这是什么意思呢？要怎么办呢？这个 complete response 的病人也可以产生 escape， 那这个 white mat 的病人 ，oligo mat 变成 white mat 呢？事实上，我们是可以把它 convert 再变回去。所以对治疗学来讲，只要我们能证实这个 tumor 是 under immune suppression。我们必须在它 escape 之前把它处理掉，这是一个我相信对我们外科、对我们内科都是一个新的观念，因为是一个新的治疗跑出来了。那未来呢？我们当然希望，我们不是用猜的，我们可以很清楚知道这一颗就是一个 immuno-equivalent 状态，那一颗不是，这一颗是。我们有没有办法这样做到？这才是关键哦。那要能做到它吗？未来应该可以因为现在已经开始看到慢慢出来，这个叫 immunopad。immunopad 的观念就是把免疫细胞长出来，把免疫治疗用 pad 的方法把它变亮。像在这个 case， 你可以看到它长的是 anti-CD8 T cell， 那你可以看到这个病人基本上在肌肉里面有一颗 tumor。这个 tumor 呢，里面是有 T cell， 那这一颗我们不要等它 escape， 我们就把它切下来，这就是未来的一个走向。所以未来我们知道呢，经过免疫的治疗呢，事实上这些界限都会变得很模糊。未来我们在看的晚期的癌症呢，我们治疗之后，还是要请各位外科医师 我们一起再来商量，我们要把哪几颗拿掉，这样可以 prolong 病人的 survival。这就是未来整个免疫治疗会对所有的医师都会产生影响，对所有病人也有影响。那这是我今天演讲的 summary。过去的13年，我们的 response rate 从3% 到30%，survival 从7个月到20个月。那我刚刚也今天没有时间提，那未来的治疗会是什么？我们有设计出几种新的治疗，那一定可以把 response rate push 到40%。那 survival 会进步到多少？现在不敢讲。那这些有效的 systemic immune therapy 呢，它会 change 所有 stage 的治疗。这就是我们要特别希望说，未来我们的病人要拜托诸位呢，不要嫌我们烦，因为这些病人开刀真的可以救他的命。谢谢大家。
我们谢谢曾教授精彩的演讲。我想其实现在很多的 cancer 都这样，我要是不听到 hepatocellular carcinoma， 你说 chemotherapy and pancreatic cancer， 好像现在是这个样子。所以不过我觉得这个是以后是 multidisciplinary 的 treatment， 应该会在很多以前困难治疗癌症都会产生一个很大的一个治疗的效果。那所以郑教授的 talk， 不晓得各位医师有没有什么样的问题？是叶教授。
郑教授，您的演讲让外科医师非常受到鼓舞啊。那刚刚有看了一个 lung cancer 的，做完这个 immunotherapy 之后，它的 tumor 变大了。那请问这样的变大是常态还是偶尔发生还是什么？因为对 surgeon 来讲，我们看 tumor 外科医师头脑最简单啊，这个肿瘤变大了就表示 disease progress。但是如果从 immunotherapy 的角度来看，里面是充满了这个 immune cells。那请问，我们怎么去判断？除了刚刚您后来说发展的这个 immune pad 之外，有没有什么可靠的办法？
谢谢。我想这是一个就是最关键的问题啦。那到现在为止，其实唯一的办法就做 biopsy，但是做 biopsy 又不实在。你有那么多 tumor， 怎么可以每颗去做 biopsy？ 所以才会出现 immune pad。那像刚刚那个免疫治疗以后稍微变大，那个我们叫 pseudo progression， 它看起来像 progression， 因为我们如果做影像的话，但其实它是免疫细胞的浸润。虽然影像看起来好像大家一样，这时候好像肝癌会好一点，因为肝癌有一个叫 mRECIST， 它是看 perfusion， 不是只看那个 imaging 还有一个 vascular perfusion 的观念在里面，但是看起来都还不太够。那真正我们在文献上看到报告 pseudo progression 的从3% 到30% 都有，所以表示说从临床上的判断其实靠不住的，所以我们也没有办法，因为像刚刚的病人他要是没开出来，没有把它开下来，他的诊断就是 SD 啊，因为它 size 差不多嘛，就是 stable disease。
谢谢李教授先。
谢谢郑教授很精彩而且启发性的演讲。我想请教一个，就是说 tumor 有时候是会有 capsule fibrosis 的那 immunotherapy 或甚至于现在的 cell therapy， 有没有办法 penetrate 进到 tumor 里面？如果不能进去的话，你赞不赞成 radiation 以后再治疗？
好，谢谢。这个李教授这个问题非常重要了到底我们 immunotherapy 跟那个 anatomy 或者这个 pathology 这些变化的关系吧如果它有整个 capsule 有 fibrotic change， 那到底会不会影响 immune cell penetration？ 我们的 gut feeling 是说会。That's why 我们要加上像刚刚说 atezolizumab 加上 bevacizumab 的目的就是增加 T cell penetration， 它可以让血管那个阻力变小，所以 T cell 比较容易进去 tumor 里面。不过这些到目前都是理论啦。刚刚我们看到atezolizumab加 bevacizumab 毒性没有增加，效果变那么好。我们的理论就是 bevacizumab 可以促进 T cell 的 trafficking， 同时也可以促进免疫环境的这个 promotion。但是这个都是一个还是很难在人体里面证实，我只能这样讲。所以我们现在只能说有些第一卷真的是，比方说它里面都是 sclerotic change， 里面都是 fibrosis， 其实那个 tumor 里面的 interstitial pressure 非常高 ，pressure 越高或者 pH 值越低，它对免疫是很不好的，就是你根本你的正常的 immune cell 是没办法进去的，或者进去它也不太被活化嘛，所以这些就是我们现在用其他的这个 combination 希望去解决这个问题。
因为时间关系，最后一个问题。
谢谢郑教授的演讲，其实每一次都受到很大的启发啊。这么多年跟着郑教授，其实也学习很多了哈。那我有一个问题是说，我们有一些比较 advanced 的 disease， 那 technically resectable。那以现在郑教授这样子的想法的话，您觉得我们是应该让他先做一些 systemic therapy， 然后看他的 response 再来做手术？还是说我 technically resectable， 我就还是把它切掉？啊，我想请教一下郑教授。
谢谢何教授的问题啊。我想，如果是我们台湾派的，我们当然都会先切掉嘛，这是我们台湾的 practice 啦，也是我们 East Asian 的 practice。然后再说 systemic therapy 是不是先做再开，还是先开了再做？就是所谓 neoadjuvant 跟 adjuvant 的差别。那 neoadjuvant 跟 adjuvant 呢，我们现在还没有 head-to-head comparison。我们台大有一个 neoadjuvant， 但是没有 head-to-head comparison。所以如果 neoadjuvant 效果非常好，那再说吧。如果 neoadjuvant 出来不怎么样，那我想大家还是会同意先把它开干净再说了。
我觉得另外一个是可能是要回去看看所谓这个 technical resectable 的病人到底以前开过的 outcome 不晓得怎么样。我觉得可能要把那个 data 弄清楚了，然后看看要做 neoadjuvant 还是做 adjuvant。
我想这是一个在你的 systemic therapy 效果越来越好，我们大可以把它变成更好开，就不要让你这样 marginal resectable， 我们让它 definitely resectable， 这样会比较好一点。
OK， 那我们谢谢郑教授，
谢谢
，very stimulating， 谢谢。
我们再次谢谢郑院长。好，那接下来是由我们台大陈嘉宪教授会为我们演讲关于那个 radiocell， 请陈院长。
陈嘉宪教授是台大医院这个肿瘤医学部和的放射肿瘤科的，还有是临床医学研究所的合并教授。那他除了做个以外呢，他还是国立台湾大学电子学院生医电子与资讯学研究所的合并教授。那陈教授是在这个阳明大学医学系毕业以后，得台大的 EMBA， 然后呢又得到在这个国立台湾大学电机的研究所的博士。那他得过很多奖啊，其中在2018年呢得到这个 Astro 的 Fellow Award， 还有2018年得到行政院的科技研究奖，杰出。那今天呢，他讲的题目呢就是 High Dose Hypofractionated X-ray Therapy for Hepatocellular Carcinoma。陈教授，请。
谢谢陈院长的介绍哦。我陈嘉宪医师很荣幸被邀请到这个纪念性质的研讨会特别是刚刚1点多的时候，可以站在外科医生群中照相感觉很有安全感特别的经历那今天来跟大家介绍一下放射治疗在肝癌目前的用法和 evidence 那放射治疗当然有体外跟体内的那体内的就是大家熟知的E-90，那是最下面那一条那这不在今天要讲的范围那今天主要是讲体外照射就是 external beam radiotherapy。那这个治疗大概已经有20几年，就是1990年代初期开始试用这样的做法，然后在那个年代才刚进到3D 的放射治疗，所以大致上在那个年代开始的时候， 大概都是用小的单次剂量，然后绵延5到6周的长疗程去做这样的治疗。那原因是因为那时候的科技大概对于准确度和单次剂量的强度还没有办法那么有把握的掌握了哈。那当然我们今天会介绍为什么会演进到今天甚至 SBRT 的少次数治疗。那今天我们要讲的当然就是从这种长疗程的治疗 move 到比较少次数的。那定义上面 hypofractionated 就是它的次数已经缩小到3周以下。那甚至 SBRT Stereotactic Body Radiotherapy 它是要在6次以下哦，所以它的次数不断在减少。那当然是借由单次剂量的提高来做这个次数少的这样的治疗。那市场上最常用的当然就是 photon 就是 X-ray 的治疗 photon 哦。那台湾慢慢有几家医院开始有这个 proton 质子治疗，他们都是放射线治疗，只是他们的放射线特性不太一样哈。等一下我们也会简单的带过。那科技的进步让放射治疗可以在设计这个肿瘤的照射的时候更精准，而且敢用更大的剂量、更少的次数去做这件事情。那放射治疗在今天用在肝癌的照射，有几种常见的状况了哈。那最常见的像 evidence 慢慢在增加的，应该是有一些病人虽然肿瘤不大，但是他某些原因或是他个人的考量，他不想做手术或者是电烧的时候，会替代的来做放射治疗。那这种小的肝癌肿瘤，其实病人在这些不适合其他治疗情况下来做放射治疗，其实效果会比我们等一下看到的大颗的肿瘤效果要好非常多。他们是会可以到影像上看不到的消退。那这是一种状况。那另外一种状况就是大到其他的治疗也无效的时候，特别是大到一个程度，然后侵犯到血管的时候，那这种情况下，当然现在有很多药物的 option 作为 standard treatment。但是如果在其他的考量之下，药物不合适或者经济上没有办法负担那些药物的时候，有时候对还是 localized 的这个大的 tumor 侵犯到血管的时候，会来做一个 salvage 的放射治疗。那这样子的放射治疗其实效果比小颗的就完全天壤之别。那一般大概都只能期待它把它 stable 在那个地方。那介于中间的就是在还没有进展到非常大的血管侵犯之前，经过其他的局部治疗之后，仍然在某些角度无效，慢慢在复发演进的时候，像是这个情况，像这个病人长在 caudate lobe， 那他经过几次电烧之后，在靠近血管这一面的热度一直没有办法达到杀死肿的效果，那这个地方一直 progression， 终有一天它就侵犯到血管。那这种是在局部治疗之后的复发来做的这个放射治疗，这大概是平常我们会收到病人的几种状况。那刚刚讲的市场上最常用的是 X-ray 的治疗，也是健保很常规会给付的治疗。那质子治疗是这几年台湾也慢慢有一些医院开始出现的。那主要的差别是剂量分布的差别。那光子就是 X-ray 的治疗，它会在皮下2-3公分就达到最高剂量，随着距离衰退它的剂量。那质子呢，它可以在它的路径上面只有1半以下的剂量，然后到指定深度才把最大剂量放出来。那过了这深度以后，就剂量又降到0。所以它质子的特点是在剂量分布上面。那因为这样子的特点，对于一个肝脏里面的一个区域的照射来说，它就可以把中低剂量也收得比较紧一点。也就是说，高剂量大家都可以达到不错的 coverage， 但是中低剂量因为质子有这种集中的分布的效应，所以它就可以把中低剂量也收得很紧，那会减少这个其他非 HCC 的部分的肝脏得到的中低剂量的量。那这个就是质子特点。所以因为这样子的特性，它可能技术上可以给更高的剂量，而不会伤及其他非 HCC 的肝脏。这是质子的不同。那今天我主要是分这3部分来 review evidence。那第一个是说目前evidence 正在演进的是小的 HCC， 那大家平常会用手术或者是RFA 的方法，那慢慢有一些 evidence 出来说，其实如果跟改成用放射治疗来比较的话，是可以有 equal effective 的状况。那第二个是大颗的和 还没有太多 data 的 immunotherapy 的加入放射治疗的想法哈。那这个从 single center 开始，我们会看到从2010年初期开始有一些 single center 会报告100人左右的这个经验哈。那 single center 当然难免有 selection bias 哦，那这个是韩国的 data 哈。那个时候还是 3D 为主的时代，它已经用到3到4次，只有非常短疗程的照射，一次都是10个月以上。那可以看得到 by size 来看呢，他们其实在小 size， 也就是3公分以下，其实它的 control rate 都在90%以上。所以这种小 size 如果 for some reason 来做放射治疗的话，其实对 local control 不是问题但是 size 一大到3公分甚至4公分以上的时候，它就会有明显的这个 control rate 的下降。但这个其实对 local control 放射治疗大概不是问题，只是我们很少说到这样的病人因为这样的病人其实在别的治疗也是很容易做那所以我们说到看到这个 series 里面，大部分都是经过别的治疗之后的病才来做这个治疗的病人所以 complete response rate 大概可以超过50%但是呢，比较大的问题仍然是在它的 disease course 里面，陆续在将来追踪的时候发生的这个治疗区域以外的liver 的 recurrence 叫 outfield recurrence 有2/3的问题，所以重点不是在 control 这一颗，而是其他地方日后的先发的肿瘤了那这是另外一个韩国 proton 的 data 这是三星的医院，他们在几年前装了 proton 以后，你可以看到1年之内就做了101个所以促销的相当厉害就是1年之内就收了101个的病人那它大小其实这个 series 大小大部分大概60%是 T1 T2 那40%是 T3 以上，所以有一点是它的前100个人的病例报告，那可以看得到它用的剂量和次数的强度更高了，因为它是 proton， 所以在 proton 其他非 HCC 肝脏剂量比较少的情况下，它可以给到更高的剂量那看起来这个大部分还是其他治疗失败之后才来做的病人那这个当然它秀的这个 response rate 当然是小颗的是非常好了，那大颗的大概就如我刚刚讲的，大概会把它 stabilize 在这个地方那看起来随着时间这 radiation 之后，它的 response 有时候要花到半年到1年才达到一个稳定的 response 所以在 follow 的时间要超过3个月以上，它可以看得到它其实可以到70%的response rate， 所以对控制那颗 tumor 来说，大颗一点的 proton 用高一点的剂量，对那一颗肿瘤其实不是问题。那问题仍然是这个 outfield， 就是你可能控制这里，在将来追踪的时候，别的地方跑出新的肿瘤出来。所以放射线已经对它治疗的肿瘤技术上还有科技上可以给到更高的剂量，更好的控制那也有少数的 report 因为今天是外科研，然后我去找到一些少数 report， 再把放射治疗跟手术对于小颗的去比较那这个部分 data 非常少，而且 data 的这个 bias 还蛮大的所以我举出2篇，一篇是中国的在广西的一个医院它是用 cyberknife 用电脑刀那它居然在这个医院的这个 series 里面用电脑刀做小颗的HCC病人比外科的 series 还多所以这是非常罕见的一个促销的手法那他主张在这个 report 里面当然是 retrospective 有很多的 selection bias， 所以你可以看得到他的病人的选择里面很自然的在手术或者是 RT 来说，手术的病人其实 performance 和基本状况是比较差的那所以他是主张在这种情况下的比较，放射治疗可以跟手术一样，对于他的这个 series 里面的病人有一样的 survival 和 control 的效果但是同样再去看一篇日本的那日本的就比较像现实大家理解的在他的 single center small series 里面有10倍的病人是手术了1/10的病人是 for some reason 去做 SBRT 的小颗的 HCC 那在这个 series 里面，因为 RT 的病人很少了所以他尝试去做 propensity score matching， 但是要去 match 这个1/10的病人，当然那个统计就非常不稳定，但是它呈现的情况就是反过来，也就是说不管他是全部的病人或是 match 以后的病人，其实外科的结果都还是在 survival 或者是单一科的控制是比较好的因为可能也是 selection， 就是说其实是不能做外科手术的才来做放射治疗了所以不管他怎么 match， 还是呈现说因为 compromise 的 selection 之后做放射治疗病人还是效果是比较差的那 比较有名的和进展比较多的 data 反而是 SBRT 比上这个RFA， 然后就是小颗的 tumor 哦。那在第一篇发表的比较有名的虽然争议很多的 series 是密西根大学，那密西根大学是做肝脏方的治疗历史最悠久的地方，所以他们在他们单一机构发表的161个病人做 RFA， 比上63个病人做 SBRT 当然这个 retrospective 也是会有 selection bias 那他们发现说，其实在他们的 series 里面，好像看起来大颗一点的大于2公分的 HCC， 如果病人是做 SBRT 或是做 RFA， 在 retrospective comparison 上面，大颗的2公分以上大颗的HCC病人做 SBRT 的那一颗的 control rate 是比较高的在这个部分达到统计的差异，而且是 independent factor 那当初发表这个 paper 的时候，整组人是有 borderline 的 0.01 的 P 值的 difference 在那一颗治疗的肿瘤。那后来细分发现说，小颗2公分以下的大概2种方法 control rate 差不多，大颗2公分以上的达到一个差别了那看起来其他的 survival 是没有很大的很惊奇的变化，但是在这一颗的 control 也就是说在这一颗的 control 看起来是集中发生在2公分以上的这个 subgroup 是 SBRT 是比较好。那这样子 paper 出来以后，引起非常大的争议，然后就是大家第一个是骂 JCO 为什么会登这种 paper 就是这个是好像不客观的理论单一机构 bias 很多当然大家也知道 paper 出版有很多这个科学以外的干扰因素了那我相信这一篇应该其中也有一些了所以很快的在1-2年之后呢，就有人用美国的 NCTB 就是他们的癌登资料去分析他们癌登资料里面的资料库里面做 SBRT 跟做 RFA 的，那这样子的人数也相差在10几倍之多了那这样子的 database 当然你看得到的只有 survival 和那一颗的 control 那另外是说你会data 来自于各种医院都会有，所以这个 bias 会比单一机构的又不太一样的 bias 所以可以看得到说，其实这2个治疗的选择的病人的 comorbidity 就先天上会有一些不同 ，stage 也倾向于 SBRT 的病人 ，stage 就是会比较高那 fibrosis cirrhosis 的情况也是 SBRT 的病人会比较差，那 tumor size 其实也是 SBRT 的病人会比较大一点，但这是符合临床 practice 在给病人选治疗的时候的一个想法那最后比较起来又跟刚刚密西根大学反过来就是 RFA 的族群呢是比 SBRT 的控制要好而且是 survival 要好了那当然这个也是有一些其他的争议，因为 database 来自于各种不同的医院，那也来自于治疗的选择的背景资料的不同比如说年纪啦或是年份啦，那而且年份比较奇怪的是它把它切分成2段年份，比较早年的时候呢其实是 SBRT 比 RFA 好，比较近年呢反过来是 RFA 比上 SBRT 好，那看起来就是美国人在学 RFA 这个技术的时候，在早几年的时候其实操作的并不是那么纯熟了，那后来慢慢纯熟了之后，他的对这个病人的 control rate 就比较好所以其实你从细项来看，你会看到很多这个可能的 bias 造成这个 data 的不同那但所以你去看说，其实在 tumor size 的这个次分项来说，其实 RFA 比 SBRT 好，就是没有 cross 这一条 1.0 的情况下，大概是这个 tumor size 不能太大的情况下，太小或是太大，大概这2个 modality 大概都差不多了就是小的大家控制都很好，大的大家控制都不好，那只有这个中间这个比较是 RFA 稳定的胜过 SBRT。那另外一个比较惊奇的发现就是data 来自的这个 institute 呢，发现说如果是比较 academic center 呢，那 RFA 是稳定的比 SBRT 好。那这个可能反映 technique 上面的好坏的不同，也就是说可能这 data 的 bias 是来自于有一些地方它的 RFA 其实做的或者是 SBRT 做的跟 academic center 的 quality 不太一样所以虽然是发表了一个平衡的这个 data， 但是争议还是非常多了那这个是最近今年发表在 Journal of Hepatology 的第一个 randomized trial 那它是用 RFA 比上 proton 比上不是这不是等一下跳太快了，这个是我们亚洲 几个国家合的 data 哦，就是除了看美国的 database 之外，亚洲有一个我们做肝癌的这个 RT 的专家的组织，总共有7个医院合了2000多个人的 data 哦，也是想来看看亚洲的 data RFA 比上 SBRT 有什么差别哦。那这个是它的这个 graphic abstract 哦，就是 RT SBRT 比上 RFA 哦。那看起来在这个 recurrence rate 来说，在亚洲的 data 好像乍看之下好像是 SBRT 比较好。那我们细看下去哦，那这有2000多个病人的 database， 里面有500个人是做 SBRT，1500个人是做 RFA 哦。那台大当然也贡献了相当多 RFA 的病人哦，台大大概是7间里面第2多的医院了哦。所以看起来，其实在先天的这个 characteristic 的差别来说 ，SBRT 确实收到是比较弱的病人，而且病情是比较严重的病人，它就有先天的差别了。那 SBRT 的技术有好几种哦。那在其他的这个 characteristic 来看呢，其实看起来这个RT 收到的病人都是病情比较严重的病人，而且是先前的治疗种类比较多，复发才来做 RT 的病人哦。那在整组病人的比较起来，没有做 matching 之前，这个 RT 的 recurrence rate 单一颗治疗就是治疗肿瘤 recurrence rate 是比 RFA 要少一点点，那 P 值倒不是非常低了哈。但是如果做了 propensity matching 之后呢，这个距离就再拉开了，所以看起来就是两年的 local regional recurrence rate 呢 ，SBRT 是在2成，那 RFA 大概是2.3%，然后在没有 match 之前 ，match 之后大概是1.6%比上3.1%的差别，然后那这个是跑出统计上的差别。但是在 mortality rate 来说呢，其实在这个 data 没有 match 之前呢，看起来好像是这个 RFA 的这个 mortality rate 比较高，但是其实 match 之后呢，其实它是一模一样的哈。所以其实这个代表是什么？其实这一颗这少数小颗的治疗来说，这一段可能大家可以在某些选择下打成平手，但是其实大家病人面对的是后面的复发，继续复发造成 survival。可能在前面的 modality 是没有什么影响的。那 toxicity 上面 SBRT 多一点点 low grade toxicity 3、4的就没有差别了。那在这个trial score 的治疗后的上升来说 ，SBRT 比较有这个 trial score 治疗后上升的这个短期的效应了。那长期可能就没有差别了。那另外指出来的是说，如果 tumor 大于3公分，又在 subphrenic region 的话，那这个部分是 SBRT 比 RFA 控制率好的最主要的一个族群哦。所以在技术比较困难的 RFA 的族群来说 ，SBRT 其实贡献的 control rate 其实是比较好的哈。那另外第一个发表的今年发表的这个韩国的第一个 randomized trial， 它是用 proton 比上 RFA 哈。那这个发表在 Journal of Hepatology 是因为它是一个 randomized trial 的 level， 虽然是单一机构哦，72个病人比上72个病人哦。那所以他们在一开始的比较上来说，因为是 randomized trial， 所以其实是比较 balance 的状况。那它是用2个礼拜10次的 proton 来治疗，剂量也是给的蛮高的哦。那 follow up 到了51个月哦。那看起来是从这张图，它特别用2年、3年、4年来做这个，不管是 per protocol 或者是 intent to treatment 的比较，你可以看到没有跨过 1.0 这条线的，都发生在2年的位置哦，到3年到4年就都跨过中线，跨过中线表示 RFA 跟 proton 是 equal 的哈。那在2年的时候都没有跨过中线，所以这个效应是集中在2年内的 follow up， 也就是说。proton 胜过 RFA 其实是短期效应啊，短期效应的意思就是说，它其实可能只是面对前段的这个病情，在治疗的选择上的差别。那对 long term 来说，这些病人可能还有不断的复发的状况，后面可能就无关这前面的控制率的差别了哈。那看起来这个差别只有在2年的数字才有差别，到后面这曲线就又交杂在一起，所以整体的 P 值是没有办法在这个 control rate 上有差别哈。那但是在2年的时候看起来 proton 是比 RFA 要好一点哈，所以这个是值得大家注意。虽然说是 non-inferiority， 但是它其实是在前面2、3年才有这个 benefit， 再久一点其实就没有这个 benefit 哈。那这个提供大家做选择，因为它再久一点面对的其他的 recurrence 其实也是5、6成以上的状况哈。 好，很快的走过small 的哈，那再来 advanced 的哈，那这个部分的 data 虽然很多，但是 randomized trial 只有1个了哈。那这个是韩国 combined 的 data， 当然有 retrospective selection bias。那他只是主张说，在大的 advanced tumor， 其实 combined modality 其实在统计上 always 都可以跑出比 single modality 要好的结果了哈。那在几年前有这个 meta analysis 在发表在 JAMA Oncology 去比较说TAC alone 比上 TAC 加 RT， 那可以看得到它的 survival benefit 看起来是有存在的，但是有合并了比较多的 side effect 当你多加一个 RT 的时候，那这个都是在 randomized trial 之前想办法用各个 trial data 去做 meta analysis。那唯一的一个 randomized trial 是韩国发表的，在2018年的 JAMA Oncology， 那他们是比较这个就是vascular invasion 的 HCC 病人呢，那一个 arm 是只有给 sorafenib， 那另外一个 arm 是 TAC 做1次以后，然后做 SBRT， 那这样子的 liver directed treatment 比上 systemic treatment 所以这是在当时比较独特的一个比较啦，因为药物的进展其实 randomized trial 早就用在这群病人是 standard treatment， 所以但是 local treatment modality 的 team 一直觉得说 HCC 的病人 liver 的 control 还是会贡献 survival 相当大的比例，所以有这样的 randomized trial 出来那他的照的 RT 呢，其实并不是所有 tumor 都照，就是 tumor 沿着 portal vein thrombus 以外的 liver tumor 给过2公分的这个照法除非他 tumor 是在这个范围里面，如果超过这个范围，他也只有多加2公分的范围去做那 TAC 就是传统的 TAC 之后再给 SBRT， 它的comparison 是 sorafenib alone 那看起来就是在后来的结果发表来说，其实所有 liver directed treatment 比上 sorafenib alone 来说，这个差别都蛮大的那因为主要是对于 liver 里面的 control， 在这个 vascular invasion 的次族群的病人里面 ，liver recurrence 常常是它最常见的一个 recurrence， 所以在 TAC 加 SBRT 和后续的 TAC 的这个族群来说，它的 liver control 都比较好而且这个好最后 translate 到 overall survival 的好所以这个 data 当然你不会全部应用在全部的病人上面，但是它只是要诉求一个说 HCC vascular invasion 的病人，因应它的 liver recurrence 是 compromise survival 一个重要的因素。如果走的是 liver directed treatment 的话，它可以对于 sorafenib 比较组来说有比较好的 control rate 跟甚至 survival 的 difference。那看起来就是也是在前几年的效应当然 liver response 来说，当然 liver directed treatment response 是好很多 sorafenib 就是大家熟悉的 sorafenib 的 response。那这些呢 switch 就是它在2个 arm 之间 switch 也大部分都是对 sorafenib response 不好 switch 到这个 TAC 加 RT 的组别所以它贡献的这个 knowledge 就是说在我们面对的病人的逻辑来说，你要选择 liver directed treatment 还是 systemic treatment， 你要评估这个病人的复发的状况会是比较 liver 为主的状况，但是它比较的是 sorafenib， 所以你可以说 sorafenib 并不是现在的观点一个最强的药物了那这个是其中一个图啦，就是说这个病人 response 非常好，即便没有照他全部的 SBRT 没有照他全部的 tumor， 但后来烧得非常好，最后 resect 下来以后也是 PCR， 但这个当然不是大部分的病人的情况就是给大家一个 surprising 的一个参考那最后台湾的 data 呢，我们有3个医学中心合并了200多个人 data 呢，做了一个 normal ground就是在我们面对的比较 advanced 的病人 BCLC stage C 的病人做了一个 normal ground 来给临床一个参考，说在我们这3个 center 合起来的1年的 survival 55%，2年是 32%。那大家熟知的几个 prognostic factor 就是这些重要的 tumor size 啦，或者是这些trial score 的状况，然后我们做了一个重要的这个 independent factor 的这个 normal ground， 然后去定出一个分数，照这个分数来跑的话，我们其实根据分数可以把这些做 SBRT 的病人分成很明显的3群的差别，那也经过 validation， 那这个是就台湾3个 center 的经验发表的一个 normal ground 的 data 那所以在 combined modality 来说，目前有1篇 randomized trial 的 evidence 去主张 liver directed therapy 比上 sorafenib 其实会有一些超过的好处那最后在 immunotherapy 来说 因应现在 immunotherapy 已经开始跟targeted drug 合并在一起，那 radiotherapy 会有什么样的想法哦？那其实一个肿瘤要消哦，绝对不是你用一个大棒槌怎么样 proton heavy ion 去敲它，肿瘤就敲完以后就像卡通一样粉碎，然后就消失，不会的。它其实照完以后，它应该是 immune cell 再把它清除掉，最后才是慢慢毁掉这个东西。所以 immunotherapy 早就在肿瘤消的过程里面扮演一个过程很重要的角色，只是我们不知道而已。然后，所以 immunotherapy 出来以后，当然想法上面大家就希望在这么多的 immune response 里面 ，RT 或是这个一拳 90能够扮演什么角色哦？那切入点非常多，但是非常难做哦。就是到目前为止，已经进展5年的这个单一这个 immune checkpoint inhibitor 跟 RT 都没有发表 data。那我相信没有发表 data 应该是没有好 data 的关系。然后那另外再小小提一点说，为什么 RT 要进展成少次数甚至 SBRT 的次数？这是台大发表的，因为我们在早年面对 B 肝的病人照完 local RT 以后，居然会有 B reactivation 的问题，所以我们在实验室发现说，它有 bystander 的效应，就是当你用细胞照完以后，用 condition medium 给没照的细胞泡一泡以后再照的时候，它的 B virus 就会 reactivate 起来。那这样子的 translational study 也做到老鼠身上，我们那时候是用 IL-6 跟 RT 哈，如果你单用 IL-6 或单用 RT， 在老鼠里面产生的 B reactivation 都是短暂或者是有限强度的。那如果你2个合并的时候，就是又多又长哦。那在 tissue 也是这样。那这个代表什么意义呢？以前早年我们做5、6周长疗程的 RT 的时候，那除了说我们觉得效果不好，因为每次的剂量很小，那另外额外的危险是，它像一个 incubation 一样，它会助长在这个疗程中不断的产生的 cytokine 造成的后续 combine cytokine 跟 radiation 的 liver toxicity， 包括 HBV reactivation 在内。那这个是经过实验已经发表，所以当剂量变强，就是用更少次数的时候，你可能在3周以内还不会让照射的 liver 产生的 cytokine 来得及合并，它可能要3周以上才会产生会合并的 cytokine， 所以你 RT 已经做完了，所以这种情况下，其实 liver toxicity 会变少哦，除了治疗强度增加 ，liver toxicity 会变。那目前 SBRT 的 data 看起来，确实大家觉得是比以前长疗程毒性要少。所以我们今天在讲的说，中疗程或是短疗程的 hypofractionated 或是 SBRT 来说，它的定义就是要小于3周，甚至小于2周，小于6次的治疗。那它其实有比较高的 dose intensity， 也有比较低的 liver toxicity， 所以这个应该会是变成市场上除了健保给付考量以外的标准选择了。我讲的说，因为健保是做一次给一次钱，所以做长疗程是有一些诱因的，但是在学理上面来说，中短疗程其实是比较符合标准的用法。那各种技术需要短疗程的配合才能做得好了。所以这个大概是我今天短短的 summary， 谢谢大家。
谢谢陈教授的演讲。那有没有什么要这个补充或是请问陈嘉宪教授的？叶大生、叶教授，看起来我们那个林口长庚的同仁们并没有对这个发表出来啦。因为为什么我要这样讲呢？因为对林口长庚的第一台那个proton 是我在当院长的时候负责引进的，所以我也有一点点涉猎啦。那个现在呢，因为我们洪副院长呢，因为身体不好，所以没有这个再出来。他在治疗200例的时候呢，我们有过一次沟通，因为我被邀请去日本演讲，所以呢我有稍微涉猎一下。其实呢，用这个他们的治疗呢，大概第1年、第2年，他们选择的病例呢，因为林口长庚的这个放射肿瘤诊断呢，非常 stupid， 非常怎么讲，非常 stupid， 他就是不主张，他就是不要随便接受病人。他宁可做这个比较困难的病例，所以呢，他们大概没有在这个发表上跟做这个 clinical trial 这样的一个东西啦。但是据他200例的经验呢，发作第1年、第2年的存活率呢，可能到不达80到60。最主要他们的 infield progression rate 大概很低啦 ，inflation progression rate 很低啦，所以表示这个在这个治疗上某一些有效果啦。 而且呢，我记得我跟他谈过以后呢，他觉得说呢，你们外科方面或是这个比较 late stage 的，比如说像刚刚陈教授讲的，这个大tumor 大的肿瘤，还有 vascular invasion， 还有这个poor liver function， 还有老年人的话，好像刚刚陈教授也讲，这个健保不给付的这个治疗之下，不老董大概可以提供这些病人一些临床上的这个用途了。还有什么要再讲的？有没有？没有的话呢，我们还是谢谢
大家。
陈教授你的演讲。
好，谢谢陈教授，谢谢陈院长。那我们接下来那个 break 时间我们那个因为时间已经 delay 蛮久，所以如果在场的观众的听众有需要的话，请自行到去洗手间或者是自行取用外面的餐点。那接下来我们会欢迎那个法国的 Olivier Donat 教授给我们做演讲。他其实也是我之前在法国的指导教授，给我很多指导。OK， Olivier, I'm just telling how good you are to the audience, and I will pass the microphone to Professor Hall for your talk.
Thank you very much.
Okay. It is a great pleasure for me to introduce our next speaker, Olivier Sonnet, Professor Olivier Sonnet. Professor Olivier Sonnet is a professor in nephrology and clinical immunology in Lyon University Hospital. He obtained his MD in renal medicine from University Pierre et Marie Curie in 2004. He specialized in transplant immunology and obtained a PhD in immunology in 2008 for his work elucidating the role of lymphoid neogenesis in chronic rejection. Between 2009 and 2011, he was a postdoc fellow in the lymphocyte interaction lab directed by Dr. Facundo Batista in London Research Institute. Since 2012, he holds a tenure position in Department of Nephrology, Transplantation and Clinical Immunology of Edward Harriet Hospital in Lyon. And he is the head of research group at the INSERM U1111, aiming at establishing new strategy to prevent rejection in transplantation. He is the current treasurer of ESOT and the president of scientific committee of the French-speaking Society of Transplantation. Today, he is going to give us a talk about the inverted direct allo recognition trigger early donor-specific antibody response after transplantation. Let's welcome Professor Olivier Sonnet.
Thank you very much for this long introduction. That's very kind, and I have the feeling that I do not deserve such a long introduction. I'm particularly happy to be with you. I remember the time when I had lucky enough to come to Taiwan to attend this meeting, and I'm very sorry not to be with you today. What I'm going to do today is to present a work that is not yet published, that we just finished in the lab. For that, I need to share my screen. I hope it's going to work. Please let me know if you see my slide. I can see that the slides are on the screen, so it should be fine. Can you hear me?
Yes, we can hear you.
Okay, fine. So I can move on. Yes, like the previous speaker said, I'm from Lyon. I don't know whether you know this city. It's the second largest city in France. It's at the heart of Europe. It's quite a nice city, and I hope that Chincha will be able to tell you more if you ask him, because he spent some time with us a few years ago. So indeed, I'm going to talk about transplant immunology, and more specifically about what we think is a new pathway of allo recognition that might be of importance for people taking care of transplanted patients. I don't know if all of you know or are involved in transplantation, so I start by a little introduction. You probably know that vital organ failure is the first cause of death in developed country. It accounts for more than 70 billion a year of health expenditure, which is roughly 25% of the total. For these patients, which are critically ill, the only option we have, or at least the best option we have, is to replace the organ that is failing by a new organ coming from a donor. So we think that there was worldwide in 2017 a little bit more than 1,400 people living with a transplanted organ. The problem with transplantation is that, for it has many advantages and it's very important techniques, it really looks like this. I mean, you really try to fit a square into a round hole. And the reason why I'm saying that, it's because I'm an immunologist. And when you do transplantation, you basically use an organ coming from a donor that is genetically different from the recipient. And because of that, there will be mismatches, especially at the level of the highly polymorphic HLA molecule. And these mismatches will be recognized by the immune system of a recipient that will mount immune response to destroy, that will ultimately destroy the graft. That's what we call rejection. What we know so far is that there is this very peculiar situation that is specific to transplantation where recipient's T cell can directly recognize intact MHC molecule from the donor, which are at the surface of the antigen presenting cells that came with the graft. We call them the passenger leukocytes. And this will activate quite a lot of these recipient's T cells, something like 1 to 10%, leading to T cell mediated rejection. These T cell mediated rejection, they used to be extremely problematic in transplantation, and they were considered as the first really obstacle to success of transplantation. I shall add that this simplistic vision has been a bit refined over the last years, and we have discovered that in addition to the donor APC, recipients APC, antigen presenting cells, that traffic into the graft, they can be covered, if you like, with intact MHC molecule from the donor. It's what we call cross-dressing. And by doing that, they can also fulfill the same function as the donor APC and activate the recipient's T cell, leading to T cell mediated rejection. So we know quite a lot about T cell mediated rejection. And in fact, unfortunately, it's not so much of a problem in transplantation anymore because we don't have very good treatment. We know how to diagnose this T cell mediated rejection. We know how to treat them. And we consider, in a recent paper by the Phil Arwan's group, it's now considered that these T cell mediated rejection are no longer a real threat for transplantation. In contrast, there are other types of rejection that do not depend on T cell, but rather on antibody. And we call them antibody-mediated rejection. And they are accumulating data coming from the last 2 decades, let's say, that have shown that antibody-mediated rejection is certainly the main cause of late allograft loss, accounting for at least 2/3 of this failure. What we know from the pathophysiology of antibody-mediated rejection is that donor-specific antibodies are very big protein. And actually, Chincha, when he was in the lab, demonstrated that because these proteins are so big, they are not very good at, they are produced by plasma cells in the bone marrow, and they are passing in the circulation of recipients, but they are not that great in leaving the circulation, meaning that the only target they will be able to see in the graft are the donor MHC molecules that are expressed by graft endothelium. And because of that, antibody-mediated rejection is mainly a vascular rejection. And there are 2 ways by which the antibodies, the donor-specific antibodies, DSA, can mediate these damages. They can either, if you have a lot of this DSA in the circulation of recipients, recruit the first molecule of the classical complement cascade, leading to an acute, if you like, type of antibody-mediated rejection. But there are situations where you have less of these antibodies, and you see you need a lot of these antibodies to recruit C1q. And in that case, a classical complement cascade cannot be triggered. But still, these antibodies will mediate damage by a different process, which is the recruitment of innate immune effectors, like NK cells, monocytes, or neutrophils, because these cells although they cannot recognize the graft directly, they are equipped with a surface receptor, which is the Fc gamma receptor, which recognize the Fc fragment of antibodies, can bind to these antibodies if they are themselves bound to the HLA molecule of the graft endothelium and mediate antibody-dependent cell cytotoxicity. What we know is that depending on the process, the mechanism that is at stake in the patient, you will have different type of antibody-mediated rejection, different severity, if you like. People in gray here that do not have any donor-specific antibodies will have a very good graft survival. And then you see that if you have a lot of antibodies able to activate the complement pathways, you will have a rapid loss of the graft. It's what we call acute antibody-mediated rejection. If you have less DSA, but you still have antibody-dependent cell cytotoxicity, ADCC, but no complement activation, you will have an intermediate prognosis here. And that will translate in the clinic into what we call subclinical or chronic antibody-mediated rejection. As you see, whether you have acute or subclinical antibody-mediated rejection, the prognosis is not good. And actually, the only thing we are good at in the clinic is to revert the patient that have acute antibody-mediated rejection, the red one, into the blue one by reducing the antibodies that are in the circulation by plasmapheresis and IVIG. But then whenever you are in the blue group, let's say, there's nothing we can do, and we know that you're going to lose your graft. And that's the reason why, as I already told you, antibody-mediated rejection is considered as the first cause of graft loss. So the real problem is not only to develop more efficient treatment, but is also to understand why these people develop donor-specific antibodies. Because if we can prevent the generation of DSA, then we will sort out the problem, if I can say. Okay, so how are these DSA generated? What we know is that the DSA are high affinity, which means they are mutated antibodies, and they are IgGs, which means that they are switch antibodies. And these are two features that are very characteristic of what we call a T-cell dependent antibody response. What is a T-cell dependent antibody response? Well, that's the usual way the B cell responds to a protein antigen. They need a first signal of activation, which is the binding of the antigen, in that case it's donor HLA, to B cell receptor, which is the immunoglobulin on the surface of B cell. This will deliver a first signal of activation, but that's not sufficient, and that's why we call that a T-cell dependent humoral immune response. It's because whenever you have the first signal, then you get internalization of this complex. The protein antigen, here the donor HLA, is processed into small peptides and presented within the context of MHC class 2 of recipients MHC, because it's recipients B cell here. And these recruit recipients T cells that recognize this complex, self or recipients MHC plus allogenic peptide. And that is what we call indirect recognition, by contrast with the direct recognition that I was just discussing a few minutes ago. This is critical for the generation of antibodies, because only when you get this recognition can the T cells of recipients deliver the second signal of activation to allo-specific B cells, which then will be able to differentiate into plasma cells, which are the cells that produce the antibodies, and in that case, the donor-specific antibodies. So this is the full picture of what is in textbook so far regarding the allo-recognition pathways. You have the direct and semi-direct that leads to T-cell mediated rejection. And as I just explained to you, you have these indirect pathways where recipients APC internalize, process, and present allogenic peptides into a recipient's MHC to recipient's T cells. And this is why you can get these HELP2B cells and generate DSA, which leads to antibody-mediated rejection. Okay, that looked pretty simple. And a few years ago, Chincha was still in the lab, and we were thinking about having a control experiment for a project. And I asked Chincha to transplant allogenic hERG to recipients mice that do not have any T cells. They don't have T cells because they are KO for CD3 epsilon, which is the transduction molecule for the TCR. And so they cannot do positive selection of T cells in the thymus. They are devoid, totally devoid of T cells. So we were expecting that these mice, because they don't have any T cells, they won't be able to do any indirect presentation, and they shouldn't as predicted by the dogma, they shouldn't be able to mount a DSA response. So we transplant these mice, and as control, we use wild-type BLAC6 mice. We transplant these mice with an allogenic hERT coming from the CBA mice. So it's a full allogenic model where the recipients are H2B receiving a hERT from H2K donor. And surprisingly, the gray mice here that have, remind you, they have no T cells around, they were able to mount a very, very fast and very high level of antibodies against the graft, which was, of course, totally unexpected. Another characteristic feature of this strange response was the fact that the antibodies were appearing very fast, actually faster than wild-type mice, but also disappearing quite fast, which was not the same when we were looking at the control, the wild-type mice in black here. So we were quite puzzled by this, and we thought that maybe we had found a new pathways in which the recipients could develop antibodies in a CD4 independent fashion. In fact, it's not that new, right? We already know that B cells can respond to antigen without the help of T cells. It's what we call T cell independent humoral response. That's what you have on the right of the slide there. The only thing is that there are different characteristics between the T cell independent and T cell dependent humoral response. T cell independent, they are supposed to be the cells, sorry. The antigen are not the same. Usually they need repetitive structure, and they are sugar antigen, like for instance the pneumococcus antigen. And what we also know is that the T cell independent humoral response, they usually lead to the production of antibodies that are not switch. They are mainly IgM and not IgG. So we thought that, okay, there's already a problem with this antigen, but let's assume that this is a T cell independent humoral response, then the antibodies that are produced should not be the same. Instead of IgG, which is the case of T cell dependent, then we should have IgM around. So we start looking at the isotype of the DSA that were produced by CD3 epsilon KO and compare them to the wild type control. And surprisingly, we found that the CD3 epsilon KO that have no T cells, they were able to produce donor-specific antibodies that were switch antibodies. They were IgG and not IgM. And so that supports the fact that they were a class switch recombination, and therefore that the CD3 epsilon KO mice, the B cells of these recipients should have received a T cell help. That the question was where the T cells were coming. If they were not coming from the recipients, they had to come from the donor. So what Chin-Che did is that he looked into the donor mice and checked whether he could find CD3 cells, not only in the PBMC, which were the control, the blood, but also in the hERT, in the hERT itself. And by doing that, he was able to show that indeed, if you look at what you have in the PBMC, you do find CD3 positive, CD4 positive cells, but the very same subset can be also found in a cell suspension obtained from a hERT graft, suggesting that whenever you transplant the hERT, you not only bring APCs from the donor, but also CD4 T cells from the donor. Chin-Che also showed that if you deliver depleting antibodies, in that case anti-CD3 antibodies, to the donor, you can really make the T cell disappear not only from the circulation, but also from the hERT. And so we had the idea that maybe if we were transplanting the hERT in which T cells would have been depleted, this would have had an impact on the generation of DSA if these T cells were important to deliver the help to recipients' B cells. So that was exactly what we did. And you can realize that if instead of harvesting the hERT to the donor without any treatment, you deliver CD3 depleting mAb to the donor and harvest the hERT 1 day after you have eradicate or eliminate the T cells from the graft, what happens is that you don't see anymore any DSA generation in the mice that receive the hERT, suggesting that indeed it is now the donor T cells that deliver the help of recipients' B cell in this model. And we call these pathways the inverted direct pathways for the reason that it is a direct recognition, exactly like I told you before, and except that this time, the APC, which is the B cells here, come from the recipients, and the T cells come from the donor, which is exactly the other way around as the classical, let's say, direct allorecognition pathway. Okay, this is very funny for an immunologist to find this type of things, but is it interesting for a clinician? That's what we try to sort out. So what we did first is that, as you probably know, some of the organ we transplant are put on perfusion machine. And we thought that maybe analyzing this perfusion liquid could be a good opportunity to see whether the human kidney graft were containing any of these CD4 T cells that seem so important for the inverted direct pathway. I just would like to remind you that there are different type of T cells. You have naive T cells. They are here in blue. They are positively stained for CD45 ARA and CCS7. And there are many memory subsets, especially T effector memory subset. And this subset is negative for CD45 ARA and negative of CCS7. And this subset is interesting because it's a tissue resident cell subset. And therefore, we were expecting that if perfusion liquid they were not contaminated by blood, but were really the reflex of what type of cells you can find in the tissue, we were expecting that they would be enriched in effector memory cells as compared as naive cells, which traffic really more outside the organs. So we compared the content of perfusion liquid. I can't remember exactly the number. I thought it was something like 30 perfusion liquid to tens or something like that, PBMCs from healthy volunteers. And you see that, as expected, in the blood of healthy volunteers, you find a lot of naive cells. Again, these cells do not go in the organs, and very few effector memory. But in perfusion liquid, these proportions are inverted. You have much more effector memory cells, which tells you that indeed perfusion liquid is a way to see what type of cells you do have within the tissue. Okay, next question was, now that we can see that CD4 T cells do contain, human kidney graft do contain CD4 T cells, are these cells able to deliver B cell help? I went very fast on my previous slide, but I would like to remind you that we, of course, know which type of surface molecule are important for CD4 T cells to be able to deliver an efficient molecular help to B cells. We know that ICOS is important. We know, of course, that CD40 ligand is important. You probably remember from your immunology course that if you mutate CD40 ligand pathway, you get an immune deficiency in which the patients cannot develop IgG anymore. And so what we did is that we look at whether these CD4 cells that were inside the perfusion liquid coming from the kidney graft were expressing this ICOS and CD40 ligand. First thing we saw is that these cells do not express this ligand at the baseline level, but as soon as you stimulate them by the TCR, they upregulate the two types of ligand, and especially CD40 ligand, as seen here, which is a sign that whenever they get stimulated, they're able to deliver B cell help, which is exactly what happened in the model, because you remember that the TCR of these cells will recognize the MHC class 2, the allogenic MHC class 2 expressed by the recipient's B cells. Of course, recipients' B cells, they are in the secondary lymphoid organs of the recipients, in the draining lymph nodes in the spleen, while the CD4 T cells coming from the graft, they are in the graft and they need to migrate from the graft to the secondary lymphoid organ. If they have to do so, they will necessarily pass in the circulation of the recipient. So if we want the inverted direct pathway to be efficient in the patients, it means that at one point we need to be able to see these donor CD4 T cells in the blood of the organ recipients. So we did some CD3 chimerism analysis in a patient transplanted with kidney transplant in our center. But unfortunately, we were unable to see any donor CD4 T cells trafficking in the circulation of recipients. We were, of course, very disappointed because this means that if inverted direct presentation exists in human, then it's probably very, very rare in kidney transplantation. But what we found was that kidney is a very specific situation because there are other types of transplantation, like lung transplantation, for instance, where you bring much more CD4 T cells. Lung is an organ in which you have a bronchial associated lymphoid tissue that contains a lot of CD4, as you can see on this picture here. This is a staining for CD4. You see that there are a couple of of cells there in the interstitium of the graft, of the kidney graft. But whenever you look at the lung, there are much more of these cells. So we were thinking that maybe just increasing the quantity of T cells that you bring with your organ might change the picture. And indeed, if you now do an analysis of the CD3 positive chimerism after lung transplantation, you start to see that you do have some donor CD4 T cells trafficking in the circulation of recipients a few days after transplantation. Of course, the number is going down with time, but maybe this is enough to get some direct pathway. Try to see if this was true. We took advantage of the situation where we have one type of transplantation, which is kidney transplantation, where you do not have this enough donor CD4 T cells, and another type of transplantation, lung transplantation, where it seems that you do have enough of these cells. What we did is that we say, okay, we're going to have two periods. The first period is a time when you do see these donor CD4 T cells trafficking in the circulation of recipients of a lung, but not a kidney. So you expect that you're going to have inverted direct pathway functioning in lung recipients, but not kidney recipients. And then, as you see, the number of his cells is going down with time. So you expect that if you look at a later time point, then this inverted direct pathway shouldn't be efficient anymore. And the two organs, if the recipients develop DSA, it shall be by the way of the indirect pathway. And in that case, both organs should be able to do the same. There should be no difference. So we were expecting that we would see no difference in the generation of DSA in lung and kidney recipients in the late time point, but maybe more generation of DSA in an early time point only in the lung recipients because of this inverted direct pathway. Let me show you the results. Yes, as expected, if you look beyond 100 days, whether you are kidney recipients or lung recipients, you do develop DSA with the same kinetic. But if you look at the earlier time point, the first 100-day post-transplantation, you see that the kidney recipients, they develop very few DSA over this short time period, while the lung recipients develop much more antibodies, and that might be related to the fact that there are much more CD4 T cells within a lung graft, and these cells can traffic in the circulation of recipients, migrate to the secondary lymphoid organ of the recipients, and help the B cell of the recipients through what we have called the inverted direct pathway over here. To further demonstrate this, we said that we tried to validate that in a different model, and we said, okay, what we know is that in the intestine, there is even more CD4 T cells than in the lung. And sometimes some patients, they need intestinal transplantation. So we took advantage of these intestinal transplanted patients and say, okay, we're going to have a look to whether they produce antibodies in the first 100 days. And this shall, if our theory is true, then they should be the one that develop the most DSA as compared as any other type of transplantation, because the intestine graft contain probably as much lymphocytes as the total rest of the body, as you see here, because of the, of course, of the mucosal associated lymphoid tissues with PO patches and of course all the rest. And the prediction is true, actually. If you look at the kinetic of DSA production by intestine recipients in the first 100 days, you see that there is a difference. We already talked about that between kidney, which produce very little, and lung recipients, which produce more. But for intestine, it's massive, right? You have 75% of the patient that develop donor-specific antibodies in the first 25 days, which it cannot be. It's too fast to be the indirect pathway. It has to be through the new pathway that we have described, which is called, which we have named the inverted direct pathway. Okay, it's nice. What is another clue, let's say that, because this is of course indirect evidence, but another clue that this type of DSA production is rely on the inverted direct pathway rather than the indirect pathway, the classical indirect pathway, is, remember the mice model. If you compare wild type mice to the CD3 epsilon KO mice, which develop antibodies only through the inverted direct pathway, you see that you have a production of antibody that is very early. But the second feature is that these antibodies, they are disappearing very fast. And very interestingly, if you compare DSA, the profile of the patients that are intestinal transplant recipients or kidney transplant recipients, as far as the duration or persistence, I would say, of DSA in the circulation, you see that for kidney, whenever you develop DSA, it's forever. For intestinal transplant patients that develop this DSA very early post-transplantation, then you see that there is a very, very fast drop that is reminiscent to what we have observed in the CD3 epsilon KO mice, further suggesting that this DSA generation is probably due to the inverted direct pathway. The last question was whether this was important for us. It's interesting to validate that the pathway that we have seen in a very specific mice model also probably exists in human, but is it important for the graft, for the survival of the graft? Well, I remind you that there are different types of antibody-mediated rejection. If you have a lot of antibodies, you can activate the complement pathways, and this is doing a lot of damage to the graft very fast. But if you don't activate the complement pathways, then it takes a lot of time for these antibodies to create the damage, and you will only see chronic rejection. It will take years for the graft to be destroyed. And so you could argue that because in inverted direct pathway, the production of antibody is only transient, then if the patients, the lung or intestinal transplant recipients, do not have antibodies that bind the complement, it shouldn't make any difference. They will have a short and transient period during which they will have antibodies that cannot activate the complement, and then nothing will happen. In contrast, if the same patients have antibodies but that activate the complement, this short and transient DSA production might be enough for acute antibody-mediated rejection to occur. So what we did is that we distribute the intestinal transplant patients from the previous cohort into 3 groups. The group here that have developed no DSA. Remember, there were 25% of the cohort that did not develop DSA at all. And we split the patient that did develop DSA into 2 groups. One group in which DSA cannot activate the complement, and because these DSA are transient, you expect that will make no difference as far as graft survival. And another group here that generate DSA that do activate the complement, and in that case, because that will create acute damages, you expect that this will make a difference, and that's exactly what you see here. You see that only the intestinal transplant recipients that have generated an early wave of DSA able to activate the complement here do have less, let's say, less favorable graft survival as compared as the 2 groups. So that is already my conclusion slide. We knew from the textbook that there were at least 3 pathways of allocognition. The indirect and the semi-direct leads to T-cell mediated rejection. We also knew that the indirect pathway was important for generation of donor-specific antibodies and antibody-mediated rejection. What I believe, or I expect, what I expect you are now convinced of, is that there is this inverted direct pathways in which the recognition of allogenic MHE is done by donor T cells and not recipient T cell, like here. So you see the color inverted, and the APCs from the recipient, which are B cells, and this inverted direct pathway allow for a transient, fast but transient wave of DSA generation, and providing that the DSA can activate the complement, then you can have damage, especially for the people that receive a graft that contain a lot of these donor CD4 T cells. I would like to finish by thanking the people involved in this study, and there were quite a lot of people, especially Xavier Charmeton, who is a PhD in the lab, and that has played an important role in the paper. But I want to emphasize the massive role of Qin Shashen when he was a PhD in my lab, because he was the one who initiated the study, and we all miss him a lot. I'd like to thank by saying that if you're interested in this type of study, then please feel welcome to apply for a postdoc position in the lab. There is one available, and I would be very happy to explore whether we can collaborate in the future. Thank you very much for your attention.
Thank you, Professor Thonet, and thank you for providing us the chance of learning in your lab. And is there any question from the audience? Okay, I would like to ask you a question. Is that from the original mice studies, it seems that the inverted direct auto recognition is activated more faster than conventional auto recognition. Is there any explanation for that?
Yeah, it's a very good question. I know that, well, my explanation would be that you probably need less phases to get the inverted direct allo recognition, because it's only about having the T cells that were in the graft migrating to the secondary lymphoid organ. While if you need the indirect pathways, well, you need first the APC from the recipients to migrate inside the graft. Then you need these cells to come back to the secondary lymphoid organs and prime recipient's T cells, and then you need the recipient's T cells to interact with the recipient's B cells. So I know it's a little bit simplistic vision of the things, but I would say that maybe this is the simple explanation to it. There are less phases for that. Another explanation would be that you don't need much clonal expansion, because every single, well, as you remember, in direct allocognition, there are 1 to 10% of the T cell repertoire that can recognize allogenic MHC. And so a lot of these donor CD4 T cells within the graft are able to interact with the allogenic MHC on the surface of B cells. While if you rely on the indirect pathways, then of course, it's a classical type of adaptive immune response where you need the very few specific effector to first expand. And I suspect that this is probably also a very good part of the response. So I think that these are the two things that explain why the response is faster in the inverted direct pathway as compared as the indirect pathway.
Thank you. And is there any other question from the audience? Okay, if no, I would like to thank Professor Thonet and hope you can come to Taiwan very soon after the COVID-19 pandemics. Thank you very much.
Thank you very much for your invitation. I will be glad to do so.
Thank you, Olivier. 好，那接下来我们下一个部分是由我们的陈炯年教授来为我们演讲。那我们请我们的李副院长。
拜现在科技的帮忙哈，我们不到1秒钟就从法国里昂回到台湾台北。今天我很荣幸介绍我们陈炯年教授，他是台北医学院毕业以后，在台大博士班拿到 PhD， 就在台大落地生根，从住院医师、总住院医师，中间也到日本卡纳扎瓦跟美国的 Pennsylvania 去进修。那在11年前升为正教授。我们最近一句话说台湾 can help， 我们也相信 AI can help， 但是 AI 能够帮些什么忙？在这个超音波的领域里面，尤其是在台湾超音波理事长陈教授的那个讲解之下呢，让我们得到一些新知。现在请陈教授。
谢谢。谢谢李副院长的介绍哦。那今天我要跟大家讲这个题目，其实就是有关 AI 了。那 AI 现在其实这几年来都很夯，所以而且它的应用哦，在各领域都有应用哦。那今天要跟大家介绍的是有关这个在超音波的 detection 跟 diagnosis 的一个应用。哎，这个是按这个。那我自己来那个。 这个下一个。我想这个因为这个题目，我想在我们外科是比较冷门的，大概没有很多外科医师在做哦。那我想，我除了胃癌以外，就是做一些比较冷门的学科了。那不过这个简单介绍一下 AI 哦，其实它发展很早，它在1050年代哦，很有名的就是那个图灵啊，哦，图灵是一个天才嘛，哦，他因为他英国才打赢德国哦，那因为他也是因为最原始的 AI 哦，那那个的出来哦，所以哦，那后来这个有关电脑的诺贝尔奖就是图灵奖嘛，就是以他的名字来命名。那其实再来就是说，在1980年以后，就是说有 machine learning 啊这样的一个 algorithm 出来哦，那也是造成很大的轰动。但是这个 machine learning 哦，其实经过了几次起伏了，哦，有几次是很 hype， 然后又变成 depression 哦，那到最后就是说，最近这几年好像就 deep learning 了。那 deep learning 哦，从2010年开始哇，就开始就是变成一个 AI boom 了哦，所以真的很夯啊！现在在电视上我都可以看到说哇，什么美国又派那个什么无人机去刺杀那些伊朗的一个将军哦，那这个都是 AI 的。那我想大家都在想说，会不会再有一个 depression？ 我想看这个情况好像会越来越发展了哦。那其实 machine learning 就是要去寻找一个对的function哦。那就像现在很多的那个 voice 的 recognition， 就是说就 function of voice 嘛。那 conversation 就是有一些 chatbot 啦，或者这些哦，他会跟你聊天啦。那阿巴过很有名哦，他是棋谱啊，他把它棋谱哦，他那个function叫棋谱 function of 棋谱。然后就告诉你下一步怎么走，哦，那我想这个传播哦，大概就是说给你一个影像，然后看他会不会告诉你他这个良性还是恶性哦。那所以这个方选大概有 linear、nonlinear 跟 highly nonlinear。那这个 linear 的当然大家都很熟悉啊，尤其我们在这个 logistic regression 哦。在我们医学上很常用哦。那现在 deep learning 就是 highly nonlinear 哦。那一般的传统的这个 machine learning 哦，它需要的 input 的这个 data set 是比较中等或比较小了。那但是这个哦，它电脑需要去学它这个 feature， 而且要懂得这样的一个classification 的路，然后出来就会跑出一个 output， 那这个 output 是比较能够理解的，哦，那 deep learning 呢，哇，就需要很大量的 data set， 然后需要更强的这个电脑，然后它不需要，你不需要告诉他，你不需要告诉他 feature， 哦，那也不需要告诉他什么特别的路，那后来他就会告诉你说 output 是什么，但是他这个 output 你没办法，很难去解释，因为它是有很多潜藏的一些 layer 在里面在运算，所以你根本不晓得他到底看到什么，然后做成这样的结论了。哦，但是呢，如果你要做这个 deep learning 哦，其实你要收集这个 data 哦，还有去标注这个影像哦，去做标注啊或者收集哦，那都是非常费时的，而且非常费工啊，其实也是非常昂贵啊。所以我们为什么要做这个 Computer Aided CAD 的 detection 呢？哦，对于这个超音波影像， 那其实这个就是在2003年哦，那时候我跟张丕执行了那个这个经济部的学界科专哦，那时候才有这个构想哦，就是因为那时候觉得说，哎，可能人眼没办法去辨识这个 grayscale 这个 pixel 之间的一个些微的一个差异啊，哦，然后如果我们把这个 feature 变成一个数字，那就有可能让 machine learning。那而且一般呢，这个变成数字以后，它变成是一个 continuous 的，就是 continuous， 它是一个 number。那但是一般我们人在读这个散播影像都是靠自己的经验嘛，还有凭自己的感觉来去做判读哦，所以一般想起来应该是比较客观啊，比较 consistent， 那也比较容易做这个之前之后的一个比较哦。那很重要的就是比较不会有这个 operator dependent， 因为超音波检查是非常的 highly operator dependent。然后我们可以把它当做 second reader 啦，或 assistant。哦，那其实哦，超音波影像会造成一些 optical illusion 的哦。它的最大的这个就是 optical 的这个 illusion 哦。比如说这个 B 啊，在这边看起来就比 A 淡啊，可是事实上不是啊，它是跟它一样啊。哦，因为它 B 外面都是比它深的。那我们超音波影像就是这个 grayscale 哦，就是由黑变灰，然后变白的这个差距，其实每一个 pixel 都是一个数字啊。哦，所以你看到的不一定是真的。哦，你可能被影响啊。如果像我们台湾的医生哦，我想那个 mental workload 的跟 physical workload 的都很容易达到极限了。那还有一些如果他在做，然后有人拼命打电话，有时候也会影响到 optical illusion。那这个大家看一下，你可以算出它黑点有几个吗？因为你会到最后看它会飘啊，对不对？所以这个是 optical illusion 的另外一个案例啊，哦，所以就是说那时候在做这个学界科专的时候，那时候就想把这个影像看能不能把它量化了，把这个 feature 把它量化，然后才能算了。那这样至少比较客观了。哦，那好，那个超音波的这个肿瘤的影像哦，大概你可以做几个不同的 feature， 像 cyst 啊，还有 echogenicity、texture、margin、tumor 的 orientation， 还有 size。那所有的这个超音波的 tumor 的影像，大概都是由这一些 feature 组成的，当然是不同的 combination 了。所以哦，如果因为那时候我们最先的做的一个研究，然后后来有技转了。哦，那技转当然就是说，希望能够这个技转的公司就希望能够把它商品化嘛，商业化嘛。哦，所以他们就要去了解，就是说，那你这个如果要通过 FDA 的认证要怎么办呢？那起先 FDA 的对 CAD 并没有什么明确的一个认证方法，所以那时候就是2008，哦，他开一个什么 Panel Meeting Brief Package， 然后到了2012的时候，才有510K submission 跟 Clinical Performance Assessment 出来。那出来以后，大家就说哇，那你这个 CAD 的 vendor 哦，这下子头大了，因为反正因为这个 regulation 出来，可能 可能你要认证就相对就困难了。那至于 CAD 怎么样去定 ，FDA 怎么去定义 CAD 啊？哦，最主要当然说要包含这个电脑，要包含这个 pattern recognition 和 data analysis， 然后要去 identify、mark、highlight， 哦，然后要去注意 portion of the image， 然后最后去显示它的这个异常的地方，哦，就是这样。那这个就是说，这个就是这些 character， 就是刚刚讲的那几个 feature。那我们可以去 identify， 比如说 identify 这个 tumor， 然后把这个 feature 把它 highlight， 哦，然后按照不同的 feature 都把它 highlight 出来。其实这个背后都是一个数字啊。比如说这个 age 的 blurring， 这个也是一个重要的判断恶性的一个标准嘛。哦，那这个它会帮你 highlight， 让你比较有一个比较 consistent 的一个看法。然后就是像 tumor 的 tolerant Y 的，这个 tolerant Y 也是一个 malignant 的 feature。哦，那他把 tolerant Y 的这个也变成数字，所以这个就变成说，其实人就是把这一些 feature 在你的头脑里面去整理了。哦，这个就是说他们发展的就是说，各个影像的那个各个影像的这个影像特征，哦，它会把它显示出来，让你做判断了。不过这个时候，它还是一个 offline 的操作，而且医生要去 identify 那个 tumor， 所以这个初期的时候是这样的。那如果按照 FDA 的规定啊，认证的规定，你这个软体要去做它的 clinical performance assessment， 那这是怎么做？就是都是有一种做法，就是做一个 multi-reader multi-case 的 clinical study。哦，那它是怎么样？它最主要目的就是要去探讨，就是说是不是用了这个 CAD， 它的诊断哦，会比不用 CAD 要好了。这个很简单的，就是这样，目的很简单。那设计就是要用 MRMC。那我们之前的这个就是说，利用19个这个 medical professional， 它也是 multi center 的，大概10个 center 哦，然后去读265张的超音波的影像。那这个影像都是经过 pathology proof 的哦，是 benign 或者是那个哦，然后来看它的 performance。那这个整个 study process 就是说，先让 reader 去读这个 image， 然后他帮这个 image 打分数。哦，分数越高的话，就是有一个 malignant probability score， 大概0到100分。哦，那你这个就是一个 data。那最后呢，经过2个礼拜以上的 washout， 哦，那些影像再重组啊，然后再读。那这次就有用那个 CAD， 哦，然后再看说，它是不是这个 data 再收集起来，然后再比较，再分析。那这种 MRMC 呢，它基本上都是用一种就是 DBM method 来去做分析的。然后因为它会考虑到 random effect of case， 还有 reader， 还有 reading modalities， 还有它们之间的 interaction。那它要确保就是说足够的 case， 然后可以做用 CAD 跟不用 CAD 的比较。那当然如果小于 0.05 就表示这个是显著的。那整个 performance 看起来用 CAD 都是比较好，其中8个其实是 significant 比较好。那这个就是说，它这个 AUC 呢有用这个 CAD 的 AUC 显著高于这个没有用 CAD 的。这个是整体的这个 performance。那我们如果把这个 reader 呢再分成 junior reader 跟 senior reader， 那都就是以10年了，小于10年就 junior， 大于10年就是 senior。那来做比较 ，junior 一样 ，junior 跟 senior 两者如果你用 CAD 都是比不用 CAD 好了，那个 performance 啊 ，AUC 的他们比较高。那就是说，但是它如果是它之间的 junior 跟 senior 的差距是如果用 CAD，junior 跟 senior 都用 CAD 来看senior 好像改进的幅度比较大，比 junior 更大，有显著了，所以这个整个 performance 如果以 performance 来讲，是用 CAD 真的有比较好有显著的比较好。那我们还要看就是说 inter-observer 的 variability 但 variability 要有改善，就要比较小那如果说它的先看 standard deviation， 如果 standard deviation 用 CAD 比不用 CAD， 它的 standard deviation 更小，显著的小。那就表示它的 inter-observer variability 其实是比较好那不管是在 benign 或 malignancy 其实都比较好。对于这个 standard deviation， 那对于 mean 呢 ？mean 的话 benign 显著比较好，可是 malignant 就没有显著差异。但是总体而言，其实它的 inter-observer 的 variability 其实是有用 CAD 是有降低的。那至于就是说这个 partial AUC 我们在 specific 在比较高的一个 range 里面的时候，你去看它，你有使用 CAD 会显著的比没有使用 CAD 要好。这个也就是说，它这个就要看它的 sensitivity 跟 specificity。那如果说你固定的一个 sensitivity 是 0.95 的话，它的 specificity 有用 CAD 是显著高于就是没有用 CAD 的。我就是表示它的 specificity 是比较好那你如果你一定要固定一个 sensitivity 或者固定一个 sensitivity 才能比较嘛？那你如果说你的固定这个 specificity 是 0.95， 那它的 sensitivity 就是有用 CAD 其实还是会比没有用 CAD 要好了那所以说，如果你用 CAD 你可以发现7.6% 的 malignant tumor 其实是需要再去注意的，就表示你可能刚开始把它判断成 benign 其实它是 malignant。那另外也可以有10% 的 的这个benign的 tumor 哦，可以减少它去穿刺的机会。所以这个结论就是说，这个 MRMC 这个 study 啊，是呈现就是说这个 CAD 系统哦是可以改进这个 clinician 它判读的一个 performance， 而且可以减少它之间的 inter-observer 的 variability 的。所以或许它这个是一个将来就是说一个 diagnostic decision 哦的一个 tool 哦。当然这个 study 还是有它的 limitation 啊，因为为什么？因为这个 study 哦，它看的是静态的图啊，不是动态的哦。这个是那个也不是一个 real time 的，不是由那当事者自己可以操作的哦。那而且它是排除了1公分以下的 tumor 哦。那再来就是说，这个跟实际上临床，还有我们台湾这个恶性跟良性的肿瘤比例是有一点不同啊。理论上，恶性只占所有 nodule 的大概是5% 嘛。那它这个恶性已经大概就是说应该超过50%。哦，这个就是这个 study 的那个啦。不过你如果没有做这个 study， 然后 FDA 哦他不同意，你就没办法认证哦。那因为这样就是说，好嘛，大家现在都说哦 deep learning 很厉害啊，所以后来就是说为了改善，就是说那我们如果 real time 来做，以前那个是说你要 offline 这个影像存起来再去分析，那这个没人可能就要用的人就少啊。如果你 real time 的话，那或许就是比较接近临床的实境。那所以说后来就是说就用上这个 deep learning 的 algorithm， 然后去做这个 real time 的 automatic segmentation 哦。我想这个影片大概就是 real time 了，就是不是 offline， 不是把影像存下来然后再去分析的。你等于说你扫过了哪边有肿瘤，它就把你圈出来了，不用你再去判断说，哎，那个是肿瘤，而且它自动已经会帮你分析它的 feature。所以当你做完超音波以后，你这个报告等于写好了。哦，那这样比较贴近的临床的一个现实啊。所以他就是立刻会告诉你这个 feature， 就是这几个 feature 嘛，这好几个 feature。哦，你做的时候他有看到肿瘤，它自动标出来，不用你事后再去看，哦，这个是肿瘤，然后再画起来再去分析。大概就是这样，其实这样是为了比较贴近临床的实境。那刚刚有提到，其实这个 algorithm 是 CADE detection， 那还有一个 CADX， 那它的 FDA 的这个的 definition 就是说，要比 CAD provide 更多的 information。说真的，这个也是有一点笼统了。不过很明确的就是说，如果你要看可能性，有没有疾病的可能性，或是说要特别去 specify 这个 disease 它的 type， 或是它 severity stage， 或是 可以当做 intervention 的 recommendation， 那这个就算 CADX。那目前据我所知，好像有人有通过 CADX 的哦，我听说好像只有1个了哦。那这个 CADX 哦，其实你要去认证，你要直接跟他们 FDA 的 agent 沟通，到底你要做什么哦，大家讲清楚哦。所以你如果说以现在的情况要把它变成有 CADX 的功能，那我们是觉得就是说，我们可以把概念加进去啊，因为概念是大家的准则嘛，而且那这个概念加进去以后，哦，对医生来讲他就比较 comfortable， 因为他不会跟病人就讲说，哎呀，这个机器就告诉我这个你是恶性的啊，哦你要怎么处理啊？那如果你按照概念，你就很有理由跟病人说，你现在的情况是这样，那按照我们这个概念，那这个概念呢，全世界所有的概念都在里面，你要选择哪样的概念，哦，所以你变成就是说，你真的只要做完超音波啦，你选择一个概念哦，它自动报告全部就列出来，你不用再去写报告。那其实呢，这个 healthcare 的 AI 其实挑战也蛮大的，哦，因为哦只有6% 的 study 呢，它有做 external validation， 所以你的临床的有效性，这个是变成说大家就有一点担心了，而且它没有一个整合平常医院的 workflow， 哦，比如说这样的软体，一定要医院愿意配合，结合它的 PACS 的 system， 哦，这样才可以才可以 work 得很顺啊。那另外就是讲的，就是这个刚刚讲过，这个你要去收集这些 data， 收集这些影像，然后还要去 label 这些影像哦，哇，那个真的实在是，你想想看，如果说一个 deep learning， 你要收集12万张影像，这12万张影像要经过这个专科医师去把它 label， 那你想你要花多少钱？哦，这个是天价哦。那另外就是说，你到底它这个 business model， 因为它是一个 software， 你到底要怎么样？你要卖断呢，还是怎么样？哦，这个很多的 business model 真的是非常复杂哦。那还有就是说，现在的这个 user 的 experience 跟 user 的这个 interface 也是很重要啊。就是像刚刚讲的，你要让人家用的方便，用的顺手，哦，那人家才有可能去买单呢。所以最后就是说，讲说这个 closing remarks on AI 哦，就是说主要针对这个 deep learning 啊，我觉得这样讲起来，这个 deep learning， 因为它是 open source， 它的架构是 open source， 就是你上网就可以找到这个架构，所以到底你怎么样去，你很可能很难 pattern， 因为那个架构已经在那里，不像machine learning， 你还有 feature， 你自己要去找 feature。那所有 big data 到底都 how big is big， 哦，这没有一个一定的标准。那还有就是人类将来的这个知识会进展到什么样的程度？ 这个也都会影响啊。所以以这个 AI 来讲哦，你这个应用在这个 medical image 哦，其实是要结合不同的那个 machine learning 的 algorithm， 就好像我们这个一个 feature 就是一个 machine learning 的哦，你拿好几个 feature， 那最后你在 segmentation， 你如果要 real time， 你要用一个这个 deep learning base 的一个 algorithm， 然后其实它是帮助医生啊，不是要取代医生啊。那当然 AI 没办法回答你这个人生的问题啊，哦，你跟病人之间的这个 interaction， 这个是没办法取代的。哦，那这个好，那最后就是感谢这个 Thyroid Cat 的 research team 哦，这个我们已经成立了10几年了，现在还在运作了，因为有我们一个就是 MCAT 的 Biomed 哦，他一直跟台大有一个产学合作哦，所以这个那其实吴明勋、陈坤远呐，还有我，还有张丕啦，那最重要，现在核心人物就是陈正刚教授，因为他是我们工学院的教授哦，这些很多都是尤其到初期我们还有比较大的贡献，到后期这边哦，他变成他的贡献最大。好，那谢谢大家。
谢谢陈炯仁教授这么给我们一个启蒙的演讲。在座的同道们，不晓得有没有什么问题要或者要分享经验，或者要请教他。
陈教授问您一个这个 common sense 的问题啊。通常我们这个 CAD 啊，感觉是用来辅助我们比较 junior 的 staff 去做这些检查，但是从您刚刚的这个数据看起来，好像 CAD 反而对 senior staff 他的这个帮忙的这个程度又更大，这个怎么解释啊？
我觉得啦哈，其实哦，每一个医师哈，尤其是一个很资深的医师哈，他都会自认他看的是100%的准哦，那当然这是不可能的，但是即使你去问很多医生，他都是觉得他就是最准的。事实上，如果经过这样的一个测试，为什么 senior 的 reader 呢，反而他的获益比较多哦？因为可能就是说，可能他的 base 哦，刚开始的这个 without CAD 的时候，可能那个 junior 本来就很低啊，就比较低啊，然后他用了 CAD 以后，可能会改变某一些人的想法。那如果你比较 junior， 或许你可以被改变的搞不好不是太多。我是这么解释啊，不晓得这样解释得通，解释不通啊。因为说真的这样的 test， 这样的 study， 其实刚刚还是有一些 limitation 在嘛。
我是不是可以这样解释啊？就是 senior staff 呢，早有定见了哈，所以事实上会有一些这个 bias。那透过 CAD 呢，所以它可以改善的空间其实相对是大的。那 junior staff 呢，他这个战战兢兢啊，所以他这个事实上他的这个 CAD 帮忙的，虽然是有，但是弧度上面不会像senior 来的这么大。也就是说就是对 senior staff 来讲，这个改变了他的一些 bias。
我觉得这样的解释应该也是合理啊，因为实在是有一些 有些真的是 key opinion leader 哦，他都觉得他是最正确的。嗯，
好，恭喜啊，陈教授，这个有一些成果出来。我想请教就是，你是纯粹从echo 的 morphology 去做判定的嘛？哦，那这里面你的 specificity 多高？那么第二个，你有没有考虑到要加上 micro circulation 的概念进去？那另外那个我的感觉是，你这个要让它更精确其实是有比较大的数据透过 deep learning 也许会越来越 accurate。那还有一个就是说，我是很赞你这 echo 去做这个 study， 因为 echo 是很 popular， 大家都会用到的。那么这种 detect 这个诊断又是很多的人需要，甚至于诊所它也会可以做。所以你这如果有这个好的 design， 那么后端的顾客又多的话，我是预期这个可以 commercialize 的东西，这是我的感觉。
谢谢。那个我想就是说，可能回答那个。先回答，对，那个第二个问题是，我觉得就是说，第一个是那个那个 specificity 这个问题其实你在 ROC 里面，当然它的这个 ROC 是从0到100嘛。所以你一定要设定一个 specificity 来看它的 sensitivity， 或是设定一个 sensitivity 来看它的 specificity。所以我们都把这一些都调的比较高的标准了。就是说，刚刚都是用 0.95 了，0.95已经快接近就是顶了嘛。所以它这个来看这个 sensitivity 跟 specificity 其实彼此是要先设定某一个，你要看 sensitivity 就要设定 specificity， 那要看 specificity 就要设定 sensitivity。那其实都设到很高的了。那第二点就是说，有关那个刚刚就是李教授讲的，就是说。有关是不是加入 angiogenesis 啊？这个我们刚开始其实是有加入，因为我们也有一个软体在算这个 angiogenesis， 但是好像对于这个甲状腺 nodule 它的效果不好，所以我们就没有用，或许对其他肿瘤会比较好。
还有没有其他的？请教一个问题就是说你选那个 thyroid 来做超音波大家都知道我们那个超音波诊断 thyroid cancer 跟诊断 breast cancer 来讲 ，breast cancer 比较 specificity 比较高嘛，比较诊断力比较强 ，thyroid 大部分还是要靠 aspiration cytology，所以我在想有2个理由可以是不是考虑一下把这个target 从 thyroid转到 breast， 因为2个理由是：第一个，我们台湾做 mammo 做 screen 那个病人很多做1次或者根本1次他都不接受，因为太痛了。这个跟西方人不一样，因为西方人的 breast 比较大他们好像一个垒球，我们的东方人好像一个小皮球，一压下去那个疼痛的感觉有的时候痛到昏倒所以接受度就比较低。但是做超音波呢？当然做 DCIS 来讲呢 ，mammo 跟超音波是不能比。但是如果不是 DCIS calcification 的话 ，micro calcification 的话，那如果是对 tumor 来讲 ，breast 的 sonar 跟mammo 呢，那个准确度呢差不了多少。所以另外第二个问题是，西方人他们比较不希望做breast 来做那个 screen 因为说做的位置没办法掌握。另一方面，西方人 breast 里面 fatty tissue 比较高所以超音波的诊断力呢就会比较下降。那我们东方人这方面呢跟他们不一样， 所以我在想，您是不是可以考虑看看，如果把这个 target organ 从 thyroid 改成 breast，将来可以在screen 的病人上面也可以使用。好，谢谢。
那我想其实我先讲一下这个为什么做甲状腺的原因呢？因为其实我的专长是胃癌啊，那就是我那时候我没有工具去做这个EUS 啊，所以我只能够transabdomen，所以我以前做的就是transabdomen的，去看胃癌跟大肠癌啊，我是从这边开始的。后来想说要做这个，哇，这个太难了，我根本没有那个工具啊。最普遍的工具就这种，那就来做这个甲状腺。其实刚刚您讲到的就是说有关乳癌其实是在 developing 当中。其实我们其中一个主持人就是张金坚教授，所以这个乳癌其实是蛮重要的啦。因为那这个是在 developing 当中了，而且应该也是很快会有结果。
对对 ，AI can help 好，那今天大家讨论很热烈哈，再次谢谢陈教授。
那我们接下来会请魏伯利教授来为我们演讲。那我们请梁金彤主任帮我们介绍。
各位老师、各位先进、各位同道、各位年轻医师，午安啊。那接下来是大肠直肠外科的主题，我们很高兴能够邀请到魏伯利教授来帮我们做演讲。好，那我介绍起魏伯利教授，我觉得就是倍感亲切了啊，因为他是我们那个魏达成教授的那个的儿子。那他台大医学系毕业，他玩了5届。那他在这里一般外科 training 完成之后，5年的 training 完成之后呢，他住院医师的时代，那个时候我都叫他小魏皮啊。他一般外科 training 完成之后，他就跟李维杰教授一起到恩主公医院嘛哈。那在那边待了好几年啊，后来也曾经有1年待在敏盛医院。他2006年才回到北医从此回到北医之后就很努力了，就在很努力在 academic research。我也念过他在 Annals of Surgery 上面所发表的文章那就在2015年晋升教授，那现在是台北医学大学的医疗副院长那我常常在讲说，我们大肠直肠外科的领域呢，我们都是见证大肠直肠外科的发展我们都是一般外科 training 出来的但是我常常在觉得说，我们那个时候，即使魏伯利教授他在民国85年 training 出来的时候，那个时候我们大肠直肠外科也没有说很明显的分科了，我们长久就是依附在一般外科里面就是因为我们这个依附在一般外科里面呢，我敢这样觉得了，就是说我们都接受很完整的 HBP 的 training 或甚至 upper GI 的 training， 所以这个大肠直肠外科对我们来说很 competent 很简单这个实在我们 CRS 的难度也不像说 GS 那么困难了。那魏伯利教授事实上我们也是见证，我们以前也都是一般外科 training 出来都没有老师了微创手术的 training 我们也是摸索了。事实上他在做那个大肠直肠外科的 laparoscopic surgery 跟甚至现在的 robotic surgery 他都比我早他都比我早。当然是我们后来的 case number 都比他们多很多了那就一起见证这个整个大肠直肠外科手术的 evolution 了。所以我们今天很荣幸能够聆听他的演讲魏教授请。
谢谢梁教授的介绍，也感谢大会邀请我回来。我离开母校 24个年头了，能够回来非常高兴。那我在想我要讲什么的时候，其实我心中带着惶恐跟压力，我不知道我要表达什么东西。那我后来想到了，我们其实不管在哪里，莫忘初衷，都是在 evidence base 之下来配合自己的 personal experience， 最后来达到patient 跟 family 的 expectation 这3个E。那也就刚好想到了这个题目，我们过去这将近30年的大肠直肠外科的治疗的一个演进，那我们这些到离开母校之后，到其他医院服务的过程当中，我们做了些什么？那我们今天是林天佑教授的纪念讲堂讲座，那我是外科的医师，所以我的题目就包含这4个面向。那我们当然知道，过去30年当中，微创手术的发展，那其中很重要的是腹腔镜。那我们也知道，直肠癌跟大肠癌其实不完全一样。当我们投身在大肠直肠的治疗当中，其实我们更聚焦在直肠癌的一个治疗。那最后我们有一些机会来谈谈 robot 的一个角色。我想大肠直肠癌的整个治疗而言，我们不管用什么武器，我们都是希望让病人得到最佳的福祉。那这个过程当中，我们并不希望去破坏它该处理的东西，所以我们不 compromise 这个 treatment。那最早1991年，所以到现在差不多30年。那麻烦您帮我按这几个，分别把这几个点一点都让它跑。在1990年年初，差不多几个重要的大肠直肠的手术都陆陆续续的开始。在开始的过程当中，其实遭遇相当多的困难，不外乎第一个，我们要在多象限去执行手术，但是我们发展了由内而外的做法。我们要做血管的结扎，但是我们有了surgical 的 endo clip， 我们有 energy device， 我们甚至有很多的包括说 endo stapler。那我们要做 anastomosis， 我们有腹腔镜下 specific 的一个 stapler。那我们要把 tumor extraction， 我们有最简单的 wound protector， 我们到现在有 multi-trocar 的 single site incision 的一个 protector， 这些在都帮我们，让我们可以完成很多的腹腔镜的手术。然而在这一片的光明之下，腹腔镜的手术在大肠直肠的治疗当中有发展的很顺利吗？那我们就来看看号称全世界最先进的美国。我们会看到在腹腔镜的发展1991年后的10年，2000年到2004年当中的一个趋势。相较于胆囊切除，相较于 Nissen fundoplication， 整个美国的普及率也不过 10% 不到。如果细致的去看恶性肿瘤跟良性肿瘤之间的差异的时候，你会发现到恶性肿瘤低于 5%。然而，外国人的优点在于他做 study， 他接受新的 evidence 去改变他的生活模式跟他的职业模式，所以我们看到了有 COX-2， 有 COLOR-2， 有 COLOR trial， 有 Barcelona， 有 Classic trial， 有所谓的 meta-analysis 去看这所有的事情，告诉大家的质疑不要再做了，不要再质疑了。腹腔镜手术可以对癌症做好的刮清，并且提出好的一个恢复。因此，你也会看到外国人他们做事情的过程当中，在上面大肠癌，下面直肠癌的部分，在后来2004之后的几年当中，他们自己的国家资料看到，慢慢的整个 penetration rate 到 50% 或者 40%， 分别是 colon 跟 rectum 的手术。然而，在台湾的健保发展之下，它并不跟着科技的发展，它跟着健保给付码的走势，但是不失为是一个很好的 real world data 的一个反省。台湾的发展过程当中，先有腹腔镜右侧结肠癌手术的码，后有腹腔镜乙状结肠癌的手术码。因此，我们在整个研究的过程当中，我们就透过这个方式分别去看待右边跟左边的一个情况。那这是我们在先前发表的这个健保资料库的一个回顾。在那样的大的数字当中，我们只能看到一个比较 long term 的一个 result， 包括说它的住院天数、它的合并诊率、它的 ICU 使用率、它的 肺部的合并症发生率，因为我们可以了解到右边结肠的手术常常是上腹部的手术，但是透过微创手术之后，这个伤口大幅的缩小，甚至往下腹部移动，可能对于伤口疼痛的改善，间接的让病人在肺部合并症的发生率下降。那我们从健保资料库当中看到了这样的一个证据。那同样的，我们去看看左边的情况，在多年之后，那我们在这次的资料审查当中，我们事实上除了想印证先前的看到的东西之外，我们还想更进一步知道说，那短时间的术后恢复如何？那最常被谈论到就是手术后疼痛，所以我们可以看到微创手术的确比传统手术在术后疼痛的这些止痛药的需求能够大幅缩减。那其实我们有进一步的去看所谓的存活率的部分，那这次的资料就可以看得更完整。我们知道整个腹腔镜提供的服务治疗不会 compromise 所谓癌症治疗的跨侵率跟存活率，因此我认为腹腔镜在过去这一段时间，从被质疑到被肯定，到现在一直在执行。那当我到北医发展的过程当中，其实我已经有快8年多、快9年的时间在恩主公做了很多的腹腔镜手术。那这过程当中，其实我是把腹腔镜带进到北医的人。那你会看到这个 penetration rate 从我刚到的时候慢慢的上来。那你会看到我们到了2011、2012的过程当中，其实分别在 colon 跟 rectum， 我们逐渐都超过90% 的 penetration rate。那也因为这样，我们很难再做进一步的细节的 study， 也不好再做任何的发表，所以我们只是做自己的深切的反省。我们也看到了，透过这样子微创手术的一些导入之后，的确在手术时间没有差异的情况之下，出血变少，进食提早，那住院天数变短。那当然这是已经是10年前的资料，现在的资料有在进步一些。那一开始的 study 其实都聚焦在大肠癌上，因为直肠癌是另外一个领域，它的难度更高，那一直被 challenge 的，一直到近年来开始有韩国人的 Korean trial， 欧洲的 COLOR2 trial。那在今天我只分享 COLOR2 trial， 我相信也很多人都了解这个 trial， 它基本上告诉我们很多的恢复都是对的。唯一我想特别 mention 的大概是在这个区块，也就是第一位直肠癌的部分。可以看到统计学上有差异，它在什么东西上有差异？它在它的所谓的 circumferential margin 的部分会有差异。但是回到现实生活当中，你可以很容易理解的事情是，我们的视野、我们的眼睛视线是不会转弯的。所以到了第一位直肠的时候，我们用传统手术，我们其实很难看到真正骨盆腔底部的位置，甚至大家也还记得在 Common前几版的 textbook 当中，你只有看到老师的手伸进去，他用手看到 rectum 的低位的地方，因此不难想象腹腔镜手术可以得到比较好的一个 result。这样的 result 最后在后面的 follow up 当中也看到了，它对于整个直肠癌，尤其是第一位直肠癌病人的存活是有明显差异的。所以在这边我给一个小的一个 summary， 我们认为在过去这20-30年的当中，腹腔镜手术进入到一个新的领域跟新的年代，它几乎占据了所有大肠直肠癌的一个标准治疗。那不管在 oncological， 不管是在 short-term result， 它都提供非常好的一个 result。然而，对于非常低位的直肠癌的时候，那又该如何？那这边其实是所有事实所要经过的阶段，刚开始都会被嗤之以鼻，然后被很 violent 的抗拒，然后最后透过很多的 evidence 来告诉我们，其实它是可以被接受的。好，那我们就接下来看看直肠癌的部分。其实直肠癌的部分我会这样看待这件事情。第一个，在台湾过去10几年，大肠直肠癌一直都是国内最常见的新诊断的肠癌的诊断。然而在这里面当中，有将近1/3是位在直肠，虽然直肠只有短短的15公分。那如果我要更聚焦看在 extraperitoneum 10公分以内的肿瘤的时候，其实借由国外的资料可以知道，将近有60-70% 的直肠癌是位在这个区块。所以总的来说，大概至少有30% 的病人会是发生在这边。 那我们换算台湾的情况，一年16000个，大概也将近有5000位病人会碰到是在低位直肠癌。那面临低位直肠癌，我觉得真正在谈论所谓的保肛这个议题，也只有在低位直肠才值得去谈。中位直肠、高位直肠其实不需要谈，因为那都叫假议题，只有在低位直肠的时候才需要。因为我们永远希望能够为病人做好的疾病跨清，但是我们又希望能够为他保留好的生活品质，但这两造之间似乎会有一些 conflict。那会看到过去其实 APR rate 还是相当的高。那 even 我们保留了肛门，我们保留了这些手术之后的成绩，但是常常还是会有所谓的 anterior resection syndrome 的发生，它的发生率可以甚至有些报告到50% 左右。那首先要追求所谓的先有活下来才能求好，先求有再求好，所以先求命再求生活品质。在这过程当中导入了外科医师的好朋友，前面刚刚有提到的 radiation therapy。那当然在这个区块我们知道现在还没有最好的一个 model 出来，但是不失为在2期、3期的病人当中，透过肿瘤往内部的缩小、往外部的缩小跟往上面的一个缩小，可以让我们得到比较完整的外界跨清，也可以减少里面的 spillage， 然后甚至可以因此而增加一些保肛的机会。那我们在跟台北医学大学之下有3个附设医院，那北医本身附设医院比较早导入 RT 的概念，在另外一家医院它导入的比较慢，那我们就特别聚焦去看低位直肠的部分。如果有做放射治疗跟没做放射治疗的病人，他的整体预后如何？那我们可以在这个过程当中看到，其实放射治疗的确在低位直肠癌可以提供好的一个 survival benefit。那甚至我们把这样子的部分做部分的 extension， 因为我们都知道我们在现有的 MRI 的 technician 之下，虽然它很好，但是它没有 100%， 所以我们甚至对 T2 lesion 也 provide 这样子的一个 treatment modality， 希望能够提供更好的一个治疗成效。其实在直肠癌的治疗当中，不得不提到这位大师，当他提出了 TME 的一个 concept， 然后告诉我们至少要做到这么多的事情，那可以透过这样的方式，让我们的所谓的 local recurrence rate 可以低于 10%， 甚至加上 chemoradiation 之后应该低于 5%。那我们刚刚前面谈到，在低位直肠的时候，才是我们真正谈保肛的议题，所以我非常喜欢2013年 Disable Corretto 所发表的这篇文章当中，它这个图我觉得是蛮到位的，因为只有在低位的部分去看待离 anorectal junction 的距离，以及对 external sphincter 之间的 invasiveness， 我们可以去分成单纯只要做 ultra low resection， 然后做 hands-on 或者是 stable 的 coloanal anastomosis， 或者我们需要做 partial or total 的 intersphincter resection， 然后最后做 hands-on 的一个 anastomosis， 或真的万不得已碰到了 external sphincter involvement 的情况下，我们必须做所谓的 APR。那在这整个过程当中，它是在1994年被发展出来，那慢慢的也被接受到是可以作为这个手术做的癌症治疗的一个手段。那这是我们跟核心医院在早期的时候一起发展跟研究的过程当中，我们首先要看到我们这样做完之后，到底这个肛门留下来之后到底有没有意义？那其实我们可以看到它的 functional result， 其实还是有不少的病人他会需要一天解便超过3次以上，也就是超过我们所谓的 normal 的 defecation 的 frequency。那所以 quality of life 并不见得是非常非常的好，那甚至有一大部分的病人他会经历到所谓的 fragmentation， 也就是他在短时间之内往返厕所的频率相当的高。所以我们知道透过 intersphincter resection 我们可以做好的 oncological resection， 但是我们不见得能 provide 非常好的 quality of life。但是我还是愿意这样做，因为病人还是有那个价值跟值得去做这个尝试。当他真的对于这样子新的 quality of life 并不欣赏的时候，我们再去 convert 它，否则 APR 做完了之后，他就再也没有机会。那我们也在这过程当中，慢慢的把腹腔镜的手术导入进去，我们也做了一些简单的 study， 我们也看到了，其实 还是需要一个 learning curve 的 overcome。那你会看到，出血的部分的确会在腹腔镜的部分比较少。那随着 experience 的增加，我们在这个小的 study 当中看到，超过18个个案之后，我们的整个手术时间就可以有效率的减少下来。那我想，麻烦帮我点一下这个题目。我想在做所有的低位直肠癌的时候，它的 key 所谓的钥匙，基本上就是 anal-coccygeal ligament。那这是教科书上的图，这是 Catava 上的图，这是腹腔镜在执行的过程当中，你会发现到其实器械的晃动是大的，原因因为镜头也到了这么低位的地方，跟器械之间彼此之间会有一些 conflict， 所以会造成一些困难的区块。那是不是帮我点一下右边这个？那在前面梁教授的介绍当中也知道，我有做一些 robot 的部分。那你会看到，我们会先从右边把低位直肠跟anorectal 跟这个 pupil rectalis sling 分开，然后接下来把左边分开之后，我就会 shift 到 rectum 低位的正后方，我会看到了 anal-coccygeal ligament， 然后我们要 resect， 我们要 transect ventral side， 我们保留 dorsal side。那这个时候这个 key 进去打开这个门，让我们进到 intersphincter space。那慢慢大家会看到 dissection 的过程当中，慢慢的 dorsal side 被保留下来 ，ventral side 被移上去，然后就进到了whitish 的一个 circumferential 的 external sphincter area， 可以让我们 expose 出来。那我们就知道我们到达 intersphincter area。好，所以在这边我针对这两个部分做一个简单的 summary。我们认为在低位直肠癌的部分 ，chemoradiation 是有它的价值，甚至在 T2 的 lesion 也应该被思考。那腹腔镜做 intersphincter resection 技术上做得到，但是其实它不是那么好做。那接下来 robot 在这件事情上能不能有一些角色？那 robot 大家谈 too high tech for comfort。But actually not， 因为其实我们也看了很多的 study， 知道开 robot 其实有一些地方很累，你的手指头很累，你的脖子很累，因为你架在那上面。那我们知道 robot 跟腹腔镜的 rectal cancer treatment 有一个大的 study 叫做 roller trial， 他看的事情很简单，他就只看一件事，就是 conversion rate 有没有透过 robot 的导入可以让它 convert 的机会能够缩减下来。我们在那个 study 之后，我们招入了几个前面的 study。做一个简单的回归分析，我们看到了，虽然 roller trial 没有办法 demonstrate 有效的 reverse 这个 conversion rate， 但是加上前面的 study 或许还有一些机会。不过我想这个事情还在 ongoing， 还在 evolution 当中。但是在疾病的跨清上面，这两招之间是没有差异的。比较有趣的是，恢复上 robot 会比腹腔镜来得好。不过我可以了解原因在于，它有所谓的 remote center， 它可以更 further 的 reduce 所谓的 postoperative pain。那我们也针对我们自己 early period of time 的一些 experience 做一些分析，其实很难 prospective， 因为我们都是自己已经有一所定见，所以你会看到的事情是，我会选比较 high 比较 advanced 的 disease 去做 robot。relatively 简单的我就做腹腔镜，可是你却会看到在 robot 上面它的 circumferential involvement 是没有的，至少在前面的这些病人这前面40例当中都没有。那最后我想看看保留了肛门之后，到底还有没有机会保留直肠？因为我们有这么多的一些先进的一些武器可以一起协助。那这是一个低位直肠癌有2次 stroke 的一个建中老师。那我思考过，如果我为他做很标准的 intersphincter resection， 如果他是那个必须一天上厕所好多次，他拄着他的 walker， 势必会增加他跌倒的风险。我想那个不是一件好的选择，所以最后我们决定在 robot 进行这个所谓的 endoluminal 的一个 surgery。我们有效的帮他把 cancer 移除掉之后，透过病理的印证，确实拿到完整的 margin，follow 到目前超过5年以上，他 disease free。那我们把初期的成绩也秀在journal 上面，去告诉大家，到我们 follow up 的时间为止，并没有 local recurrence 的一些状况。最后，我想要把过去在 有 robot 进去之后的成绩跟老师们做一个报告。我大概执行了快1000例的大肠直肠癌的手术，其中98%以上我们是微创手术执行。那这当中有1/3是透过 robot 的一个执行，我的 conversion rate 只有0.42%。所以我想在这一段我告诉大家的是，我想 robot platform 它在目前我可以 available data 当中，它还是有机会，可能是对欧美人能够有效的 reduce 所谓的 conversion rate。那但是我想在座所有的 HR surgeon 面对 HR patient， 那我们非常 experience 的一个状况之下，大概这个数字是比较难被发展出来跟看到的。那我想它对于我们在 endoluminal 的一个 treatment 应该有一些角色的存在。我想最后我还是回到我最前面讲，在 evidence 下透过个人的 experience 去达到 patient 的 expectation。那我想 MIS 应该是现在 colorectal cancer treatment 的一个 standard。那我想 chemoradiation total maxillary excision 绝对是最好的一个方法，但是所谓的 chemoradiation 的 best solution 我想还在 evolution 当中。那我相信后面的讲者王兆元教授或许会给我们一些答案。那最后我想 role of the robot remain elusive。 谢谢。
很谢谢魏伯利教授精彩的 review 对这个微创手术的进展做一个很 comprehensive evidence based 的 review。那不晓得在座有没有什么意见要提出来一起讨论的？周恩辉教授，张碧 comment 一下。
那时候还没有 laparoscopy 爱就甲我讲，这 anatomy 爱看到再创，所以他在做 这个 rectum 的地方，在他的时代，真的不像我拢做光手来个吐，伊就安尼背，哇背个足慢的，我足推啊，我背个吼，所以讲要个基础。现在回想起来，就是说，但是真的有limitation，就是不能做到这下面来。我看他很保守，就是在那个 lower 的，所以点点都在甲讲有几个 C 啊，吼，什么confidence， 还有什么几项 C 哦 ，sexual 的问题，还有 organ preserve， 所以我现在感觉说，魏伯利还有等一下我们王兆元一定还有他那个叫做 precision medicine， 真感谢我有这老啊，个人来这学这样真多谢呢，就是这个。
谢谢张 P 的 comment。因为时间的关系，我看我们这个就 close 这个 section 谢谢。Committee 自证感谢状。
谢谢魏教授。那接下来是我们王兆元教授为我们演讲，那我们请张金坚教授为我们介绍。
各位同道，还有各位先辈，还有今天我们这个主办的田义文主任，还有董事长李博王，今天接近尾声了，不过我很高兴我刚才听到我们的这边北部的北霸天，这样我来叫南霸天来讲一下。王兆元教授，我大概介绍一下，他是高一毕业，他后来要读硕士班，读临床研究所的博士班，然后就一直从事一般外科。那么高一跟台大有一点一样，就是说大肠直肠外科很晚才分出去，所以他基本上他的老师就是那种沈伯钦啊、黄宗仁啊、柯成国，所以呢，他们是这样一路长大，也接受这个消化器外科跟一般外科。那后来他就一直比较引握在 colon 那一方面，不过他对这个基础的研究很有兴趣，所以呢，他就做了这个，后来不但当了教授，又做了临床研究所的所长。更重要的，他还引握了这个就是生物的资料库。曾经一阵子在中研院跟国卫院有办这个大肠直肠的召集人，他是一个负责召集人。这一点我们要。后来呢，他很多的 paper， 那里面对这个研究的很有兴趣，所以呢，他也得了很多的奖。那他一直都是在这里，甚至于当上了副院长。那么他现在 还是在积极做这个啊。那么在南部的话，他也做了 laparoscopy， 也做了 robotic。那么我们现在就听听他南部的经验。更重要的，他是叫做 precision therapy and surgery in rectal cancer。那想必我过去有听他讲，他也有一些这些 KRAS 啦，还有这个是一个什么 RAF 呀，这些的跟治疗有没有什么样的连接？那我们就不多浪费时间，以热烈掌声来欢迎我们的王兆元教授。
好，谢谢张教授给我介绍哈，很高兴33年哈。其实我大学1到6年是在高雄，那第7年就在台大哈，就是那年其实台大给我很多的启发。那时候我的主任就是王世明教授哈，本来那时候他有讲说要不要留在高一，都在台大啦。那时候因为家人在高雄，后来就回高雄，不然我现在应该是台大的一份子哈。这是我之前的故事。那我想在讲这个演讲之前，我稍微讲一下，就是说，我觉得大肠肠外科这几年的进步非常多。那我从2个观点来看，我第一个会讲到手术，第二个讲到分子生物学的概念哈。第一个我讲到 precision surgery， 那我是有很多感触才会想要讲到这个题目。第二讲 biomarker， 那未来我想 NGH 时代已经来了，那能不能用？我等一下就会跟大家稍微做一点简单的介绍哈。那为什么讲到这个 precision surgery？ 给我概念是，我那时候当学生的时候，老师的 那个 breast cancer 都整个拿掉哈，然后就后来就那个 MRI、BCS 越开越小哈。那 lung cancer 一样哈，我们看 lung cancer 发展史一样，从整个这个让这个 lobatum 这样切，越切像我看他们胸腔外科都是这个一个这个 GI 一钉就切下来了。我觉得这个大肠肠外科到底有没有这样的趋势，可以做这么 precise 的手术？我觉得是可以的哈。那我们知道，刚刚其实魏博教讲很清楚，直肠癌的进步这几年真的是有关这个手术的进步、病理的进步，还有这器械的进步，包括 robot 的引进，让我们可以做得非常好。那当然，刚刚讲到陈家教也讲到这个 neoadjuvant 的 therapy 对我们讲很重要，就是所谓 CCRT， 他把这个 local recurrence 下降到10。我刚刚看到魏教授他们 data， 它降低了将近8倍。那我们高位 data 是降低差不多2点多倍，从以前的10几%降低到现在的大概6%。我想它是给我们很大的进步。那这个进步，我想来自于这个一些器械的进步，那还有解剖学。我觉得就像刚刚张教讲，以前的手就一直在那边挖，好像在搅果汁机一样，在开 rectal cancer。那现在我们都是一个 anatomic plan， 非常 precise 去做这样的处理，包括淋巴腺的获取。那在 robot 下，神经你看得非常清楚。你不会去伤到神经，所以 hypogastric nerve 都可以看得非常清楚。那腹腔镜确实在 colon cancer 的已经很大的 approve， 你可以这样做。可是在腹腔镜在开 rectal cancer， 尤其刚刚讲的 low rectal cancer 是很难做的，因为第一个它没有角度可以弯，它就要像2只直直的筷子在开很低位的直肠癌。那第二个就是你要看那些神经的血管保留非常非常的困难哈。那我们看一下 robot 它的发展，可以看到非常进步非常快哈。早期进步最快就是泌尿科，它一直跑，妇产可以跑很快。可是后来居上是什么？一般外科。所以我想未来 robot 在一般科它的角色非常重要哈。我想这张 slide 可以看到，现在1年就100万人在做 robot 的病人接受哈。那我想大家都很清楚，合并症真的下降很多。我们自从我们高引进 robot 的话，这手术合并症。以前大家看到我们开那个 rectal cancer 就不小心弄到 pre-surgical process， 我们进 robot 引进没有一个病人伤到，0哈，现在 0这 complication rate 哈，就是有关那个 pre-surgical injury。那刚刚讲的 conversion rate 哈，我们高一做到现在是0，刚刚讲他们顶点是，我们刚刚是没有，几乎都是可以开得下来哈。那我想这个 robot 引进真的是对我们来讲，这个以前腹腔镜 conversion rate 真的10几%，开了一半就开不下来，真的是火气很大哈，就不行了。就改成 open， 可是 robot 进来这个就没有所谓的 conversion rate 哈。那我们最早其实我们开始发展，我那时候在跟下面讲说，我们要发展这个 robot， 人家做那么多，这个 colon 又是大外国人病，那我们要发展我们台湾自己的特色哈。所以我就跟我们 team 讲说，我们是不是做不同的手术？所以一开始我们发展就是有点不太一样。那这些概念其实是刚刚讲张教讲，我们是从一般外科的概念来的。我们知道在未来在开刀哈，血管会分得很漂亮 ，sclerosation。但是你不会把每条血管都干掉，因为干掉这个 blast 会有问题。所以我那时候就把开胃癌的概念用到这个开 colon 的观念。你可以把血管分得很干净，但你不需要去截到你每一条血管。 那而且这样子以后，我们在开 robot 的时候，你这个机器人这个 docking 就要一次而已。我去韩国学是 dual docking， 机器手背要一用2次，很花时间。那我们这样的手术是只要做一次，然后会跟他讲为什么只要做一次那我先举一个例子，这个是已经3年后了。我之前因为今天时间比较短，我是从3年前一个病人是一个很年轻的女性来找我要开直肠癌，因为很低那这是第2个 case 它离肛门5公分。那在其他医院因为 tumor 太大塞住了，做 colostomy 就从台东就直接转到高医来。那这个病人因为我第一个病人他经过一个新的治疗趋势，那时候2013年第一例的时候，那时候的 NCA 刚才大家去看告诉我们怎么治疗，就是 RT 加上 Kebistamine 或加 5FU， 刚才这样跟我写。那个病人因为他说要肛门要留下来，那个 tumor 离肛门口就有3公分，吃到阴道。那病人跟我讲要留下来，我跟他讲之前的治疗经验很不好，因为没有病人可以留下肛门的所以这个病人我也是用后来策略，就是有加上 oxaliplatin。那时候该还没有写出来的时候，我们就开始做我们是 long course RT 加上 oxaliplatin 的治疗。这一开始 tumor 这么大我想大家专家在这边一看，这个大概你都是 AP 要拿掉因为实在吃的太乱了那我们怎么做？我们就给病人放射性治疗，做 RT 就 chemo， 然后再做评估。那时候 tumor 有效，但是你 digital 一摸 tumor 还是 infiltration， 所以这个时候病人要求要留下肛门是有点困难，我们就继续再治疗。tumor 有效，但是这个时候大家可以看到还是整个是 infiltration， 所以肛门口那些 tumor 还是在的那我们再给病人再多打2个 cycle， 再做腹腔镜去做探查，不能切，还是不能切。跟病人讲对不起，这个时候还不能手术。那时候实在是想不到方法了。那时候真的是没办法，那就再打，结果发现 tumor 变大了，本来变小，现在又变大了。那时候真的好像踢到铁板一样也不知道怎么治疗。那后来是真的没办法，硬着头皮，这 tumor 又比原来更大。那后来只好跟病人讲说，那假如说你要留下肛门，我们试试看别的方式。我就换一个 regimen， 就 FOLFIRI 就打上去，再打7个 cycle， 打完再帮病人做评估。这个时候病人可以开刀，再帮病人做手术那这个病人打 FOLFIRI 变成这样子那我们今年也有发表一篇文章，就是打 FOLFIRI 的病人里面有大概7到8成病人打 FOLFIRI 变有效，所以你可以 change regimen 那可以看到 tumor 就从上面这样一直变到几乎看不到。那我们帮病人看这个 CA 从300多降到3点多这个病人最重要的是这个病人等多久？看他等了1年了356天，不是365天那时候告诉我一个概念，说病人假如要真的要完成一个好的手术，是不是每个病人该奈都是照高奈讲的6到8周做手术？你可不可以 individualize 帮病人设计这个治疗计划来完成我们要做的这件事，还有病人的期待那这时候因为这个病人他开刀的时间这个可以等了1年了这个影像可以放吗？好，所以我们可以看到这个 tissue 非常 fibrosis 但是因为有 robot， 其实我不害怕了因为 robot 是真的是我们直肠癌的好帮手所以我们每个 plan 慢慢做那可以找出你要的那个 surgical plan。那我的习惯我是用 spectacle， 我比较少用 Caesar 了，因为 spectacle 我觉得很像腹腔镜的 hooker 所以很好用。那在一些微小的地方，其实看到 fibrosis 非常严重，但是真的 robot 下我是不会害怕我知道哪个 plan 我可以下去，哪个地方我可以做。那跟前面的一些组织 infiltrate 部分，大家可以看到实在之前是非常厉害的，其实我们可以很 easy 的把这样子分出来，那达到你要的这个效果好，那这个病人出来是 PCR 是没有 cancer cell。那我们高一做，自从2013年开始做到现在，大概我们的病人里面10个是没有 cancer cell，3个30几%，几乎这代表这3成病人是完全没有 cancer cell。那我们用的策略是每个病人的治疗计划都不一样我们是真的是 individual 在帮病人做这样的治疗策略那我们来看看一件事啦。那为什么传统的我们都叫病人说 high ligation？ 那这个都是从早期日本那个观念来讲。我们知道淋巴腺252那个实际上是 lymph node 是 root 的地方。那日本告诉我们说你要做 high ligation， high ligation 做人会发生什么事 ？blood supply 你会受到影响。那你要切更多的肠子。那你为了要 tension free 要做 spleen flexion 的 mobilization， 你才能拉得下来接，不然你根本拉不下来。那这样做是一定是对的吗？那假如说我们可以把血管分干净，刚刚讲像开胃癌一样把它分很干净，选择你要的血管去做结扎、做保留，这样可不可以这样做？ 那我们是不是有机会切不要多那么长子？那你有比较好的 blood supply， 也不需要做这个 spleen facial 的 mobilization 哈。好，那这是议题。那为什么要做 high ligation？ 大家为了就是什么？日本人在告诉我们，淋巴腺要这样拿，你淋巴腺才拿得多嘛。那你要这样的，但是你要做 mobilization 嘛。那假如你不这样做，会产生怎么样好处？你 blood supply 可能会比较好 ，survival 有没有差别？我等一下跟他讲，几乎是没有差，不会因为你这样没有做 high ligation， 但是淋巴腺要清的哈，这边讲特别讲，而且神经你是可以保留，因为你做 high ligation 的时候很容易把 hypergation nerve 伤到，会造成病人术后的 unibladder 的 incontinence， 还有这个 sexual dysfunction。那这样子你肠子够，你根本不需要做那么大的这个 mobilization 哈。好，这个我们看到解剖图就知道了，在录的地方那么多神经，你假如说没有你做 high ligation 不小心是很容易伤到这个 hypergation nerve 哈。那这个 gangrene 你很容易伤到哈。好，那么这来看这个2006这个日本这个文章哈，我们看到这个253这个淋巴腺有，就是录的淋巴腺角有的话，那你的 survival 是比较差的 ，cancer survival 也比较差。可是我们去看仔细的数字，当你是 T1 到 T4 的时候，其实它淋巴腺会 meta 比例真的很低 ，T1 是不可能几乎是0。那对不起 T1 是0 ，T1 是0.4，那 T2 是0.2点多，那整 T4 才也是2点多，那整个大概是多少 ？1.7。这也告诉我们什么数字？我们都学日本的 high ligation， 你得到的 benefit 只有 1.7%， 那这个 1.7% 到底有值得这样做吗？我们是需要为这样去做这 1.7% 去做 high ligation 吗？哈，我跟他讲，我们高一去年遇到2个病人，就是在其他医院做 high ligation， 结果 massive bowel ischemia， 整个喉咙都黑掉了，送到我们医院来。我那2个病人我们处理得很惨，真的非常惨。为什么？因为我们 spleen facial 有 7% 的地方是没有 marginal supply 的，所以你阶段是要非常小心哈。好，那我们来看国外的一个review的文章，可以看到怎么样的一个结果。这个 lymph node 的253，看这么多 study 告诉我们，这样很低的 incidence 会有 meta， 而且它也不影响到你的 recurrent 跟 survival。那为什么要这样的 high ligation？ 好，我们再看下一个文章，就是这个 IMA high ligation 可能会影响 blood supply， 另外它也会影响到这个 bowel 的 function。Urinary function、sexual function 都会受到影响。那我们来看传统的淋巴腺扩清，就像这张图写的哈，那你就是 IMA ligation、IME ligation 整个这个地方都清掉。哦，那这个是标准的这个我们做 rectal cancer 的手术的治疗方式哈。那我们高一是没有这样做了哈。第一个，我们把 IMA root 全部找出来，找出来以后开始扩清哈。那从这个IMV 这整个都清下来，其实我们应该清到这个地方了哈。这个图，这个我一个学生画的不是很漂亮，我们这整个地方全部都清掉哈。那清完了以后，断在这个 left coronary artery 这个地方就可以了。那这个地方，假如说你是在比较高的位置，我们会断到 sacral artery。那假如 lateral 就断到这个 superior rectal artery， 但这个地方你要清干净了哈，不是说这个地方你就不清，还是血管会做扩清的动作哈。那旁边也做 mobilization， 那往下做这个 pelvic face 哈，我想这个 lobar 的手术技巧差不多这样子哈。那我们今年也发表这个文章哈，我把它选一个名字叫做 high dissection selected ligation， 因为找不到相关的文章，我就把它定这个名词哈。你可以选择你要断的血管，但是切药的肠子，这样就够了哈。那这张图就是告诉我们说，我们可以怎么做？你把淋巴腺清得很干净。你洗口膜就断洗口膜的血管 ，retin 都断 retin 的血管，但是淋巴腺还是整个都清掉哈。那 survival rate 跟那个 disease free survival， 你去看，我们有去比较全世界的 center， 我想我们 data 是 comparable， 比全世界最好的 center， 我们 data survival 都是接近的，代表这个技术是可行的，而且病人不会受到任何的影响哈。那第二部分我来跟大家讲这个有关 biomarker 哈。那我想这是一个很夯的主题，但是因为今天时间不是很长，我简单跟大家讲一些基本的概念就好了。我想这张slide大家都很清楚哈。我们大肠癌现在目前就分成4个 category， 就是 consider molecular subtype 1、2、3、4。那这个在早期，我想我们都是分很简单，就是 chromosome instability 跟 microsatellite instability 2个 pathway。像我们分得非常细，那这么细为什么要这么细？因为它的治疗方式是完全不一样。那以 我们传统的 pathway 就是 type 2跟3，就 canonical 跟 metabolic pathway。那 canonical 这个 pathway 就 Wnt pathway， 那 metabolic pathway 就跟 KRAS mutation 比较有关系。那 type 1的话是跟免疫比较有关系，包括 BRAF mutation 跟 hypermethylation 这个都有关系。那 type 4的话就是跟 TGF beta 有关系。早上这个在那里教授在讲这个 tumor cell infiltration、lymphocyte infiltration 跟 TGF beta 其实也有很大的关系，因为它跟 soma infiltration 是有关系，因为这两群预后都是特别的差，特别的差。那我们来看这个，现在以前都看被他笑就有个眼科叫左眼科那大肠现在已经分得很清楚，左大肠跟右大肠治疗方式是完全不一样。我们看右大肠预后是比较差的，左大肠预后是比较好的。那可以看它的 subtype 也不一样，在右大肠是 CMS 1回来的比较高，那左大肠这个在 CMS 23来的比较高，所以基本它的机转是不太一样，它的基因突变结构都是完全的不一样好，那所以我们现在治疗都是分左大肠、右大肠，以前分右大肠、左大肠跟直肠，现在直肠就分在这个左大肠里面的治疗策略里面好，那我们来看这一张这样非常有趣右边的刚刚讲过，它是跟免疫有关系的，所以它对免疫的治疗有效。左大肠会对 anti-EGFR 有效，所以当你把它分左右大肠的时候，其实它的治疗策是完全不一样。所以以后未来的治疗，你一样要去做选择包括这个左右大肠的位置，还有你的基因 profile 都要做一个非常完整的一个分析那这个是我们高一跟中院合作的一个计划那我们可以看到一些有趣的 data我们发现台湾人在 right side 大肠 ABC mutation 是比欧洲人来的高，但是在右大肠PIK3CA 比这个西方来的低。那台湾人很特别他左大肠的 PIK3CA 比西方来的高很多。这个是我看我目前去找文献，目前全亚洲还没有人发现，我们最近应该会把它整理，把它 publish 在左大肠，我们台湾人的 PIK3CA 特别高，那 PIK3K mutation 病人去对 anti-EGFR 是没有效的。这也可以解释说，在左侧大肠刚刚讲要用 anti-EGFR 治疗里面，为什么这群病人没有效？因为这些病人可能是 PIK3CA pathway 是 mutation， 所以它对传统的 Erbitux 跟 panitumumab 是没有效的那我们来看这个整个这个癌症的发展在大肠一样，最左边我刚刚讲最传统 pathway MSI， 还有这个chromosome instability， 这个左右 genomic pathway 已经跑到 epigenomic pathway 了跟 methylation， 那刚刚讲的 transcription pathway CMS 1、2、3、4到 soma immune 的关联性，你要知道这个 tumor 它没有 immunogenicity 或是没有 immunogenicity， 还有左右位置刚刚讲的还有 driver 基因的突变 ，KRAS 在左边比较常见 ，BRAF 在右边比较常见。那 colon 要分 proxima 跟 distal 所以未来的趋势一定是非常的清楚的好，那我们看看一个临床的一个概念。我们当一个病人转移性大肠癌病人，我们给病人 anti-EGFR 治疗的时候 ，primer 我们可以看到，这些病人里面有40% 是所谓的 RAS 是 Y type， 就是 KRAS Y type、NRAS Y type、PIK 什么都是 Y type。那你可以接受 anti-EGFR 治疗，可是，在治疗过程中，它会产生什么情况？叫 acquired mutation。它本来是 Y type 会被 mutation， 所以治疗会产生失效。那现在目前大概 liquid biopsy 就可以解决这个问题。你这样一个简单 liquid biopsy 就可以知道这个病人基因 profile 有没有做改变那我这边举一个例子所以在一些假如说这些病人他有其他基因突变，你不能用单纯的这个传统的标靶药治疗，你要加上不同机转的标靶药治疗才会有效包括我们 BRAF mutation 病人，你包括你可能不是只有一个 BRAF 的 inhibitor， 再加上 Erbitux， 你要很多种药去做 combination 才会有效那我举一个最近一个例子，我自己个人一个经验这是一个 sigmoid colon cancer 的病人，那一开始是 stage 3C， 不过是相当 advanced， 是 T4A-N2B-N0， 我想这个预后是相当的不好。那你 acute obstruction， 所以我们帮他做个 colostomy， 放个 port， 那开始给病人 neoadjuvant chemotherapy。那我们在我们高一 colon cancer 相当 advanced， 我们其实比其他人来的早，我们很早就做 CCRT 的概念我想 CCRT 目前在 rectal cancer 证据很强，可是 colon cancer 今年因为我跟英国有些合作计划，他们已经开始在做了 local advanced colon cancer 开始做 CCRT 了，他们认为 colon cancer 可以做 advanced 可以做那这个病人做完后，我们就帮病人开刀，把这个左边大肠切掉 stomy closure。那当然后面就给这个 adjuvant chemotherapy 打 4FOXC， 这是标准的治疗策略哈。那治疗过程中，这个病人发生 liver 跟 non-meta， 好，从 stage 3变 stage 4。那我们高一是标准的这些基因 profile 一定会列的哈 ，KRAS、NRAS、BRAF 都是 Y type。那 UGT1A1 是66，我们会帮病人多验整个病人 metabolic 基因哈。那这个病人，我想左大肠 RAS Y type。VY 我想最好 first choice 是 anti-EGFR， 所以我们就给病人 anti-EGFR， 而且我们病人剂量从180调到260哈，这个是相当高的剂量。那我们高一有研究哈，你调高的剂量，其实病人效果会比较好。那后来 liver 就消得很好 ，liver 就切完了，好就切完了。那lung的部分，我们因为这个病人lung是好几颗，等一下跟大家讲哈，所以我们就给病人再接受5个 cycle 的。saturation 治疗，但在治疗过程中，我们发觉血液有在上升，我们就有问题，赶快搞片里面再做 CT， 发觉让 PD 哈。那我跟他讲，这个 PD 有点故事哈。我们看这个病人哈，这个病人很有趣，这是左边的肺哈，这是还没有做这个标靶胺之前，那做完变小了，哦变小了，在过程中又变大了，哦这 T 有长出来了哈，这是左边的哦。那我们看右边，这个病人很有趣哈，右边大家看这一颗哈。其实在还没有标靶药前是这样子，打完标靶药消得很小，我们看也是有效哈。那最后再继续打还是有效，那告诉我们一件事，什么事？这个病人左右肺的反应是完全不一样的，右边肺一直在变小，左边的肺反而在变大。那到底什么 story 在里面？所以我们就把他的标本拿去做基因检测，做 NGS。所以我们高一现在 NGS 已经开始在做了哈。我们把左边的肺去做 NGS。发现一个非常有趣的事情哈，我刚刚跟大家讲，这个病人 primary tumor RAS 是 Y type， 他发生什么事？这个 KRAS 变 G12D mutation， 它从 RAS Y type 变 mutation， 而且它产生 PIK3CA 也 mutation， 同时两个基因都发生突变，这就是所谓的 acquired mutation。病人在治疗过程中，他可能从传统的 Y type 变 mutation， 所以你整个治疗策略就必须要换了。那这个病人我有帮他测那个tumor mutation burden， 他 MSI 不高了哈，所以我跟病人讲说，2线可能贝法舒斯酶，3线可能可以 Rigonimo 这样做使用。我想这个 NGS 时代已经来了，当你把所有资料都摊开来看的话，你可以告诉病人1线到4线治疗，那天来我就帮他设计好1到4线要怎么治疗，你都可以跟他讲，你3线、4线怎么治疗，你不用担心。那你的他会问我，这个因为他这个病人本身是个医生啊，他也很厉害，那问我一句话，我能不能 re-challenge？ 我说像这个题目，我想两边也很清楚。现在非常热，我能不能 re-challenge？ 我说可以，你只要做liquid biopsy就只可以做 re-challenge， 因为 re-challenge 会多1线的机会，我们可以3线再 re-challenge 原来的药物。所以我讲 NGS 的时代已经来了，病人 affordable， 因为这个病人他 economic 非常没问题。他说你都不要跟我考虑钱的问题，你就帮我治疗好就好了哈。所以我觉得未来 NGS 是已经到我们这个领域了。我们这个外科医师刚刚，我想。很多前辈都讲到，未来我们外科医师可能内科东西也要懂，不然你没办法去帮病人做完整的一个治疗哈。好，我简单做一个结论哈 ，high dissection、low ligation 是可以的 ，sterilization 也可以，你产生的结果是一样的。那只要你开刀的时候，你这个用 LOBA 慢慢分，LOBA 还有一个好处，你在分 part RDV more， 其实你会很 comfortable 哈。尤其我们最近像有一个这个 lymph node 在 aorta 很多 lymph node 做完 chemo 后消得很小，我就很好清，你清起来你也觉得很 comfortable 哈。那我想。整个这个基因的 profile 大家肯定要了解，因为你才知道你的 treatment target 在哪里，你用什么药物在帮病人治疗。那 biomarker 我想未来会进来。那政府现在在讲 NGS 到底要不要给付，最近好像健保署也要开会讨论这件事。那他也选择说哪些病人是适合 NGS 给付。那假如说 NGS 可以给付，我想可以照顾更多的病人哈。好，那这就以上报告啊。对，我讲这张一定要讲一下哈。我觉得 precision therapy 哈，常常就讲到 precision medicine。好像外科医师都被忽略了哈，那外科医师是什么角色？假如今天你可以做这么好，你就有 precision surgery， 可以教到 precision medicine 变成所谓的 precision therapy 哈。所以请内科医师不要忘记外科医师的存在哈。好，那这是我最后一张 slide， 好，谢谢各位，谢谢。
谢谢王教授的精彩演讲，不知道大家有没有什么问题要请教？王教授，我是最近那个2020的 ESMO 的这个对这个基因 test 的 guideline 哈，只有几个 cancer，colon 跟 breast 都还不行。那你现在一下体检用超前部署，有没有什么自己的一个 criteria？
我觉得是应该这样，一线的话大概还不用急着 NGH 上了，因为一线的病目前 target therapy 都有标准治疗。可是当一线失效的时候，我们知道 colon cancer 二线是没有 target therapy 的，病人是没有健保是没有给付。我觉得二线就病人讲 afford 都可以用了，因为这时候你二线就可以帮病人选择适当的药物了。
因为我为什么这样讲？因为 NGS 有时候做了以后，还 mutation 有啊，无药啊，你知道啊，都还艰苦啦，那种怎么办？我们有很多的 mutation， 或者哈，
我跟张教报告，其实他们这个报告其实蛮完整的。他讲没有药，他会告诉你有 off-label use 药，像这个病人他其实 sofosbuvir 他有效，他会给你一份报告，他可以用这个药，就是肝癌刚刚在讲的那个肝癌药 sofosbuvir 那个有效，所以他会告诉你说 off-label use 可以用，但是当然是你要跟病人讲这是 off-label use。当病人没有药的时候，你可以考虑。我想以后的癌症应该是跨癌别啦，它可能同一个 pathway， 但是用的药可能会一样。
谢谢。好，那我们因为delay太多了哈，后面还有2个演讲，那我就代表李博煌教授来给他赠送这个。
我们下一个演讲是由我们台大医院的郭廷钧医师来为大家报告。那我们请我们的叶副院长。
再过来，我们邀请郭廷钧医师帮我们做这个演讲。那郭医师还相当年轻哈，2012年才毕业嘛，啊，2012。主治医师，对不起，2014主治医师。那2015呢，进修博士班，那现在已经 qualify 了，还是对嘛哈？那今天那个郭医师会跟我们报告一下在 pancreatic cancer 的这个 glycosylation 的这个议题。那这篇 paper 当然发表的很好，那郭医师待会会跟我们报告啊，谢谢。
大家午安，我是台大医院郭廷钧。今天要跟大家讲的是 expression and function of all glycosyltransferase C1Q-T1 in pancreatic cancer。然后感谢田玉文教授以及解剖学科黄敏全教授指导。然后，就是这篇 paper 很有幸，就是发表在这个月发表在 Oncogene， 然后它题目是 C1Q-T1 high expression is associated with poor survival of patients with pancreatic ductal adenocarcinoma and promotes cell evasiveness through integrin alpha V。接下来就跟大家介绍一下这篇论文的主要的内容。然后就是据我们所知的话，其实 pancreatic cancer 是非常的致死率非常高。然后在台湾的话，在2019年其实是 all cancer mortality 的第7位。然后在全世界的话，其实也是10大死因的第6位。然后甚至在美国预测在2-3年内的话，还有可能会进展到第2位。然后可以看说，其实这是一个在发表在 Lancet 一个 global 的 data， 这是一个 survival statistic。可以看到这个2条线，一条是 incidence， 一条是 mortality， 这2条线几乎是重叠的，就表示说大部分的病人 pancreatic cancer 的病人都会死掉。虽然说从1990年代到2017年代，我们这个 incidence of mortality 的这个线已经就是有大幅的进步，就是有2倍的成长，不过其实还是跟其他的癌症还是有很大的差距，就是还有很多努力的空间。然后刚刚讲的是 global data， 接下来这个是从 SEER 就是美国的 data， 可以看到其实它的 incidence 跟 mortality 也是几乎是重叠的。然后从1975年代的 5-year survival 大概是 3.8%， 然后到2020年其实进步了3倍到 10%。然后到底是为什么原因可以进步呢？然后就刚刚有讲说，其实 survival 非常的差，然后这也是美国的 data， 可以看到就是粉红色框起来是 pancreatic cancer， 大概有82%的病人诊断都一定会死亡。另外的话，这些 死亡的病人的话，其实有大于73% 的病人其实是在1年内就诊断的12个月内就会死亡。所以预后是非常的差的。那为什么预后这么差呢？其实主要是因为它其实诊断的时候都是一个比较 advanced stage， 然后它的因为没有什么好的一个临床的症状，然后另外的话就是有85%的病人其实一开始诊断的时候就是一个 non-resectable 的 status， 然后可以看到这个 stage 跟它的跟它的 5-year survival 是有一个很大的关系。所以如果能够提早诊断的话，其实想必它的预后是有办法可以得到一些提升。然后到底我们对于这个 pancreatic cancer 的一个 unmet needs 到底是哪些？就是我们必须克服的。第一个的话，就是身为一个外科医师，我们当然就是可以先做一些 emerging 的 strategy， 包括说增加一些 radicality， 就是扩清率，或者找到一些 therapeutic 的 targets。然后第二个部分的话，就是透过刚刚大家都有提到的 genomic and molecular biology， 就是去看说到底哪些是跟我们的 metastasis， 或是在 pancreatic cancer 比较特别是在一个 desmoplasia 的环境是有什么样的关系可以去做克服。然后第三个就是刚刚提到的，就是 early diagnosis 或者 early detection， 如果能透过这些研究找到一个 novel 的 biomarker， 想必是可以提高就是 pancreatic cancer 的 survival。然后目前的话，针对 pancreatic cancer 的一些 state of art treatment 大概有几个 strategy。第一个的话，就是我们必须要想办法得到更多的 R0 resection， 就是得到更多的 margin active。第一个的话，当然就是从就是 Wilson process 比较常发生 margin positive 的地方，然后就是透过一个 mesopancreas 跟 mesojejunum 的 resection。然后第二部分的话，比较常发生 margin positive 就是在 vascular groove， 就是 SMPV。如果我们切更多的 SMV portal vein 的话，那可能有机会就是改善这个地方的一个 margin positive 的状况。然后第三个话就是 pancreatic neck transection site 也是一个常见的 margin positive 的位置。然后刚刚其实上午田教授也有介绍到，就是我们就是做比较多 total pancreatectomy 或是 WASA， 或是刚刚田教授提到的现在比较新的一个术式 WASA， 其实针对一个 central located PDAC 其实都是一个有办法得到更多的 margin negative 的一个术式方法。然后再来的话就是透过一些像是 neoadjuvant 去做 downstage， 这些方法的话都是目前觉得可能有机会得到更多的一个 R0 resection， 或是从外科的角度去改善 PDAC 的一个 prognosis 的方式。然后这是针对于 pancreatic cancer 一些比较重要的一些 clinical trial， 然后比较特别是大家比较 promising， 就是在这个 Project 24， 就是 modified FOLFIRINOX 其实是目前最 promising 的一个 regimen， 它是一个 adjuvant 的 setting， 然后目前的话可以在 overall survival 最高是可以达到 54.4 个月，所以目前的话大家其实还是对这个 regimen 虽然是比较旧的一个 regimen， 可是大家还是对它寄予厚望，这样子。然后再来就是从1975年代开始，慢慢的有很多的 clinical trial 的发表，然后随着这些 clinical trial 的成功，其实我们的 survival 是慢慢的增加，一直到现在这个 modified FOLFIRINOX。那到底什么样是一个好的一个 winning formula， 其实还不是很确定，因为虽然说已经进展到 5-year survival 是 10%， 可是其实还是有很多成长的空间。接下来就要讲说，到底要怎么样有机会得到一些成长。首先讲到pancreatic cancer 的一个 tumor microenvironment， 简称 TME。然后在 pancreatic cancer， 它比较特别的是，它旁边有一个很致密的 stroma， mesenchymal stroma。然后在这个 stroma 里面，其实很多的是一个fibroblast 成分跟这个 extracellular matrix。然后这样子的一个 stroma， 其实它会让整个环境改变。然后这个卡通图呢，其实就是说，这个 stroma 会包着这个 pancreatic cancer 的 cell， 然后这样子的一个 desmoplastic stroma， 其实它本身会去增长它自己的 growth， 然后也会带来一些 pro-tumor genetic 的一个 response。另外的话，它对于这个 tumor genesis 或是也会增加更多的 radiochemo resistance。然后另外的话，就是在 pancreas stellate cell， 就是胰脏的一些stellate cell 的话，其实它本身它对于这个 extracellular matrix 就是胞外基质，它是有一个帮助，然后或者是它有办法去 build 或是 maintain 这个 ECM 的成分，然后它们之间其实会有一些 crosstalk， 就是这个ECM 的话，它其实也会 这个 PDAC cell 就是 cancer cell 会 adapt 这些 PSC， 然后变成 cancer associated fibroblast， 然后它就会产生更多变化的这个 ECM， 然后再去活化它的这个 PSC 再去活化更多的这个 CAP， 所以它们之间就是有一个 crosstalk， 然后造成一个恶性循环，癌症就会越来越严重。然后接下来就是这个 trauma reprecipitation 的话，它其实就是在这些 tumor， 然后跟这个 就是 cancer associated fibroblast， 还有这个 ECM 之间的一个很厉害的 crosstalk， 然后就叫做这个。然后另外的话，这个作用的话，其实就是透过这样子的一个恶性循环的作用，然后就会 promote 这个 pancreatic cancer 的成长。然后所以过去大家就曾经，这是一个就是讲这个 microenvironment 的卡通图，然后大家就想说，在过去可能想说，那如果我们直接去 complete ablation 这样子的一个desmoplastic stroma 是不是有办法可以得到很好的治疗？因为刚刚讲说这是一个这样子的一个循环，那如果我们打破这样一个循环，不过在过去的一个动物实验跟临床实验证明，其实我们直接 complete ablation 这个 desmoplastic stroma 反而得到一个相反的效果，就是那个时候实验的结果是病人就在或是老鼠在 ablation 之后，反而它的 disease 得到就是进展的更快，然后死亡率更高，所以就后来这个实验就终止。然后接下来讲说，就是在这是细胞，然后这细胞外的基质包括说 collagen、HA， 然后还有 laminin、fibronectin 这些。跟细胞之间的一个 interaction 主要透过哪些东西？除了 integrin 之外，像是 DDR、CD44、laminin receptor 或是 FAC 或是 SUC family， 其实都是目前这是发表在2020的 paper， 就是目前这1-2年来比较重要在 pancreatic cancer 或是其他 cancer 一个很重要的 targeting， 主要就是去找说在就是 ECM 跟 tumor 之间 interaction， 然后透过这个 interaction 去治疗，看有没有机会去治疗这样子的一个 cancer。然后 integrin 它其实是一个就是 integrin 它是透过24个 heterodimer， 然后有18个 alpha 跟18个 alpha 跟8个 beta， 然后去做一个排列组合。然后它本身就是透过它的结构的不同，或者它的表面的就是 cell surface 的一些 modification 的不同，它会造成它的就是被 activated 或是被 inactivated。然后另外的话，就是它其实作用非常的多，包括说在一些 cancer 的作用，然后它也会跟一些像是 receptor tyrosine kinase 或是在 cell surface 的 mucin 之间会有一些 interaction， 造成一些后续的一些 pathophysiology 或是 tumorigenesis。然后接下来的话就是讲到说 glycosylation 就是糖化作用。糖化作用其实是在我们的一个 post-translational 的一个 modification， 就是在蛋白质的转移后的包装扮演一个很重要的角色。然后 glycosylation 有非常多种，然后今天大概主要就讲的是这个最常见在 cancer 或是就是哺乳类细胞上面的一个 O-glycosylation 这个形态。然后这个O-glycosylation 的变化呢，就是这个 aberrant glycan 其实在过去就曾经被发表过，就是很多 cancer 就是很多人类的 solid cancer 的一个 biomarker， 就是跟预后是有关系的。那另外的话，透过这些aberrant glycan 的话，其实它也会去改变细胞对于这个环境这个 TME 的一个 adaptation， 然后就让细胞就更能去适应这样的环境。然后在 O-glycosylation 的 biosynthesis， 它其实是在这个 peptide 上面的 serine 或者 serine， 然后透过这个 GalNAc 这个 enzyme， 然后加上一个正方形的糖链，就是 GalNAc， 然后在第二个就形成 TN antigen， 然后接下来的话就透过今天要讲的这个 C1-GalT1 这个 enzyme， 然后再加上一个圆圆的这个是 galactose， 然后加上这个 galactose 之后。形成第二步骤，然后它就会形成 T antigen， 然后接下来再透过不同的 branching 或是透过不同的增长或是中断作用，然后就产生不同的糖类的变化。然后这些糖类的变化就是跟后续的不管是正常生理功能或是一些癌症的细胞的生理功能都有息息相关。 然后这个 C1QT1 在 pancreatic cancer 的话，其实在我们实验室或者在我们这个 team 的话，过去的话就有发表过 C1QT1 的 overexpression， 在不管是 breast cancer、colorectal cancer、gastric cancer、head and neck cancer、hepatoma 跟 ovarian cancer， 其实都是跟它的一个 malignant behavior 有关系。不过就曾经有人发表过在这个 C1QT1 的 NACA mice， 可是在这个 NACA mice 上面的话，看到它是一个相反的一个就是 property。那我们就想到底是为什么呢？就是其实在这个时候，其实就是 C1QT1 对于 pancreatic cancer 的一个角色，到底是一个增长关系还是一个抑制的关系，是不是非常的明确？然后我们这个 study 的话是希望可以得到，就是希望这个C1QT1可以成为一个 potential 的 therapeutic target。那另外的话就是可以去了解说 OGA-cosylation 在 integrin alpha 或是其他的 integrin subunits 跟 PDAC 之间的一个 pathogenesis 的一个关系，或是扮演的角色。接下来就讲到我们的实验的结果。首先的话，就是在我们从这个 Oncomine 这个 public database 可以看到说，C1QT1 的 mRNA level 就是在 cancer 里面跟 normal tissue 其实是一个，就是在 cancer 里面会有一个 significant 的 increase。然后在我们的病理切片上面看起来，就是把它分成0分就是比较低的，然后2分的话就是最高的染色，就是比较 high density。然后可以看到说，在 cancer 里面大概有超过85%的 cancer 它都是有一个 higher expression。然后右边是台大医院就是手术的病人的 data， 可以看到说C1QT1比较高的就是2分以上，大于等于就是2分的病人，就是红色这条线，它的不管是 disease-free survival 或是 overall survival 都是比较差的。所以说就是在不管是在 tissue 里面，或者在 mRNA 表现，或是它跟就是比较，如果它的 expression 比较高的话，它跟病人的 survival 也是会有比较有关系，就是它 survival 会比较差。所以它是可以 prediction。然后再来的话就是在细胞实验，然后这是我们有的一个9株的 pancreatic cancer cell 跟1株的 normal 的 cell 的，它的C1QT1 的 level 其实表现是不一样。然后首先的话，我们就是用 knockdown 的方式，就是降低它的表现，然后去看说它对于细胞的一些 malignant behavior 的影响。啊，就是在就是 C1QT1 的 knockdown 在这5株的pancreatic cancer cell 里面可以看到说它的 viability， 然后 migration 跟 invasion 都是有一个 significant 的 increase 的 decrease， 就是它会降低这些，就是如果我们调降 C1QT1 的表现的话，它这些恶性的表征其实都会被降低。然后可以看到这个是flow cytometry 的 data， 可以看到说这个 T antigen 其实是在 C1QT1 knockdown 之后，它其实是有上升的。然后再来就是说，我们去看说C1QT1 的 knockdown 这个，如果是 normal cell 跟就是 pancreatic cancer cell 的话比较，这边是就是可以，我们是用一个 C1QT1 的 inhibitor， 就是 itraconazole， 它其实是一个治疗霉菌的药物，不过它可以去就是很有效的抑制 C1QT1 的一个表现。然后就是在 cancer cell 的抑制之下，就是 cancer cell 用这个 itraconazole 治疗之下，它的 cell viability 是有 significant decrease。不过在 normal cell 的话，它 decrease 的情况就没有这么的明显，而更证明说其实它是 potential 可以用来治疗 pancreatic cancer。因为如果它对于 normal 的 ductal cell 都有一些毒性的话，可能就不适合作为一个 therapeutic target。然后再来是刚刚做的是knockdown，就是降低它的表现。接下来是做一个反向的，就是我们去 overexpression C1QT1 的 expression， 然后可以看到它的migration 跟 invasion 都是在2株细胞里面都可以看到一个增长的情况。然后不过它的 viability 的话是没有特别的影响，因为在有些 cancer 其实它这个表现大概就是已经到了顶点，如果再增强的话，可能不太会影响它的 viability。然后接下来的话就是我们去看，因为现在pancreatic cancer 的 gold standard 的 cytotoxic agent 还是 gemcitabine， 不过很多的病人其实很快的就会进展到 gemcitabine resistance 或是一些 chemo resistant 其他的 chemo resistant。然后我们就是在这些 gemcitabine treated cell， 我们去看说C1QT1 的表现是不是有什么影响？然后从这个 flow cytometry 的 apoptosis 的实验看到说，在gemcitabine治疗细胞之下，C1QT1 就是可以再提高它的 early apoptosis。 然后这就表示说 C1-GAL-T1 对于这样子的 pancreatic cancer cell 可能就是它的卷沙病的治疗可能会有一个 synergistic effect， 或者是说它可以让这些细胞对于卷沙病的 sensitivity 提高，就是让它更 sensitize 卷沙病的治疗的效果。然后我们去看一些anti-apoptotic factor， 就是这个 BCL-XL， 可以看到在 C1-GAL-T1 knockdown 之下，这个 anti-apoptotic 的 factor 其实是有一个 decrease 的现象。然后刚刚是transient 的 knockdown， 然后在 stable knockdown 的细胞株底下的话，也是看到说就是这样子的一个 apoptosis 增加的情况也是存在，所以它就是对不管是对于一个暂时性的表现，或是在一个长期表现C1-GAL-T1 比较低的细胞的话，都是有一样的 sensitize 卷沙病的效果。然后接下来是动物实验，就是我们用这个 C1-GAL-T1 stable knockdown 的 cell line， 然后去做这个 Nosky 的 xenograft， 然后这是在就是 subcutaneous injection 的 model， 然后可以看到它的 tumor size 在C1-GAL-T1 knockdown 的这个组别的话，它的 tumor weight 跟 tumor size 都是有一个 significant 的 decrease。然后另外的话是一个 isotopic 的 injection 的 model， 就是把 C1-GAL-T1 的 cell 不好意思，把那个 knockdown 的pancreatic cancer cell 就是打到老鼠的 pancreas， 然后去拿下来之后看到说，不管是 primary tumor 或是 liver mass 或是 lung mass 或是 peritoneal seeding 都是有一个 significant decrease 的情况。然后所以说在就是在 in vivo 跟 in vitro 都可以得到一样的结果，就是C1-GAL-T1 knockdown 就会去抑制它的就是 pancreatic cancer 的 growth， 然后还有抑制它的 invasiveness， 包括说像是 metastasis。然后另外的话，我们就是去探究它背后的一些 mechanism， 然后可以看到这是一个 receptor tyrosine kinase 的一个array， 然后可以看到C1-GAL-T1 的 knockdown， 它可以去 suppress multiple receptor tyrosine kinase， 像是 EGFR2B2 或是这个 MET 跟 MSPR， 所以未来的话有可能就是可以跟这些的 receptor tyrosine kinase 的 inhibitor 可能就是做一些 synergistic effect， 或是做一些 combination。另外的话就是从这个是一个蛮有趣的实验，就是我们发现C1-GAL-T1 的 knockdown 它可以去改变就是 pancreatic cancer cell 的一个 spreading 的状况，就是它抑制之后呢，它的 cancer cell 的话就开始比较不会去 spreading， 比较不会去爬行，就是它的spreading 的状况就是大幅的减低。然后另外的话，因为看到这样的现象，我们就去探究它背后。然后这是 EMT 的 marker， 可以看到就是在 C1-GAL-T1 knockdown 之后，这个 E-cadherin 跟 N-cadherin 都有些微的下降。然后接下来的话就是看说 C1-GAL-T1 knockdown， 其实它也会抑制这个就是 multiple 的 ECM 跟 pancreatic cancer cell 之间的 invasion， 就是它会让就是这些cell ECM 之间的adhesion 也会下降。然后这些的话，这些就是 ECM associated 的FAC 的 activity， 就是 factor for phosphorylation 也会下降。好，另外的话 C1-GAL-T1 的 knockdown 的话，也会让就是这些multiple integrin 上面的 TN 也会上升，就是会改变它这些就是这些 integrin 之间的一个 alkylation， 然后主要是integrin alpha B、integrin alpha 5跟 integrin beta 1， 然后至于像是 alpha 2跟 alpha 3这两个 subunit 就没有看到这么明显的结果。然后另外的话就是说，这个 C1-GAL-T1 的 level 其实是跟这个 integrin 的 alpha V 跟 alpha 5之间的表现是有一个就是反相关的，就是一个 inverse 的 correlation。然后再来的话就是我们用一个就是 FAC inhibitor， 然后去看，因为刚刚讲说它其实会影响这个 FAC 的 phosphorylation， 那我们就是用 FAC inhibitor 去抑制它的这个 phosphorylation， 然后可以看到说其实就是也是会有一个像刚刚的那个 gemcitabine 的 sensitization 这样子的类似的 genome copy 的作用，所以我们就是假设它之前造成的就是C1-GAL-T1 调控这个 pancreatic cancer cell 的，不管是跟 integrin 之间的相关性，或是跟 cell invasiveness 或是 cell adhesion 之间的关系，应该是透过 integrin FAC 这样子的一个 signal pathway， 然后去造成后续的一个就是生理的变化。 不过在它就是这个 cell 就是在细胞的表面这些不管是 integrin beta 1、integrin alpha 5跟 alpha 5 beta 1或者是 alpha V， 其实在它的细胞表面的降低不是那么的明显。然后接下来的话，我们就是用integrin 的 blocking antibody 去治疗，然后可以看到说，就是在三株 cell 里面可以看到说，就是透过这样子的一个 functional blocking， 然后不管是 blocking alpha 5或是 blocking alpha V， 然后可以看到这个就是 C1-GLT1 的 mediated 的 cell invasion 都是会下降。然后另外的话，就是除了它的 cell invasion 会下降之外，它的就在 signal pathway 的话，它的 FAC 的 phosphorylation 也是有同样下降的状况。然后就是在 TN， 就是尤其是在 alpha V 上面的这个 glycosylation 的 modification 是特别的明显。所以我们就结论是结论的话就是说 ，integrin 的 alpha V 其实在这个 C1-GLT1 的 mediated 的 invasion 其实是扮演一个最重要的角色，就是比 alpha 5跟 beta 1更重要的一个角色。那接下来讲到 discussion 的话，其实在我们的这个 study 里面，80%以上的 pancreatic cancer tumor 其实都是表现比较高的 C1-GLT1 的 level， 然后这样子一个比较高的 C1-GLT1 的 level 其实是跟 poor prognosis 或 poor survival 有关，不管是 disease-free survival 或是 overall survival。然后另外的话，就是透过 C1-GLT1 的 knockdown 可以去 suppress tumor 的 growth 或是 tumor 的 invasiveness， 然后这样子的现象，不管是在 in vitro 或是 in vivo 都是有看到一样的表现。然后就是这些除了 tumor growth 跟 invasiveness 或是 metastasis 之外，它的 cell ECM 之间的 adhesion 也会下降，然后也会去抑制就是 ECM trigger 的phosphokinase， 就是 FAC 的 phosphorylation。然后另外的话，这个 ECM 的话是 multiple ECM， 包括说 collagen、laminin、fibronectin。然后另外的话，它的 downstream 的 signal 的话，就是为什么要去研究这个 FAC 的 phosphorylation？ 因为 FAC phosphorylation 是 integrin 它最重要的一个 downstream 的 signal。然后另外的话就是integrin beta 1 alpha V 跟 integrin alpha 5其实是会被 C1-GLT1 就是被它会被这样子的一个 enzyme 然后去调控跟去糖化。去调控糖化调控，然后在 pancreatic cancer 里面，然后其中扮演比较重要的角色，就是在这个 C1-GLT1 mediated 的 invasion 扮演比较重要的角色的话，是 integrin alpha V 跟 alpha 5这两个 subunit， 就是 alpha subunit 是扮演比较重要的角色。然后这两个 subunit 其实在过去是很少被提到的。然后另外的话就是C1-GLT1 的这个 mediated glycosylation，就是我们这个实验的话，结果就是可以了解到说，C1-GLT1 mediated glycosylation 在 pancreatic cancer 的 pathogenesis 或是 pathophysiology 里面扮演很重要的角色。然后包括说，我们去建立了这个 integrin alpha V 在 C1-GLT1 mediated 的 invasiveness 里面扮演的一个角色，跟未来可以突破的一个点。然后 glycosylation 在这个 integrin 上面的话，其实是透过像 GLT1 这样子的 enzyme 去做 modification， 然后进而去调控后续的，包括说 cell 跟 ECM 之间的 adhesion， 还有就是 integrin 跟 FAC 这个 signal pathway。然后这个 integrin alpha V 的话，会就是被 C1-GLT1 的 modification， 然后再就是透过这个 TN antigen 去做 decoration。然后我们用这个alpha V integrin alpha V 的 blocking antibody 就是 anti-integrin alpha V 的话，也可以同样的去抑制这个 C1-GLT1 mediated 的 PDAC 的 invasiveness 或是它的一个胰脏癌细胞的一个 invasion。然后再来就是我们去证实了，其实在integrin 的 alpha V 上面确实是带有这样子的一个 O-glycan， 就是带有一个这样的糖类，而且这样的糖类其实可以就是同样的去调控它之间的功能，跟它往下游传递。不过在 alpha V 是角色是比较建立，至于在 alpha 5的话，目前还是不是那么的清楚。这个卡通图的话是这个 study 的一个就是它的结论跟它就是去讲说C1-GLT1 到底怎么样去调控，造成后续的一个作用。就C1-GLT1 可以去 modify O-glycan， 就是在integrin 这是 integrin， 然后左边的话是 alpha subunit， 右边蓝色是 beta subunit， 它可以去modify 就是这个 integrin 上面的这个 glycan， 就是 glycan 就是上面的这个很像树枝的这个糖类，它去 modify 这个糖类的长度跟它的表现，然后去 trigger 它下游的这个 integrin 跟 FAC 之间的 signal pathway， 然后再去透过这样子的一个 pathway 的 trigger， 然后去让 tumor 可以得到 growth 跟 metastasis。然后在我们过去的study 也去证实说，还有可能透过其他的 pathway， 除了 integrin 之外，就是有可能像是 receptor tyrosine kinase 或是 mucin， 这些可能都还是就是希望给我听完它是有 multiple 的调控，包括调控 integrin、调控 tyrosine kinase 的 receptor 或是 mucin 这样子共同的调控，造成下游的这个 tumor 的 invasiveness 跟 metastasis。然后我们的结论的话，就是在希望给我提问的 knockdown 其实会让 pancreatic cancer cell 不管是 in vivo 还是 in vitro 都会抑制它的 growth 跟 metastasis。然后为什么跟之前那一篇希望给我提问 knockout 的那个结论是相反的呢？我们提出来的假设，第一个就是说，其实这个phenotypical 的 phenotyping 的这个 difference 在 knockout 跟 knockdown 其实就是你对基因的完全的 ablation 跟 partial ablation， 其实在很多的 gene 或是很多的animal 的 study 可以看到说，不管是 zebrafish、mouse 或是 human 的 cell line， 其实都可以看到说，你用 knockdown 跟 knockout 甚至可能都会得到相反的结果，在很多的基因都得到证实。然后第二个就是说，这样子的结果就是他们这个 knockout 结果有可能是一个 off target 的 effect。然后为了克服这样子 off target effects 的话，其实我们用了3个 independent 的 sRNA 跟2个 independent 的 shRNA 去避免这样子的一个 off target effect 的作用。然后再来是说，就是 knock out 一个这样的 gene， 一个很可能就是对生理很重要的 gene 的话，它可能会造成一些 genetic 的 compensation， 然后透过其他的 collateral pathway 可能会让整个 phenotype 就是相反。然后这些是我们就是解释为什么我们的结果会跟这个 study group 他们是发表在2019年的 Gastroenterology 为什么会有相反的结果的一个解释。然后再来是说，就对于这样子的一个 complete loss， 就是一个这样子的希望给我提完 knock out， 我们是用一个就是希望给我提完的 knock down， 然后是一个它去 mimicking low level of 希望给我提完，就是在我们的 group 里面 survival 比较好的那群，它不是 no 希望给我提完，它是一个 low level 的希望给我提完这样子的一个 model 去做。然后接下来的话就是在我们的病人就是我们的这个病人里面大概有超过 97% 其实都是有表现希望给我提完，然后比较低的这样子的 level 其实跟 survival 是比较好的。然后如果我们之后要拿来当成一个 therapeutic target 的话，我们应该就是去 decrease 它的 level， 就是 decrease 它的表现，对病人 survival 可能会有帮助。不过就是我们可能是要就是降低它的表现，而不是做一个 complete loss 或者 complete ablation， 不然可能会得到就是像刚刚讲的 knock out 的结果，或是像之前就是做 complete ablation of stroma cell 得到一个相反的结果。那我们结论的话，就是希望给我听完它可以 control 就是 O-glycan 的这个 elongation， 然后它的表现如果过高的话，在 pancreatic cancer 的不管是细胞或是病人身上可以看到它的 survival 比较差，然后整个 malignant behavior 也比较差。然后至于 integrin alpha V 的话，其实在这样子的一个希望给我听完的mediated invasiveness 扮演一个很重要的角色。然后未来的话，可能就是一个 potential 的 therapeutic target， 然后包括说我们可以提供就是对于这样子的 integrin alpha V 跟 alpha 5的之间的糖类的一个变化跟角色，提供一些就是更多新的一个观点。好，感谢就是实验室的大家，还有就是台大医院的那个研究计划跟科技部计划的帮忙，还有田老师的大力赞助。然后另外的话，还有就是中研院跟国院对我的研究有很多的帮助，跟我们的共研也是帮助很大。这样子，以上报告就到这边，不晓得大家有没有什么问题想要提出或是 comment？
很完整的 study 啊，我们已经 delay 1个半小时， 所以如果没有问题，田批恭喜啊，多了一个 scientist。那如果没有问题，我们就结束这个 section 啊。